Morning, Dr. Asim. Am I audible to
Morning,
you?
yeah. Yes, you are audible.
Yeah, so we are starting in just 1 or 2 minutes. I'm just waiting for the moderators to join and then we'll start. Join and then
Am I
yeah,
audible?
Mrinalini, good morning.
Good morning, sir.
Mrinalini, before you start, let me make some announcements and all, and then we'll take it forward.
Okay, sir.
So, 1 or 2 announcement from the organizing team. First of all, I'm welcoming today's on occasion of World Cancer Day. Today is the 4th February, and it is being earmarked for whole world that we are celebrating this World Cancer Day, and we are taking pledges and we are making strategies how to diagnose the case and how to reduce the burden across the globe, the cancer burden. So on that occasion, National Health Academy and MedSkill, along with the University of Britannia, they organize this event today, and this is the 4th day. We have already being 3 days already gone, and we have many speakers who have given their insights, thoughts, and they enlightened us with various aspects of management, diagnosis, and the social angle of this oral cancer and a general cancer per se. So there's 1 or 2 announcement today from here that Padma Shri Dr. Ravi Kannan, he is not in town actually. He is away from his place. So he tried to join, but the network is not optimum. So he said that I would be sending you the recorded message, though I'll try to join. So, Dr. Padma Shri Ravi Kannan may not be available today for his talk. And then we have one more announcement that Dr. Vishal Rao, his meeting scheduled with the health minister today in Delhi, but this meeting is being postponed, post lunch today. So due to this, his talk is around 2:45 to 3:10 p.m. So he might be available. So these are and then another one speaker, Dr. Sunil Saini, he's a postdoc on supportive care in health and head and neck oncology. So on his place, Dr. Abhishek would be joining from his organization on his behalf. He would be talking on the same topic, supportive care in head and neck oncology. So this is how we would be progressing for today. So we have the first speaker in our meeting room. Dr. Asim Mishra is already joined in. So without making any delay, we'll start our day's first session. Over to you, Dr. Milnani, for chairing the sessions.
Okay.
Thank you.
Thank you, sir. Good morning, distinguished attendees, esteemed speakers, and honored guests. As we gather on the final day of Ioccon 2024, that is the International Oral Cancer Congress, in the recent advances in the diagnosis and management of oral potential malignant disorders, we extend our heartfelt gratitude to each one of you for contributing to the success of this extraordinary event. We'll commence today's program with the very first talk by Dr. Asim Mishra. Dr. Asim Mishra has been trained in head and neck surgery at Tata Memorial Center, Mumbai, and currently working as a professor, head and neck surgery at Tata Memorial Center, Varanasi. With over 12 years of dedicated experience in the field of head and neck oncology, he has made significant contributions to the medical community. Dr. Mishra's extensive expertise is reflected in his impressive portfolio of over 60 publications in index journals, along with delivering more than 100 keynote lectures as a guest faculty both in India and abroad. Actively engaged in numerous randomized controlled trials in head and neck oncology, he also plays a crucial role in community based screening programs and national programs for cancer control. He is actively involved in training residents in head and neck surgery and devising methods to train otolaryngologists in oncology. His areas of interest span head and neck surgery, skull based oncology, cancer screening and control programs, and cancer awareness. Today, Sir will be sharing his valuable insights on margins in oral cancer. Over to you, Sir.
Thank you, Dr. Mrinalini. Is my screen visible?
Yes, sir.
So thank you and good morning, everyone. And thanks for joining with us. And I thank the organizers for giving me this opportunity to discuss on the role of margins in oral cancer. So we have often heard about why margins, what margins, margin is there, this is very important, why it is such an important issue, why is margins considered so important? And the reason that we talk about margins, especially in oral cancer, is because that is something which reduces the risk of local recurrences, it improves survival, and it is also involved in treatment decision making. Even after the surgery, when we have assessed the margin, we make decisions whether we are going to add chemoradiotherapy to that, or we are just going to give radiotherapy to the patient in the adjuvant setting. And this is the reason why it is important, is because that is the only prognostic factor that is under the control of a surgeon. Every other thing like a perineural invasion or a worse pattern of invasion or the lymph node positivity, these are controlled by the biology of the disease. But margin is something that when the surgeon is excising a tumor, he has to place his knife or a cautery at least at a distance so that he is getting a tumor-free margin. And why is the margin important? It affects survival, but how much survival is affected by that? It is almost 8% difference in survival. So when a patient is having a involved margin versus a patient having a free margin, so it's almost 60% versus 52%. And we talk about the local control, that we talk about whether the disease is going to recur in the local area or not. It is almost doubled when the margin is involved. So the negative margin is a very important thing in oral cancer management. We also have a 5-year survival assessment by the Sloan Kettering group, and they have evaluated that there is a worse survival when there is less than 5 millimeter margins, from 66%. So it drops down from 90% to 66%. So that is a very significant reduction in survival. So let us come to what actually is a margin. So margin is, so the yellowish, the creamish area that we see in the center is the tumor cells or the cancer, and the resection area all around the boundary with the normal tissue, that is called a margin. Now in this we call a negative margin because the tumor is surrounded by a healthy tissue all around the tumor. Suppose this tumor was extending to one of the edges of the normal tissue. Now this, whenever the pathologist is going to assess, is going to become an involved margin. So that is how we assess. And whenever a surgeon is operating, the aim is that he gets a normal cuff of tissue around it, so that the cancer cell is surrounded by normal tissue, so that there is a tumor-free margin. Now, how this margin is calculated and what are the factors that are associated with this margin? Because whenever a surgeon has removed it and the pathologist is evaluating it, in between there are a lot of things like the orientation. Whatever way a tongue tissue has been resected, or a buccal mucosa or a composite resection has been done, the orientation, the side, the superior margin, the inferior margin has to be labeled properly, so that whatever the surgeon is resecting, the pathologist is also reporting the same as it is. So that what happens is there is no loss of orientation. It should not happen that the surgeon is saying anterior and the pathologist is saying posterior or superior. This confusion needs to be avoided in the reports as well, especially in oncology. And therefore, proper orientation of the specimen is very important. You may take small stitches in the superior or a long stitch in the lateral part. You can label it in different ways. You can color code it, but you must always orient your specimen so that the pathologist exactly knows which margin and what is he processing in that section. Now, there are various factors that affect the margins. Most important first is the mucosal changes. So if there is a tumor tissue in the center and along the mucosa, there are a lot of leukoplakic or dysplastic mucosa that can affect, that mucosal changes can affect the margin status. If there is extensive field cancerization, same thing, extensive field cancerization towards the opposite side, towards the normal side, towards the lower alveolus, these things are going to affect your mucosal margins. Now, very important thing is tissue shrinkage. Whenever a tumor is resected, when it is in the body versus as soon as it comes out of the body. Immediately after resection, there is 20 to 30% reduction in the size of the tissue. This is because of the tissue shrinkage. And as the tissue shrinks, the margin also reduces. Therefore, it is very important that when the surgeon is excising, he has to take care that that extra tissue shrinkage has to be considered, and he has to place his knife at least 20% ahead. So when you need a 5 millimeter tumor-free margin, you have to place your knife at least at 8 or 9 millimeters so that you get a 5 millimeter tumor-free margin in the final histopathology report. How to do that, we will discuss once again in coming slides. Now, the next thing is the pattern of invasion. The pattern of invasion is how the tumor behaves at the tumor host interface. Just at the site of the tumor ends and the normal tissue starts, that is a tumor host interface. And in that area, what is the pattern of the tumor cells? There are various classifications. The Gensler classification system that is very common has 5 patterns of invasion. So there may be a satellite of cells, there may be small nest, or there may be a small tumor bud that may be extending from the edge. And all these things, whenever they're extending beyond the tumor edge, these are going to change the margin. There may be some mucosal disease, and there may be the tumor host interface itself may be carrying some tumor cells, and which may also affect the margins. So now, whenever we talk about margin, let's come first to the definition that what margin are we going to define? What are we going to say closed? What are we going to say involved? And what are we going to say free? Now, based on various groups, radiation therapy, RTOG group in US or the European Organization of Research, EORTC group, they have various classifications of less than 1 millimeter, more than 5 millimeters, 1 to 5 millimeters. But the standard that is practiced worldwide based on various NCCN guidelines or the UICC guidelines is less than 1 millimeter or 1 millimeter is involved, 1 to 5 millimeter is closed, and more than 5 millimeter is tumor free. So that is what is considered for all treatment decision making so far. And the latest NCCN guidelines that we follow are free margin is when the tumor is 5 millimeter or more from the resected tumor. From 2 to 5 millimeter, it is called closed, and 1 or less than 1 is considered as tumor free. Now, this is the standard of practice. But in Tata Hospital, we conducted a study to see till what margin are we going to have, or more margins, are they going to have better survival? Or is there any cutoff after which the margin increment is not going to help? So it is very important that we know what margin is going to give us the maximum survival. Because many a times people said that if you take more margins, if you take 2 centimeter margins, you may have a better survival as compared to when you are taking lesser margins. And for the same, the study that we conducted found that in a T3, T4 tumors, if you read and go through this study, you'll understand that we have divided into 2 groups. One is the early and one is the advanced. So in early T1 or T2 tumors, if the margin is 5.5 millimeters, and in advanced tumors, when it is 6.5 millimeters, the survival is best. Even after that, after 7 millimeter margin, whenever we try to increase the margin to 1 centimeter, 1.5 centimeter, 2 centimeter, they are not going to have any improvement in survival. So the maximum benefit of survival in the local control is at 7 millimeter margin. So a surgeon must at least aim to get a 7 millimeter tumor-free margin. Another study, it was done on the tongue cancer, and we found out the same results, that till 7 millimeter margin, that is the best survival. Beyond 7 millimeters, we do not have any increase in survival. A similar study had also been done in the Taiwan group, the Changgung Memorial Group, and they also find that the cutoff value of less than 7 millimeter gave the best statistical power for local control. Beyond that, you will not have any increase in the survival. Now, to get a tumor-free margin, a lot of surgeons say that we'll use frozen section. Frozen section helps us achieve free margins. But that is full of fallacy. So you have to understand, because when the frozen section is being routinely utilized, it is not cost effective and it is not going to impact the oncological outcome. Therefore, what we did was, we also did the same study on the frozen section and the cost benefit analysis, and we found that the cost benefit analysis for the frozen section was 12:1. So it is actually not benefiting. And why it is not benefiting? Because if you are resecting the tumor, you are getting a tumor-free margin, you are able to grossly assess that margin. And when you can grossly assess that margin, you can say that the histopathologically also the margin may be free. But how do we get over by doing just a gross examination and not do any histopathological or the frozen section assessment? So first thing, so we have to be surgically trained to resect the specimen, that you are placing our cautery or knife at least 1.2 centimeter from the tumor, considering the tumor shrinkage, the submucosal disease, the possibilities of having microscopic spread beyond gross disease. All these things are considered while you are operating in the mind of the surgeon. Then after resecting the specimen, the surgeon examines all the boundaries, all the margins precisely, and then measures that he is getting 7 millimeter margins in the gross as tumor free, and only then he will be very, very sure that this is tumor free margin. But how can you say that a surgeon is examining it is 100% foolproof? And the study that we did was the same. So we compared this gross examination by the surgeon in the operation theater and then compared the histopathological margins in the final histopathology report. And then we found that the things that we talk about, like the microscopic spread, the worst pattern of invasion, the tumor budding and everything, all these things account for less than 5.7% of all the patients. And this microscopic spread beyond the gross disease in 99% of the times is just up to the level of 2 millimeters from the tumor. And hence this number of 7 millimeter. So when we have taken a 7 millimeter gross margin, we have incorporated that 2 millimeters of microscopic spread as well. We have taken considerations of all the other factors as well. We have examined the specimen properly. So in 99% of the times, we are sure that yes, we are going to achieve a tumor-free margin. So when do we use a frozen section? It's not that the frozen section is not required. Frozen section is required. It is a good tool, but it is to be utilized judiciously. Suppose you are resecting a specimen and you are at the infratemporal fossa, you have some doubtful tissue, they are not sure whether this may be malignancy. In those cases, send it for frozen section to confirm. That is an indication. You know you are going to save a mandible in a case, you have resected till the mucoperiosteal stripping, and you do not want to resect that extra mandible now. You can preserve the mandible. You can send it for frozen section and confirm. Now, these are the indications. So we then studied the microscopic spread, and we found that this microscopic spread is just in 5.7 to 8.7% of the patients. And this microscopic spread of the tumor beyond the gross disease, this itself is associated with poor prognostic factors. So whenever the tumor is having microscopic spread beyond gross disease, they are having higher or poorer differentiations. they're also having higher incidence of nodal metastasis, perineural invasion, and the extracapsular invasion. So microscopic spread itself is a poor prognostic factors. So we further evaluated what microscopic spread is actually. So we found that these are the worst pattern of invasion that is there in the tumor. And so we classified this worst pattern of invasion into various grades, and we found out that from worst pattern of invasion type 1, 2, 3, and 4 and 5. So we divided them into these groups, and we found that when the patient is having worst pattern of invasion 4 and 5, they had a higher incidence of locoregional failure. So the locoregional failure was 66.5% versus in pattern of invasion type 1, 2, 3, where it is just 50%. So there is an improved survival when the pattern of invasion is 1, 2, 3 versus when it is 4 and 5. So we further evaluated what is there at the margin and what is there beyond the margin. So we found that beyond the margin, whenever we are extending beyond the margin, there are some tumor inflammatory cells. Now these lymphocytes, eosinophils, and other population of cells that are there that are also affecting the survival. So what we evaluated was that when there is improved or the increased lymphocyte response at the tumor microenvironment, those cells, those tumors, they perform very well. So this lymphocyte, they act as a wall around the tumor and it prevents spread of the tumor. This may be one of the possible explanations why we got a better disease-free survival in those patients. So this continuous pattern 1 lymphocyte response at the edge, that improves survival. So now we have analyzed what the margin is. We saw what are the factors that affect the margin. We know when the margin is involved, there is reduction in the survival, and it is almost half. So from 36%, the survival drops down to 18%, or the reduction increase in the incidence of the local recurrence. So that is there. So the margin is the most important factor. And this factor is very important because this can be controlled. A good surgery means that we are able to resect all the margins properly. The second point that we understood is that whenever we are doing a gross examination properly, we may not need to do a frozen section in all the cases. And to assess the margins properly, we have to have the proper orientation of the specimen done so that there is no confusion between the surgeon and the pathologist in calculation and assessment of the factors and the margins. And there are biology of the disease, and always the biology is the queen, because whenever there is microscopic spread or the worst pattern of invasion and any changes in the tumor microenvironment, these are the poor prognostic factors. And we must also pay attention to the tumor microenvironment because there are various drugs, various expressions of receptors, that PDL1 and other receptors that are being analyzed now, and these are targeted. So the tumor environment must be recorded. What are the changes there? That must be recorded in the future, and that is the future to targeted drugs and targeted therapies. Thank you. Are there any questions?
Any questions from audience? Attendees want to ask question, they can unmute your microphone and they can open the camera and they can ask the question. The margins of the tumor is a very important aspect actually. So if anywhere have any doubt, they can ask question right away with Dr. Asim. There is no any question, Dr. Asim, but I request you to stay with us maybe for at least one session. So if there might be any questions, no, we can club with the next speaker and we'll get back to you for the answer of the query.
Thank you.
With your permission, should we move to the next speaker?
Yes, please.
Very nice, and very better you have summed up the topic which you have delivered now. And we are very grateful that you have spared your precious time and joining us. I thank you on behalf of our whole organizing committee. So with your permission, I'm moving to our next speaker. We have Dr. Priti Jain. Due to some reasons, her talk was due yesterday, but there might be some emergency surgery, so she couldn't join yesterday. She was in OT room while her time was scheduled. So we are fortunate that she is available. And I have already announced that Dr. Ravi Kannan is not available. So you would be getting his presentation in a recorded format, and I'll email you all the subscribers and all registrants who have registered with us will share their PowerPoint presentation or PPT or PDF format. So we are fortunate that Dr. Priti joined and she is available now. Dr. Priti Jain, she is a director oncology services at Saptarishi Hospital and Cancer Center, Jabalpur, and ex-HOD surgical oncology at Mahavir Cancer Sansthan, Patna. Director of Fellowship Program on AOMCI Oral Oncology Fellowship at Saptarishi Hospital, Jabalpur. He is ex-director of Fellowship in Head and Neck Oncology and Gynecological Oncology at Mahavir Cancer Sansthan, Patna. Formerly worked at Manipal Cancer Center, Bangalore, Tata Memorial Hospital, Mumbai, NK, MSK, CC, New York. Receiver of Healthcare Excellence Award in outstanding contribution in the field of oncology in Bihar in 2015. Authored about 50 publications in national and international journals. Organized national conference at CMEs at Patna and Jabalpur. Her area of interest are head and neck oncology, breast and gynae oncology. So over to you, Dr. Priti. I have made you a co-host, so you can share your slide.
Thank you so much, Dr. Nurul. At the outset, I would like to thank you and all the organizing team for giving me this excellent opportunity to interact with a wonderful audience. And I really sincerely apologize for not being able to be present yesterday. Today, can I share my screen now?
Yeah, you can share your post, so you can share your slide. Yeah, it's coming. Yeah, it's visible now.
Visible? Okay.
It's a make. Yeah.
Yeah. So my topic given to me is the decision making and management guidelines in oral cancer. However, this topic is so huge that it covers almost everything about oral cancer. But I would like to summarize and be as short as possible here. Well, from our childhood, we have heard that you learn from your mistakes. But if the same thing starts happening in our surgical careers, we'll be in a mess. Because if I wait till I commit a mistake and then correct it, I'll probably lose many patients. So it's important that we have something which makes us understand as to how to take decisions in surgery, how to take decisions in oncology, and in especially in surgical field. Every second, every minute, you are forced to take so many decisions. When we are operating, when we are seeing a patient, there are so many things that run in our mind. Okay, what kind of imaging I should get done, what kind of biopsy I should do, what kind of surgery I should do. Okay, should I take this approach, should I take that approach, what should be my priority of handling the tissues. There are thousands of decisions that we keep on taking. We don't even realize how much our brain works, and this is where our evidence helps us, because there are certain things which are so objectively made in oncology that you don't have to think much about it. If you have this combination, go for this particular approach or go for this particular treatment. Or if you have tumor characters like this, your patient goes for adjuvant therapy, your patient doesn't go for adjuvant therapy, so on and so forth. So thanks to the evidence that made our job easy. So in short, surgery is the final execution of a series of decisions that you take, but your work starts much before OT. It's not that you get your patient on OT table and then you start deciding as to, oh, now what should I do. Your work actually starts right from the time your patient enters into your OPD, starts from where you start suspecting, you start diagnosing, then you stage your patient, then you optimize your patient, you check whether the patient is nutritionally all right or not, whether he can withstand surgery, what is the fitness status of that patient. Because sending the patient home is not our ultimate goal. Our ultimate goal is that our patient should live and the patient should live well. So, knowledge about multimodality treatment, where to give other adjuvant therapies, where not to give, is extremely important. So, as far as decision making about oral cancer goes, it is largely governed by tumor factors, patient factors, and then, of course, last but not the least, the infrastructure or the physician factors. Tumor factors always guide supreme in all oncology cases in oral cancer. And what are those tumor factors? Location of the tumor. What is the site of the tumor? In an oropharyngeal cancer, probably you would not think upfront surgery as the treatment of choice. So location of tumor is important. What is the extent of the tumor? What is the T stage of the tumor? Is it very close to the bone? Is my tumor away from the bone? Do I have enough margin so that I don't have to resect the bone? Or do I have to take part of the bone? Or do I have to take the entire bone with me? All this is decided by proximity to the bone. Then, has my patient received previous treatment? If the patient is post-RT, then your approach may be slightly different. You will never do for example, you will never do a marginal mandibulectomy in a patient who's heavily irradiated earlier, and so on and so forth. Then comes the tumor biology. See, nowadays, there are a lot of cancers, wherein the staging system itself follows the tumor biology. Like, for example, we have stomach cancers, we have GE junction, esophageal cancers. The staging itself for a squamous carcinoma and for an adenocarcinoma are different. Similarly, you see in sarcomas, you have grading incorporated into the staging system itself. So there are so many things. In breast cancers, you have a different systems for triple negative. You have different system for ERPR positive. So meaning thereby that tumor biology is for a T1 lesion of a bad biological behavior versus a T1 lesion of good biological behavior, their behavior will be different. Their chronology will be different, their outcomes will be different. So it's important to understand the tumor biology. Then the presence of or absence of other pre-malignant lesions or conditions in the oral cavity. This again makes a very important criteria to decide as to what you want to do with your patient. I would not like to treat any patient with upfront radiotherapy in a case where there is extensive submucous fibrosis, which means that the patient might land up in getting another second, third, fourth primaries. So if you exhaust the modality of radiotherapy in treating the first cancer, which can equally well be treated by surgery, then don't subject that patient for radiotherapy upfront, because you're losing one very, very precious modality which can be used later in case the patient develops a cancer of the oropharynx or esophagus or cervical esophagus, etc. So here are some glimpses of cases wherein you would jump on the decision that yes, these are the early cases and they should be subjected to surgery. And you are right in saying that this is a small lesion of the labial mucosa, a small lesion of the tongue. And then there are some lesions that will tell you that please do not touch me. If you touch me, then there is your patient and you both will land up into problems. See this, how ghastly this looks. So it's very easy to look at such kind of lesions and say that yes, this is inoperable. But there is a group of patients which are called as borderline resectable, technically resectable, but they have a very high failure rate if you operate. So these patients need to be looked into, and the philosophy behind and the science behind treating such patients must be clearly understood before you take up such patients for any kind of treatment. So as far as extent of tumor is concerned, how do we ascertain T stage? We do a good clinical examination with a good illumination, with good light, with good open the mouth nicely, use your gloved fingers, spend some time in palpation, examining the entire oral cavity with inspection and palpation. And then, of course, imaging acts as an adjunct. OPG, we do not do this very regularly now, and we don't ever depend on this modality as a modality to image the bones or cancers of the head and neck, because we all know that by the time OPG starts showing you bone resorption, it is already pretty late in the course of disease, and the early changes of bone resorption cannot be seen. So, what are the imaging recommendations? The basic fundamental imaging modality of choice is CT scan for all head and neck cancers. MRI should be your first imaging in tongue cancer, however, because tongue is better visualized. The lesions of the tongue are better visualized on a MRI as compared to the CT scan. Then contrast enhanced MRI can generally works as a problem solving modality in subtle lesions, in seeing intracranial extensions, in deciding on whether the patient has perineural invasion or not. So for bone imaging, CT scans are the best. You can see little minimal cortical erosion here, which cannot be, diagnosed on any other modality other than a good CT scan. With good 3D reconstructed films, you will see the exact extent of how much erosion is there, how much bone is involved, and how much do we want to resect. This is a picture of MRI of the tongue. You can see the tongue lesion nicely, which is coming till the midline. On clinical examination, the lesion was looking very small, but on MRI evaluation, you can see exactly what is the extent of your disease, and you can plan. Now, a word about PET-CT in oral cancer. There have been a lot of studies wherein people have documented what is the role. It is not generally required for loco-regional extent of disease, because we know that there are very less chances of having distant metastasis in oral cancer. However, advanced cancers of the tongue, where you can have lung metastasis, you must do a PET-CT. In cases where you have N3 node, where you have a very large node, where you have extranodal extension, then you have multiple nodes which are specially located in the lower part of the neck. They are also likely to have lung metastasis. And then, of course, whenever you are dealing with residual or recurrent disease, after the primary treatment is over, a PET-CT is required. However, for our routine cases of T1, T2, T3, T4 oral cancers, lateral buccal mucosa cancer, RMT, you don't need to get a PET scan. You must be very clear about that. Imaging of the neck is generally done along with the imaging of the oral cavity. So there is nothing more specific about it. Coming to operability. Well, as far as the old definition of TNM classification goes, it was clearly divided into T4. T4 is advanced disease. But now T4 is divided into T4A and T4B. T4A is moderately advanced disease, wherein you have involvement of the cortical bone, involvement of the maxilla, skin of the face. However, and T4B was called as when the tumor invades the masticator space, pterygoid plate, skull base, or encases the. But now, with lot of studies coming up about these T4B lesions, a lot of T4B lesions are now slowly getting included into the operability criteria. Earlier, T4A was operable T4, T4B was inoperable T4. But now we have a sub-classification even in T4B lesions, and some of the studies have been have told that some of these involvement of masticator space is also resectable. So what is clearly unresectable here is supranotch infratemporal fossa involvement, skull base involvement, pterygoid plates, and pterygomaxillary fossa involvement or encasement of the internal carotid or the common carotid artery, fixation of prevertebral fascia, and skin edema if or beyond the zygoma. And then, of course, a tongue primary with involvement of soft tissue till the hyoid, anterior tongue primary involving the vallicula, means it is so extensively involving the tongue that the lesion has gone till the vallicula. So this is the group of patients which is clearly considered to be unresectable. Well, this is a large meta-analysis of the surgical outcomes of patients with T4A and infranotch T4B lesions with the masticator space involvement has not gone above the notch. And it has been found that the outcome of these infranotch T4B lesions is equivalent to T4A. So that is why we started including some of the masticator space involvements in the operable group, as against how it was earlier, that little involvement of pterygoids, and we would call it as inoperable. What happened? So if you see the pool 2-year and 5-year overall survival data, they have very, very comparable survival. And now the clear inoperability criteria here are supranotch involvement of the skull base, intracranial extension. These are clearly inoperable cases. However, minimal involvement of, like for example, involvement of the medial pterygoid lower part and infranotch are considered to be operable. Now, this is an example of a 38-year-old man who was a tobacco chewer, had a recent onset trismus. He had an extensive involvement of the infratemporal fossa, a kind of supranotch involvement, but he was downstaged with chemotherapy and was operated and had an excellent survival. He's still alive at the end of 2 years and he's disease free. So we must give a good chance of surgery for these patients, but then again you have to be choosy in selecting your patients for these advanced disease for surgery. And coming to the extent of resection, it is extremely important to evaluate your soft tissue involvement, because the extent of resection is decided by soft tissue involvement. Mucosal and bone margins are very easy, but the battle of buccal mucosa cancers is lost not in the mucosa, not in the bone, but in the soft tissues. And this is what sometimes what you get. This lady was an advanced buccal cancer with involvement of the skin, nicely downstaged with chemotherapy, but she had florid post surgery. She had florid appearance of these kind of cutaneous nodules, and unfortunately she succumbed within a month to this kind of a recurrence. These are a few more examples of soft tissue involvement, just to give you an idea of how soft tissue involvement looks like, and how these inoperable cases they appear on clinical examination and on CT scan. This guy had fullness till the zygoma. On CT scan, had a really advanced disease with involvement of the supranotch ITF. Another gentleman who had an RMT lesion with severe trismus. However, there was no other sign of disease on his face, but his CT scan revealed extensive involvement of the infratemporal fossa. Again, this is a very advanced case, and these kind of cases, these kind of skin nodules, patients with skin nodules, they come back with skin nodules, recurrent skin nodules very fast after surgery. So these are not good candidates for surgery. So coming to patient factors, it is important to evaluate the patient factors in terms of what is the age of the patient, what is his performance score, what are the comorbidities, what is the occupation of the patient, and then of course sometimes patient preference also works here, because some patients do not want to opt for certain kinds of reconstructive modalities, etc., etc. So sorry. So it is important to take these things into consideration for doing this kind of a massive resection and a massive reconstruction free flap in a young gentleman is all right, but this kind of a surgical procedure you can't perform for a patient who is having who is old age, who has a lot of comorbidities. So and this guy, after that extensive resection and reconstruction, is still alive at the end of 18 months, 19 months after the surgery and radiotherapy got completed, and still doing very well. So coming to physician factors include the competence and confidence of the operating surgeon, whether you have human resources or not, whether you have technical support or not, whether you have the infrastructures which is required to do certain kind of procedures or not. And one must clearly understand their limitations as to what their infrastructure can hold and not hold. Coming to surgical approaches, you have a per oral approach whenever you have an excellent mouth opening, a relatively anteriorly placed lesion, and a small lesion. You can do away with excision being done per oral. However, for little larger lesions, you have to raise lower cheek flap. Visor flap approach is good for midline lesions. Upper cheek flap, of course, would be required for upper jaw tumors, for the CA maxilla, and mandibulotomy is reserved for cases wherein you have posteriorly located tumors. This is an example of a small buccal lesion in an elderly male, which can be easily done through paroral approach. Mouth opening should be good. This was a small tongue lesion resected per orally with excellent mouth opening, easily margins achievable here. So that's how surgical margins. I would not go into detail as Dr. Asim has very nicely covered everything about mm, margins. However, I would like to again emphasize that taking adequate margins on table is very, very important. The surgeon should first get satisfied that yes, I have taken good margins, so that on histopathology I will get at least a 5 millimeter margin. Aim for about a centimeter of clear margins on table, so that after the shrinkage happens, you get clear good margins. Margin shrinkage also, Dr. Asim has addressed. Intraoperative margin evaluation, frozen section it has not proven to be of great value, so most of us do not perform it. However, when you are in doubt, you can send those areas, particular areas, for a frozen. A word about revised surgical margins. There are papers which are coming up that say that on table, if you receive a report of a positive margin on frozen section and you revise them, the survival is inferior to the cases wherein you get the clear margin in the first go. So you must be very careful while resecting good margins. Now the second approach is the cheek flap approach, which is done most commonly in our patients for a little bigger primary, for almost all the cases, wherein we first perform the neck dissection, then go ahead and open up the cheek flap. And to achieve good margins here, it's important that you get a good exposure, and this is how you you use that approach. Mandibulotomy, as I've already mentioned, is good for posterior oral cavity lesions, and reconstruction becomes easy with flap inset. Sometimes becomes easy with a mandibulotomy. Visor flap is reserved for anterior lesions of the oral cavity, like in this GL sulcus lesion. We've done a marginal mandibulectomy with a visor. Just a tip about intraoperative evaluation of margins. Buccinator is a very good guide. If you see that your tumor is sitting here and is not involving the buccinator is technically totally free, you remove the buccinator as the margin, and that generally gives you good enough margin, because the thickness of the cheek is very less. You cannot aim at achieving a 1.5 centimeters margin in the depth of the cheek. And if you find that your buccinator is being involved, it is better to go ahead and remove the overlying skin and do a through and through resection rather than doing a partial resection. So sometimes to achieve margins, basically all cancer operations are wide excisions. You have to achieve negative margin on all the tissues. And sometimes this resection takes you to places like infratemporal fossa. This is the skull base, which is clearly visible here. We have done a bite excision, maxillectomy along with a mandibulectomy, and excision of the entire masticatory apparatus from the infratemporal fossa, and that's how your surgical site looks like. With more and more masticator space involvements being taken up into operable group, one must know how to how to do a good ITF clearance. So here are some of the basic fundamental steps. Raise the cheek flap, cut the masseter at the zygoma, expose the temporalis, pull the mandible down, cut the temporalis with a lot of margin as much as you can. Clear the posterior border of the ascending ramus of mandible. Take the maxillary artery, clip it so that your bleeding in the infratemporal fossa is less. Cut the mandible, pull it down, see the medial pterygoid muscle coming up. Cut the medial pterygoid at the level of your pterygoid plate. Expose the lateral pterygoid muscle. Cut the lateral pterygoid muscle from its origin at the pterygoid plate, and just follow the the skull base, and you will get this kind of a clearance. Your specimen looks much more chunkier as compared to when you do the hug the bone or follow the bone technique, in cases wherein you don't want to do a extensive soft tissue clearance. Now, a word about how you manage mandible in oral cancer. Well, earlier it was considered that all the oral cancers, they spread through the mandible, which has been proven untrue. And we know that there is nothing, the lymphatics have nothing to do with the mandible, and they don't traverse through the mandible. So you don't have to do an in continuity resection always. Because the dentate mandible has lot of defense against invasion of disease. However, edentulous mandible has reduced height, has pores in the cortical bone, and has less defense against invasion. And an irradiated mandible loses all its defense and is very prone to get directly involved. So that's how came the concept of marginal mandibulectomy, wherein if you do not have enough margin, if you're not getting 1 centimeter margin beyond the tumor, you can take a margin of the bone. Like for example, in this case, wherein this tumor is not leaving a more than a centimeter margin, so we have taken marginal mandibulectomy with us. Another example of marginal mandibulectomy. This labial mucosa lesion is not enough away from the bone, so we have taken a marginal mandibulectomy here also. So, however, it is contraindicated in mandibles that are grossly involved when there is extensive paramandibular disease. Irradiated mandibles, edentulous mandible should not be subjected to marginal mandibulectomy, because an edentulous mandible, you won't be able to leave more than a centimeter of about a centimeter of mandibular height. So you can either remove a segment of the mandible, hemimandible, extended hemimandible. Coming to the treatment of the neck, well, the question of whether to address the neck or not has been put to rest by this very, very important article by Dr. De Cruz sir, wherein he clearly demonstrated the survival advantage of doing an elective neck dissection in N0 oral cancer. So discussion about neck dissection is relevant only in very small oral primaries, which are removable through the open mouth, because if anyways you have to raise a cheek flap, might as well perform a good selective neck dissection. It doesn't increase the morbidity in good surgical hands. We all know that what are the levels to be dissected. Generally, we address level 1 to 4 for most oral primaries. However, you have to do a comprehensive 5-level neck dissection for all the node positive cases. We remove the sternocleidomastoid in involved necks, plus we also remove the sternocleidomastoid for the ease of inset of our PMMC flap sometimes. This is the functional neck dissection wherein we have done all 5 levels, but we have saved the sternocleidomastoid. A word about nodal yield. Well, there has been a lot of variation which is seen in the yield of node that comes out of the neck dissection specimens. However, a good supraomoid neck dissection or a selective neck dissection level 1 to 3 should have at least 6 lymph nodes, and a good comprehensive neck dissection, 18 lymph nodes or more are more desirable. Well, sentinel lymph node biopsy has been considered as a part of management of oral cancers, but in our scenarios wherein we have extensive disease wherein you have to anyways enter the neck, the sentinel node biopsy becomes a little less relevant. However, it is an accepted modality, and is considered to be equivalent to doing a selective neck dissection in cases where the primary is small and you're not entering the neck for approaching the primary. A word of caution for contralateral necks: do not forget to address the contralateral neck in cases where you have a primary which is reaching the midline or crossing the midline, where your ipsilateral neck is loaded with multiple nodes, and you have, especially in tongue primaries and FOM primaries, uh, in primaries that are poorly differentiated histology, it is important that you address the contralateral neck. Coming to reconstruction, the purpose of doing reconstruction is to establish mastication, swallowing, articulation, and speech, prevention of deviation, and last but not the least, the cosmesis. Ideal reconstruction in oral cancer is something which you replace volume by volume. You've lost this much of tongue, you replace this with a radial forearm, which is almost equivalent in volume. Tissue by tissue, you lose bone, you replace with free fibula. Restores function. Restoration of function is the most important goal of doing any kind of reconstruction in head and neck. For example, in this patient where we did a segmental resection of mandible and we did a free fibula, so you can see the kind of occlusion this guy has, and he's able to chew rotis and his normal diet normally, and that is what we want to obtain. This guy had a buccal cancer. We did a marginal mandibulectomy, wide excision, reconstructed with a radial forearm free flap to restore function. Now, pectoralis major myocutaneous flap remains our workhorse, whether it is a single paddle, whether it is a bipaddle, or it is a spiral PMMC, but PMMC still works like our workhorse. Even in some of the very bad and very extensive resections, we have used pectoralis major myocutaneous flap, and with very, very good results. Infrahyoid flap is the flap which we use for lateral tongue reconstructions. In some cases, it can actually replace reconstruction by a free radial forearm. However, you must be very careful while dissecting the neck in these cases, because you need to have their blood supply intact. Posterior oral cancer, especially the upper part of the oral cavity, a temporalis fascia works wonderfully. It can be easily harvested. However, it requires a separate incision, but it nicely, beautifully mucosalizes in the posterior oral cavity. Then, of course, we have microvascular free tissue transfer, which we do for almost 60% of our patients. Tongue resections, you need very little bulk in the mouth. Radial forearm free flap is wonderful for their reconstructions. Central arch mandibular resections, segmental resection of the mandible done here. You reconstruct with a nice free fibula flap, and this is how the kind of result that you get. Well, cancer surgery, especially for oral cancer, is not free from complications. So one must learn what are the basic principles of treating these complications, and the best way is to diagnose and accept it as early as possible in the course of disease, whether it is your flap failure, whether it is a OC fistula, whether it is bleeding or anything. You must act fast. And especially in cases of OC fistulas, local cleaning and local care is more important than giving systemic antibiotics. Please do not keep on giving antibiotics for patients who have pus discharge from their wounds in oral cancer, because most of it can be looked after by just doing a good local care, giving them good nutrition, correcting their systemic ailments. They become all right. Well, I think I am already running out of time, so I may not touch on these topics of neoadjuvant chemotherapy. There is a lot to be discussed about the indications, contraindications of chemotherapy, when to give, when not to give, what should be the margins post chemotherapy, how the patients should be selected. But it's a topic which takes which will take a lot of time. However, I will just enumerate the indications of doing adjuvant radiation. All your T3, T4 lesions go for adjuvant RT, node positive patients. N2, N3, extranodal extension. Patients with extranodal extension, they go for concurrent CTRT rather than just RT. nodes at level 4 or 5, margin positive patients, closed margins, perineural invasion, lymphovascular invasion, they are all high risk for failures and they should be subjected for RT. Then, of course, comes treating recurrences, managing your failures. It is extremely, extremely difficult, especially in the beginning, to accept that you have your patient as a recurrence. But remember that it's a part and parcel of oncology that you keep getting recurrences and metastases, and you see a lot of patient suffering as well as mortality in these cases. So, whenever you see a patient with suspected failure or a recurrence, you must evaluate the patient nicely, suspect it early enough, quickly accept that your patient has developed a recurrence, confirm with appropriate biopsies and imaging, assess the extent of damage, and then act accordingly. And if at all you need somebody's help, please seek help, because in difficult cases, it's always nice to have somebody who has more experience around. And so our goal is to basically identify patients at an early stage and treat them accordingly as per the guidelines, and not allow them to reach this state. So suspect, diagnose stage, either you treat yourself or refer, but do it well in time. And it's nice to have a team of workers together, of multiple minds working together can do better for your patients than you working alone. And of course, the keyword is keeping a balance between what you resect, what you reconstruct, a balance between the aggressiveness of your treatment and the ability of your patient to tolerate, the balance between your science and biology versus your patient's quality of life. So I once again I thank you, Dr. Anwar, for inviting me over, giving this opportunity to interact. I would be happy to answer if there are any questions. Thank you very much.
Thanks, Dr. Preeti, for your enlightening and valuable presentation. Yesterday, Dr. J.K. Singh, I think your mentor was joined, and his day one, actually on Thursday, he delivered his keynote lecture.
Yeah, I worked
yes,
with Dr. J.K. Singh
yes,
when
yes.
I was in Patna, and together we served Mahavir for almost
Mhm.
10 years.
Okay. Yes. Anybody from the attendees who want to ask any question, any query to Dr. Preeti? So, Dr. Preeti, there is no any question to be heard, and there is nothing in the chat box. If you stay with us, maybe if their question arises, we will come back to you.
Sure,
Meanwhile, with your permission, we are moving to our next speaker.
please.
Over to you, Dr. Milani.
Moving ahead with the next stop, we have Dr. Ruwan Duminda Jaising. Dr. Ruwan is a senior professor and chair in oral medicine and radiology, as well as a specialist in oral surgery at the Department of Oral Medicine and Periodontology, Faculty of Dental Sciences, University of Paradena. Additionally, he holds adjunct honorary professor positions at Teesside University, UK, University of Puthisastra, Cambodia, and serves as adjunct faculty in Savita Dental College and Sri Ramachandra Dental College and Hospital, Chennai, India. Graduating with a BDS from the University of Paradena in 2001, he earned an MS Oral Surgery from the Postgraduate Institute of Medicine, University of Colombo in 2005, becoming a board-certified specialist in oral surgery in 2007. He is a fellow of the Faculty of Dental Surgery, Royal College of Surgeons and Physicians of Glasgow, and a fellow in the National Academy of Science of Sri Lanka and Craniofacial Research Academy. He has contributed significantly to research with over 150 full paper publications in national and international journals, numerous presentations, and multiple awards. Serving as the current director of the Operational Technical Secretariat at the University of Paradena and the former director of the Center of Research in Oral Cancer, he has held various leadership roles within the academic and professional community, showcasing his dedication to dentistry and oral medicine. I request Sir to share his expertise on teledentistry for the prevention and diagnosis of oral cancer and oral potential malignant disorders. Over to you, Sir.
Can you hear me?
Yes, sir.
And my slides are visible.
Yes, sir.
Right. Thank you very much for those kind words of introduction. And thank you very much, Dr. Nurul, for inviting me to do the presentation, as well as for us to be the part of this International Cancer Congress for 2024. So far, the things are excellent, and we have a very good opportunity to learn various aspects of oral cancer and OPMD. And today, I will be touching something little different from the talks we had earlier. So the surgical aspects in the management is really important, and there's no two words about it. But at the same time, we are struggling with the prevention and diagnosis of oral potentially malignant disorders and oral cancer as well. Our conventional methods are not working properly, so therefore there is a need for us to find different new modalities. So the teledentistry is coming up as a new modality in various aspects, and I will be talking to you on these aspects for the next 20 to 25 minutes. As we know, the oral cancer is a major problem of this part of the world. Indian subcontinent, that is where the major problem is. And you and me, we all the time see patients with oral cancer and OPMDs and in various parts of the oral cavity. Oral cancer is different from the other cancers because it is easily identifiable and preventable cancer. Most of the oral cancers develop from the oral potentially malignant disorders. And if we can identify and treat these OPMDs appropriately, we can prevent the malignant transformation. But unfortunately, lack of awareness about the signs and symptoms of OPMD is responsible for the diagnostic delay. Not only the OPMDs, even the people, their knowledge and the awareness regarding the oral cancer is not up to the point. And it is not only among the patients, but also with the healthcare professionals. There can be different types of delays in the process. There can be identification delay where the patient is not identified that the patient is having a problem. And even when they identify, there can be a delay or when they comes into the clinic for us to see. So that is presentation delay. And from there onwards, there can be a delay from our side, the diagnostic delay or the management delay. And finally, all these contributes to the prognosis of oral cancer and OPMD. So if you look at the oral potentially malignant disorders and the oral cancer, the oral cancer survival is not good. And the survival rates has not improved over the last 4-5 decades. And overall, the 5-year survival rate is about 90% if we can diagnose them at the stage 1. Whereas when it is diagnosed at the stage 4, the prognosis 5-year survival rate drops to 20%. Unfortunately, most of our cancers, oral cancers, are diagnosed at the stage of stage 3 or 4. Overall prognosis is around 50%. And this overall prognosis is worse among all cancers, the major cancers that can happen in the human body. And this poor prognosis is due to the late detection, which is a problem, as I told you earlier. Most of the cancers are detected either at the stage 3 or stage 4. And there are no applicable markers for early detection. That is one reason why the cancers are detected late. And there is a possibility of second primaries as well as failure of advanced lesions to respond to the chemotherapy. Still, only the surgery and the radiotherapy act as the primary treatment modality. The chemotherapy is only playing a supporting role. This is what we see in our day-to-day life. The people who are coming with extremely late cancers are spread all over, not only the regional areas, sometimes it spreads into the neck as well as they comes with the distant metastases. The diagnosis of oral cancer comes with the histopathology, that is the gold standard. So far, we don't have any other alternative than going with the biopsy. The biopsy comes with its own problems. Being an invasive procedure, surgical procedure, it can induce some type of a fear. And that is one reason why the people are not coming into the clinic, or they are keep postponing it simply because of the fear that they are having towards the surgery. And if we can identify a better method, then the chance of we detect them early can be improved. And there are different methods which can be used to screen, but still they are not the diagnostic modality. The screening methods include the conventional oral examination and various commercially available diagnostic aids and adjunct techniques. All these, including the vital staining, the cytology, chemoluminescence, tissue fluorescing imaging, and salivary diagnostics, they still play a supportive role. So far, they are not playing a critical role in the diagnosis. Therefore, new early detection strategies are currently in need to reduce the mortality, morbidity, and economic burden associated with the oral cancer. So with this in mind, we have to understand and appreciate the blend of the healthcare system with the technology. And the technology is mixed with various other forms before the healthcare system. For example, the management, the commerce, it took the technology much earlier than we have e-commerce, e-science, e-government, and all these management and the financial related activities are very much blended, mixed with the technology. Now you cannot separate one from the other. Whereas the health, they're being recognizing the importance of importance of these technological advances. Now we are having them blended with the healthcare systems too. All these digital technologies can have effects on all the aspects of healthcare. It can be the healthcare system, healthcare delivery, health of the individual, health of the living being, as well as the overall impact on the society. The involvement of technologies in the healthcare, there is an evolution. We started it as e-health, then it evolved into the hem-health, and then into the telehealth. But today we are talking about the digital health, where we have the healthcare technologies, big data, and ICT combining together and providing, the healthcare system is much easier, as well as the efficacy of such systems getting much easier. The WHO came up with a global strategy on the digital health. After recognizing the importance of digital health in controlling, maintaining, and managing the healthcare systems, they come up with this strategy. So therefore, the WHO has taken a step to promote the healthy lives and well-being for everyone, everywhere, at all ages via this strategy. So they expect to deliver its potential national or regional digital health initiatives, and they advocate it must be guided by the robust strategy that integrates financial, organizational, human, and technological resources. Digital health is not something simple. It's a little complicated, and there's a multidisciplinary involvement. We healthcare professionals alone may not be able to go into the next level, and we need the support from multiple people, including the software developers, as well as hardware developers, and many other people in the industry. And it involves many stakeholders. There are providers, and mostly we as healthcare professionals, we are the providers, and the health system itself, the institutions, they may be the providers, and there are payers. Either individuals will pay, or if it is government involved, then finally the taxpayers has to pay for it. And then finally the patients. The patients are the people who are going to get the ultimate benefit, but at the end of the day, the patients can be the providers as well. They provide us the information regarding their problem, so therefore they can act as the provider as well. And when it comes to the digital health, there are three basic pillars: artificial intelligence, big data, and cloud. So the final outcome or the development of digital health will depend on the development of these three pillars. And if you look at the digital health, it has broad scopes, which includes the mobile health, that is in-health, which goes through the mobile phones that we are using. And then there is health information technology, wearable devices, telehealth, telemedicine, or the topic today, the teledentistry, and the personalized medicine. So you can see the wide spectrum of digital health. Telemedicine is the preferred term, And most of the time, when we talk about the telemedicine, basically the teledentistry is included under the telemedicine. Telemedicine is the combination of telecommunication with the healthcare systems to provide healthcare services. So the teledentistry is the same where we are using all these in the dental field. At times, we prefer the term telehealth because not only the medical specialties, some non-medical, non-clinical specialties like nursing can get used to these the systems. Teledentistry is defined as the transmission of real-time post-to and forward clinical information using electronic health records, digital imaging, photographic, information and communication technology, and internet to provide oral health care and dental services. And the teledentistry is used in all branches of dentistry, including oral medicine, oral pathology, and oral and maxillofacial surgery. And it can be used in any of the areas, whereas here I will be focusing only onto the oral cancer and oral potentially malignant disorders. Teledentistry is growing very fast. And it is growing because we have the developments in the broadband infrastructure, and we have increased human resources with expertise. And now even kids, they know how to use most of these devices, and they are basically having a lot of experience with those devices. And finally, the reduction of cost associated with the technology. Everything is getting less and less expensive, even though most of the things are getting costlier day by day. This IT-related stuff, because of the competition and because of the wider usage, the prices are coming down. Healthcare providers increasingly use the technology in all aspects of the management and delivery. If you look at the generation above us, they use very little technology. We are using much better than them. And the current generation, the new generation, they are using 10 times more technological aspects than us. So the teledentistry can be classified according to the time of information transmitted. It can be synchronous, asynchronous, or self-monitoring. There are multiple applications in the teledentistry. It can be used for the patient education, continuous professional development, networking, and knowledge sharing. These are very critical. The teledentistry can be used as a very important platform for the patient education regarding the oral cancer or PMD prevention. Nowadays, most people are into the social medias and various other such platforms. And irrespective of the age, people are very much into those. So therefore, we can use these the advantages for our benefit. Then the continuous professional development. So like what we are having today, having one-to-one physical meetings are getting more and more difficult, and it is getting more and more costlier. So all these teledentistry related applications can be used for the continuous professional development. Now we are telecasting this through the YouTube and various other apps. So it is basically part of the teledentistry. And it also can be used for the networking and knowledge sharing. It is one of the ideas of this conference too. Teledentistry can be used in the diagnosis as well. And most significant aspect is ability to minimize the healthcare disparities, improve the patient access to professional advice, shorten treatment duration, and reduce wasting time. One of the biggest problems that we are facing with, we have larger number of people with OPMD and oral cancer in the periphery, whereas our specialties, the specialists, are located in the central areas. And we who are working in the central areas, our number of patients are much less compared to the actual patients who are in the system. So therefore, the teledentistry will help us to communicate between the two, and especially the general dental practitioners who are working in the periphery. This can be the connecting platform between the dental surgeon working in the periphery and the specialist. There are different dedicated apps for teledentistry. But unfortunately, these dedicated apps are very costly and it takes longer time to develop. And therefore, the teledentist can be used in the equal effectiveness using the social media. And when it comes to the social media nowadays, everybody is very much familiar with the social media. Now here you can see the dedicated app, what we call as the Mimosa, which was developed by a Malaysian team. And then the simple use of social media platform. for the discussions regarding the patient-related activities. So this is a book chapter that we wrote very recently with some colleagues from India. So here we have discussed the social media, how we can use them effectively in telemedicine. Now, various teledentist-related applications are coming up, and they are basically sophisticated, but unfortunately, we have to consider how good they are clinically as well as how cost-effective they are. Lack of adequate number of such system is a limiting factor. And we cannot create such system in a day or two. Now, for example, this Mimosa program that I have discussed, I was involved in the project, and it is 5 years now. Still, it's evolving and developing, even though it is partly in use in Malaysia now. There are various common social media activities, and depending on our preference, depending on our availability, we are using all these different types of social media networks, and you will not believe the number of different social media platforms that we are having. A lot of people using social networking platforms like Facebook, Twitter, Google+. Again, it varies as a geographical variation. And then we have the professional networking groups like LinkedIn. Likewise, there are so many different types of social media which can be used for our purpose, prevention and the diagnosis of oral cancer effectively. Social media, we have to be a little careful when we are using it because some ethical and professional issues may come into the play when we are using the social media as a teledentistry platform. But on the other hand, the people has recognized the importance of the social media platform in teledentistry. So now most of the governments and the professional associations are recognized the value and they are basically relaxing the regulations, the rules and the laws applicable for that, allowing the healthcare professionals to use these things. And in addition to that, these governments and the professional associations are coming up with the guidelines. It is very important to have a balance between the proper usage and misusage. So therefore, the guidelines are coming up for the people, the healthcare professionals to use them effectively and with the proper care as well as some protection. One of the major issues that we are facing with when we are using the social media and teledentistry is the security of the patient-related data. Some of the personal information maybe we will be using that. So therefore, in the case of a cyber attack into our systems, whether this personalized patient data, can it get leaked and whether it can cause a problem is something that we have to think of. So again, some of the communication that I was having. So this is simply through the WhatsApp, and everybody is using this, even though it is not well organized. We all are using this WhatsApp and other social media platform of communication. Teledentistry can be used for the prevention of OPMD and oral cancer, and it's a very helpful device. But still, the healthcare professionals are a little hesitant. It has not taken the full, the acceptance by the healthcare practitioners, and it has not gone into the full potential. Very commonly, more than the patient communication, we are using this social media platform for the dissemination of knowledge and the patient education. This is a very critical factor which we can use for the prevention of oral cancer. So if we are using the social media platform very well, we will be able to pass the message effectively. As I told you earlier, there are multiple studies conducted all over, which shows the patient's awareness regarding the oral cancer, and especially regarding the OPMD and the risk factors associated with oral cancer and OPMD is very minimal. So therefore, we need something beyond the traditional methods of traditional print and the electronic media and our posters and the education lectures. We need something different. And nowadays, the people are gathering information through the social media than any of those accepted standard media. So therefore, the social media has to be used by us for the patient education effectively. At the same time, there are various aspects of the social media where we have to consider the bioethics very seriously. There is a consumer engagement, bias, profit maximization, and there is issues with the online content and related areas which we need to consider when we are coming up with the proper guidelines for the management of the social media related issues. There are dedicated telemedicine programs, and I know that the Indian group has developed one program, the Malaysian has developed one program, and there are other programs developed by the Western countries. So these things are there, but unfortunately, it needs a lot of time, a lot of money, and we need the resources for the development and the maintenance. So that is the issue with the proper standardized resources. And when you look at the patients, most of the patients are having a positive attitude towards the social media delivered telemedicine. That is something important. The people believes it more than the healthcare professionals. The people believes it, and most of these people who are, irrespective of their age and the area, they are very much familiar with some type of the other the social media platforms. Social media and teledentistry, as I mentioned many times, are very much interrelated. And there are multiple recommendations using the social media and the teledentistry when it comes to the oral cancer, not only the oral cancer, but also the other activities as well. So there has to be a proper standards, proper guidelines, as well as proper ethical use of these social media apps. The last few slides regarding the mHealth. So this is the use of mobile devices. mHealth is defined as medical and public health practice supported by the mobile devices, such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. And most of the time, we use mHealth and teledentistry together. They cannot separate from one from the other, because nowadays we all are having a mini computer, that is our mobile phone. When you combine the teledentistry and the mHealth together, they provide the excellent opportunities for us to deliver the requirement. But there are certain barriers associated with that, and we have to consider these barriers too. Especially when we are using the photographs to get the information from the patient, it is not like looking at the patient really. So when you are looking at the patients, we can use more than one sense. When you are looking at the photograph, it is only the vision. Whereas when you have the patient, the other sensations are also involved. Number two, our final diagnosis will depend on the quality of the images. These images, if they are poor and if they are not showing the lesions properly, we may go into a wrong or misdiagnosis. So in order to protect us with all these related issues, we have to have appropriate policy and legislation and more research in relation to the teledentistry, its advantages and the issues faced by not only the healthcare professionals, but also the users, those are the people. Teledentistry can be combined with the artificial intelligence. So this is the current trend, artificial intelligence, and I'm very sure that many of you are working on this area. So there are multiple studies conducted on the teledentistry and artificial intelligence. This is one group. We are combining the artificial intelligence with the software that I have discussed earlier, the Mimosa. And right now, it has gone into a very good level. And we have the sensitivity and the specificity around 90%, and we want to fine tune it further. So these are some of the publications that has come from these studies where we are trying to combine the teledentistry and the artificial intelligence together. So the basic idea, you take the photographs, and the photographs will tell you whether this is a referable case or whether it is a case which a general practitioner can keep and treat at the general dental practitioners level. This is the early idea. Later on, we will develop it with the larger number of cases. We will develop it to give the accurate diagnosis too. So these are some of the activities that we have conducted. You can see many studies are completed and some more are going with. The future perspective, teledentistry cannot be regarded as a substitute for traditional dental care. That is the most important lesson. It will only an additional to the conventional dentistry. Intersection of dental and telecommunications will establish, and we expect to progress on the constructive path for us to use this in a better way for the prevention and diagnosis of oral cancer in the future. Thank you.
Thank you, sir, for such an enlightening session. If the audience has any doubt, you can ask sir directly or put it in the chat box. We'll move ahead with the next talk of the day. We have Dr. Mohan Menon. Dr. Mohan Menon is a distinguished consultant medical oncologist at Sir H.N. Reliance Foundation Hospital. Boasting an impressive 22 years of experience, Dr. Menon has practiced as a medical oncologist both in USA and India. Prior to relocating to India, he served as a consultant physician at Harvard Hospital within the Connecticut School of Medicine for 17 years. Dr. Menon holds the esteemed position of visiting faculty at Gray Cancer Center, Harvard Hospital. His extensive academic background includes a fellowship in medical oncology from the Roswell Park Cancer Institute, Buffalo, New York, and a residency program in internal medicine at the University of Connecticut School of Medicine. Dr. Menon is American board certified in medical oncology, internal medicine, and palliative care, being one of the pioneering physicians in the United States to achieve certification in both medical oncology and palliative care. Notably, he also holds an MBA in healthcare from Alvernia University. Dr. Menon's diverse expertise encompasses cancer symptom control, head and neck cancer, lung cancer, breast and gynecological cancer. We are truly honored to have you here with us today, sir. So I'll hand over the platform to you to share your insights about the treatment of oral head and neck cancer. Over to you, sir.
Thank you. Am I audible?
Yes, sir.
Okay, thank you. Let me start my slides. All right, there we are. Thank you so much, Mrilali, for that kind introduction. And thank you, Dr. Anwar, as well as members of Ioccon, for the opportunity to give this talk. It's a good afternoon, and I do hope that this session will be informative to all of you. So the topic is current trends in treatment of oral and head and neck cancer. The reason for this title is because oral cancer forms part of a group of cancers which are sort of treated in a similar way. And most of the trials that have been done both as oral cancer as well as part of a group of head and neck cancers, especially in medical oncology. So the way I was thinking of giving the talk was we'll talk about the background a little bit about head and neck cancer, organ preservation. That means while in head and neck cancer, we talk about preserving the larynx and so on and so forth. Where do we stand as far as organ preservation, as far as the oral cancer is concerned? Adjuvant therapy, that is after surgery, what do you do? That means, do you give chemotherapy? Do you give radiation therapy? So on and so forth. We then move on to chemotherapy in an advanced setting. That is the conventional chemotherapy that we do when the disease is no longer curable. Targeted therapy, where there is a target that we can focus our treatment on. The most advanced, the most interesting part of it is the role of immunotherapy. That means harnessing the power of our own body's immune system to fight the cancer. And finally, conclusions. So it's a common cancer, which is big enough to be a public health concern, both in India as well as in several countries. It's because we have risk factors that if we focus our attention on them well enough, we should be able to make a dent in this disease, not immediately, but over a period of time. Unfortunately, our screening techniques, our screening protocols haven't been widespread enough. And so we see most patients in the later stages, unless we are fortunate to catch them early. And there is both an increase in absolute and relative numbers over time, as this slide from Glovocan makes clear. Now, as I said earlier, the thing about oral cancer is that it is a part of a heterogeneous group of cancers, which arise from the epithelial lining of the upper aerodigestive tract. So while I understand most of you are dentists, the way we look at it in medical oncology is that both from a trial perspective as well as a treatment perspective, there is a commonality in them. One is this fact that most of them are of a squamous cell etiology, squamous cell histology. They have similar etiologies, that is tobacco and alcohol and viruses. And the concept of trying multimodality therapy, that means surgery, radiation therapy, chemotherapy, immunotherapy, targeted therapy, and so on and so forth. Our treatments are fairly similar when we look at it across the spectrum. Now, when we look at head and neck cancers, including oral cancers, we can look at it from the perspective of what is causing it. It can be a virus such as HPV, as in oropharyngeal cancer, or EBV, where it is involving the nasopharynx. And while the anatomic sites may be different, the processes of treatment are reasonably similar, irrespective of the etiology. And non-viral, as you know, is tobacco-related, and of course, various other factors that can cause the same thing. Now, I'm sure all of you are familiar with the TNM staging with T1 to T4, as well as the end staging. So when we move on to how treatment has evolved in head and neck cancer over the last century or so, while surgery was introduced somewhere in the 1900s, that is radical surgery, the concept of en bloc surgery, radiation therapy sort of came of vogue somewhere in the 1920s to 30s. The initial cobalt-based radiation therapy was quite difficult to do. And similarly, as far as chemotherapy was concerned, while we attempted to treat people with methotrexate and 5-FU, really the introduction of cisplatin in the 1990s was the major factor in improving the response rates for treating this disease. Subsequently, of course, IMRT came of vogue. And then of late, we have a slew of improvements that had happened. Targeted therapy in the form of cetuximab, as well as immunotherapy in the form of pembrolizumab, nivolumab, and so on and so forth. So as you can see, towards the latter part of this period, that means from 1990 onwards, we've had a significant improvement in our ability, the tools that we've had to be able to treat this disease, as well as the effectiveness of what we were able to do. On the research side, we also found that tobacco and alcohol somewhere in the 1950s were found to be risk factors. The introduction of EGFR in head and neck cancer, as well as PD-1, PD-L1, as well as other viral markers, were also helpful in establishing the etiology of this disease. So we start off with organ preservation. Now, like I said, organ preservation, head and neck cancer specialists were the pioneers in looking at organ preservation. And why is that? And the reason for that is if you took patients with advanced larynx cancer, I'm digressing here a little bit. What we found was that if you took these patients and you did a laryngectomy on them, that means removed their voice box, wherein the patient is unable to speak anymore, and you followed up with radiation therapy, the 5-year overall survival was about 50%. That means half the people lived and half the people, of course, died. And then this was associated with morbidity as well as speech loss. And so for the duration of the lifespan of those individuals, that means the half that was going to die, it was considered as a pretty significant loss by the patients. Now, as I said earlier, the introduction of cisplatin changed our ability to treat head and neck cancer, and we had a high rate of complete tumor regression with chemotherapy. And there was this veteran study group. This is a good landmark study that showed that if you gave chemotherapy and you followed it up with radiation therapy,
सर बस
radiation
अल्लाह करम
therapy,
खैरियत से मैं बोला आपका सामने है 5 बजे के राउंड हमारा
I think there's a little bit of a disturbance there.
एंड होगा ये करीब 5:30 के आसपास 5 मैंने भेज दिया है कुछ नाम वगैरह आप उसको व्हाट्सएप पे ही देख के मोबाइल पे देख के कर लीजिएगा या लिख लीजिए
Dr. Nehru?
Hello. Yeah, there was some conversation going on. I just
Yeah,
wanted to wait.
just one second.
Shall I start?
Yes, sir. Sure, sir.
All right. So what we found was that when we in this veteran study group, when we treated people with chemotherapy followed by radiation therapy, you had approximately an equivalent survival in that group of patients. And if you use surgery as something of a reserve in case the disease progressed, you were able to preserve the larynx in about 64% of the people. So that means the concept of preserving the larynx in this group of patients who had bad disease was certainly considered to be beneficial to a lot of patients. And so that is the concept of organ preservation. So now, while it's established, it's very well established in larynx cancer where you can preserve speech. The question is, can you move it on to other organs? And we have, to a certain extent, with varying degrees of success, been able to do that. So here's a study by Susan Urba, and this is in the Journal of Clinical Oncology. And this is for hypopharynx or base of tongue cancers, where chemotherapy was given with cisplatin-based chemotherapy, and you had a great response. That means about 76% of the patients had a pretty significant response, and about 54% had a complete response. That means, if you did a scan at the end of the treatment, you basically didn't see evidence of disease. And so when you took that group of patients, there was definitely benefit in trying to preserve the hypopharynx and base of tongue in this group of patients. What about in oral cancer? Well, our data is not that great. And this is a study that came from Taiwan, where you took patients with oral cancer. You treated them with this combination of docetaxel cisplatin and oral Tegafur, which is basically an oral form of 5-FU. And what they did was, after the first cycle of treatment, if the patient had about a 30% reduction in size, the patient underwent cycle 2 of chemotherapy. Now, if they did not, they went ahead and did surgery. And so by doing this, they were able to get a pretty good response rate in this group of patients. And they were able to get pathologic CR, complete response, in about half the number of patients. The survival wasn't significantly different. And so while it's a nice piece of evidence, I suspect it's not something that is ready for prime time yet. But in groups of patients who are unable to undergo surgery because they decline surgery or unfit for surgery, this is an option. That is, you could give them chemotherapy, shrink the disease, and then probably consider radiation therapy thereafter. Now, if you can protect the tongue, that means if you can reduce the amount of tongue that you remove, perhaps you might be able to improve or keep more of the tongue function. So where do we stand today in terms of chemoradiation therapy? As I said, in larynx cancer, it is the standard of care. That means you can give radiation with cisplatin and follow up with surgery as a salvage if the disease remains or recurs. In oropharynx, it's certainly something that you can consider as based on the previous paper by Dr. Urba that I showed. Nasopharynx, which is a disease that's somewhat different and responds very well to chemoradiation therapy, we do that. There's a paper by Al-Saraf et al. That shows that this combination of radiation with cisplatin followed by cisplatin chemotherapy, it works well. Unresectable disease, of course, you don't have a choice. You give radiation and cisplatin. And we'll talk about adjuvant therapy. That means after surgery, after this. So adjuvant therapy, which is basically giving chemotherapy or radiation therapy after completion of surgery. Now, where do we do that? Well, not every patient who has surgery needs adjuvant chemotherapy or radiation. Now, let's say if you have, this is from the NCCN, National Comprehensive Cancer Network. I have borrowed their slide here. And if, let's say, you have an early stage disease, you do the surgery, and then you do not find any positive nodes, no adverse features, which I will define later, then that group of patients can be followed on an ongoing basis. Now, let's say you remove the nodes, and then you find that one or more nodes are positive in terms of pathology without any adverse features, you can consider radiation. Now, if you have adverse features, as you can see here, that means if there is extra nodal extension, that means the disease has spread outside the lymph nodes that has been resected. If there is a positive margin once you resect the disease, or other positive risk factors, that is a T3, T4 lesion, or N2, N3 disease, or perineural invasion, vascular invasion, lymphatic invasion, you can selectively consider giving them adjuvant chemotherapy in that setting. And this is generally done in combination with radiation. It is generally done either with cisplatin or carboplatin or cetuximab, as I will subsequently state. Later stages of disease, that is T3N0, T1 to T3, N1 to N3, T4 with N0 to N3, the threshold for treating this group of patients is somewhat higher. Again, if you have no adverse features, you can consider radiation. If there are adverse features, like I said earlier, and as I have defined the adverse features earlier, you could consider giving them adjuvant cisplatin or carboplatin in the appropriate patients, along with the radiation, which is given weekly. Now, what about disease that is not resectable? What about disease that is advanced? So we have much better abilities to treat this group of patients with the introduction of platinum. That means if you have recurrent disease that cannot be operated on, or if this is a patient who has had radiation therapy in the past, that is a group of patients that is generally considered incurable. That means you're not going to be able to resect the disease. And in that group of patients, we have a wide variety of drugs, as I have listed here. Cisplatin, carboplatin, docetaxel, paclitaxel, 5-FU, methotrexate, and several others are drugs that work, that have activity against this disease. And if you give them in combination, that means cisplatin with paclitaxel or docetaxel, and so on and so forth. The regimen that we like the most is TPF, that means docetaxel, cisplatin, 5-FU. That's our best regimen. That showed a pretty significant improvement in the response rate versus giving the chemotherapy as a single agent. Of course, there is more side effects when you give the combination treatment, but in a patient who is otherwise healthy or fit, you can certainly consider doing that. What side effects are we concerned about when we give chemotherapy? Well, the most common one that we worry about is a lowering of blood counts, specifically the white blood cell count, and that is called as neutropenic fever. That is a temperature more than 100.4 in a setting of low blood counts. That is a thing that we worry about a lot. And neutropenic fever is a medical emergency which needs to be treated under the guidance of a medical oncologist, which includes starting antibiotics quickly. Nausea and vomiting, yes, they are important, but we have very good drugs that treat them. And if you treat the patient with appropriate anti-emetic regimen prior to initiation of chemotherapy, you're able to keep that under good control. Hair loss is a reversible symptom, and it varies based on the regimen that you give. Fatigue is probably the most common side effect that patients talk about, and people have good days and bad days depending upon where they are in the course of treatment. Cisplatin causes hearing loss, neuropathy, and 5-FU causes mucositis and diarrhea. This is a local invention that is invented in India, especially at the people at Tata have popularized this. That is metronomic therapy, which is a daily treatment of two drugs, celecoxib and gefetinib. Celecoxib is a COX-2 inhibitor, and gefetinib is an EGFR inhibitor. These are both pills, and this is given with methotrexate, which is given on a weekly basis orally. And what was found was that you had very good responses even in patients who had been heavily pretreated. By the side, you can see this paper from Tata Memorial by Dr. Vijay Patil in September of 2020. It's a phase 3 study where they compared it with cisplatin given every 3 weeks. And the survival was actually better in the metronomic arm versus the standard chemotherapy arm. More importantly, side effects were less and the cost of treatment was less. Moving on to targeted therapy. Now, the head and neck cancer cell has several pathways, cellular pathways that we can target. The most common being the EGFR pathway, which is present in somewhere up to 80% of the cancer cells. And these are the drugs that work the most: cetuximab, which is a monoclonal antibody, and afatinib and erlotinib, as well as gefetinib, which are oral agents. And by blocking the EGFR pathway, we are able to achieve a temporary response, and sometimes more than temporary response in this group of patients. Other pathways that are coming of vogue, there is the MET pathway, and we have this oral agent called capmatinib, which is not yet available in India, but you can import it. And then, of course, there is the Notch pathway into which we are still investigating. So targeting this pathway can be used either as an alternative or in combination with chemotherapy in the following ways. So cetuximab, which is basically an EGFR antagonist, as I showed earlier, blocks the EGFR receptor. This is a picture of what the protein actually looks like. And it is used in two settings. It is used in combination with radiation when a patient cannot tolerate cisplatin or carboplatin. Namely, if a patient has bad kidney function, if the patient is too frail to receive cisplatin or carboplatin, you could potentially consider using this particular drug. And this is a study by Bonner et al. From the New England Journal of Medicine in February of 2006, where the combination of cetuximab with radiation, again, this is not only in oral cancer, this is all head and neck cancers, that improved the locoregional control as well as reduce the mortality without significant toxic effects associated with the use of cisplatin. Now, it must be borne in mind that cisplatin and carboplatin, if cisplatin cannot be used, remains the standard of care. Cetuximab is used only if you cannot use either of these two agents. So I do want to make that clear. What about in combination with chemotherapy? And here there's a trial called as the EXTREME trial by Vimorkin et al. In the New England Journal of Medicine. And as you can see on the left side, both from the perspective of overall survival and progression-free survival, there was an improvement. That is a median overall survival of 10.1 months with the combination of a platinum-based chemotherapy and cetuximab versus 7.4 months for the chemotherapy alone arm. And in progression-free survival too, there was an improvement of a few months. Now, again, remember, we are talking about median. So some people benefited a lot more. Some people did not benefit as much. The newest and most exciting thing in the whole thing is the role of immunotherapy. Now, let me tell you a little bit about this. So The process of generating an immune response against the cancer, one puzzle that we all wonder is, why is it that our immune system does not take on cancer, does not fight the cancer on itself? And we, of course, hear of stories where miracles happen and the cancer suddenly disappears. Most likely it's because the immune system has sort of been primed to act against the cancer. So, is it possible for us to get that done by some process? And what has to be understood is that it is just not enough that this is what's called as an antigen presenting cell. Most of the times these are macrophages, and this is something called as a MHC class 1 or class 2 protein, which is on the surface of the antigen presenting cell. Now that is presenting this peptide, it's usually 8 or 9 amino acid peptide to a T cell. And this is a CD8 cell. And there's something called as a T cell receptor, which is receiving this particular protein, that is peptide molecule. Now that's not enough. Just giving this molecule over, handing this appropriate molecule over is not enough. There are also what are called as co-stimulatory molecules. And you need these co-stimulatory signals in order to get this particular T cell, or what is called as an effector cell, to fight against the cancer, to sort of get primed against the cancer. And these co-stimulatory signals can either be inhibitory or excitatory. And we are talking here about inhibitory. So this PD-1, PD-L1 interaction, that means PD-1 from the T cell and PD-L1 from the antigen presenting cell, if these two proteins touch each other, it actually delivers an inhibitory signal to the T cell. Okay. So we have to prevent this from happening. That is, we want to prevent the CTLA4 from talking to the B71 or 72 protein on the antigen presenting cell. And similarly, we want this PD-L1 to stop talking to this PD-1 on the T cell, so that the body can proceed with getting this T cell primed against this particular protein. And so this is the priming phase. And then now let's say if you have been able to get this T cell primed, that means you've got it sensitized to this particular protein. What will happen is that, suppose this is a tumor cell and this is the T cell. What will happen is that T cell receptor that is here, it will pick out the fact that this particular protein is present on this particular cancer cell, and it will go and attack it. Now again, here also, if the PD-1 and the PD-L1 talk to each other, that is actually going to cause an inhibitory signal that will shut down this T cell, and it will go into anergy. So what we want to do is we want to block this particular interaction. We want to block this interaction between PD-1 and PD-L1, so that this process of priming the tumor cell is something that we want to get done. And the way we do that is by this particular protein or monoclonal antibody. That is, we have several of them in the market now. The most common ones that you may have heard of are nivolumab and pembrolizumab. Pembrolizumab is Keytruda that you can see here. So this PD-L1 is present on the antigen presenting cell, and you have this PD-1 receptor that is present on the T cell. What you're doing is you're blocking this particular protein so that this PD-L1 doesn't get to talk to this PD-1. And so you're blocking the development of an inhibitory signal, that is this co-stimulator, through these co-stimulatory molecules, so that the T cell receptor that is present here can receive this appropriate antigen to which it can respond. So I hope that is clear as to how this particular immune response is stimulated. And it happens both at the lymph node site as well as in the tumor site. So in the lymph node side, what you see is that there is activation of the T cells by the antigen presenting cell, which, as I said, is either a macrophage or any cell that develops as a result of that. What happens is these lymphocytes, that is, they are usually CD8 lymphocytes, go through your blood, go through your tissue, and then recognize the cancer cell in the tumor area. And what happens is that if you block that interaction, what happens is that the T cell generates an immune response, which causes these cells to die and also releases antigen, which subsequently causes a cascade to develop where you fight the cancer as it is. Now, is there a way to know which cancer cell is going to which cancers are going to respond and which cancers are not going to respond? We are not very good with this, but the best marker we currently have is something called as the PD1 or PDL1 identification. That means, let's say, and this is a score that we use. This a CPS score is something that we use to see what is the extent of staining. That means, let's say, if the stain shows that a number of the tumor cells as well as a number of the lymphocytes are marking as positive on the stain, the likelihood of getting a response is high. So here what I'm showing you is, let's say, there's about 10% staining. That means about uh, a bunch of cells here are showing evidence of PD1, PDL1 staining. And this combination of the tumor cells as well as the lymphocytes, that is used as a marker to tell how likely it is that you're going to respond. So for example, let's say you can see over here, 30% of the cells, about a third of the cells are showing staining with the PDL1 stain. Here, all the cells are. So CPS becomes 100 over here. A lot of them are, so it's 80 over here. About half of them are, so CPS becomes 50. So the higher the stain, the CPS number, the more likely it is that you will respond to the immunotherapy. Now, there are other markers such as the tumor reputation burden and so on and so forth, and the presence of MSI, which of course is unfortunately not very common in oral cancers, which are also used as surrogate markers. Now, how well does this combination of immunotherapy do versus the previous standard of care, that is chemotherapy with a targeted therapy, which is cetuximab? So you may remember I had mentioned about the extreme trial by Ioccon, where they had given cetuximab with chemotherapy. So that was the control arm. And here are the two experimental arms, that is pembrolizumab by itself versus pembrolizumab with chemotherapy. And this was given every 3 weeks. And the pembrolizumab was continued for 35 doses. And what happened was that there was definitely an improvement both in overall survival as well as in progression-free survival in that group of patients who had a CPS more than 20. That means more than 20% of the cells were staining with this particular stain. So what that did was it achieved a new standard of care. This is a paper by Barbara Burtness et al. It's called as Keynote 048. And what that shows is that the combination of chemotherapy with pembrolizumab or in patients who cannot receive chemotherapy, pembrolizumab by itself, seems to very significantly improve the patient's overall survival. Now, when we give immunotherapy, what we have to remember is that as opposed to the previous side effects that I talked about, that is lowering of blood counts, nausea, fatigue, and so on and so forth, the side effects of immunotherapy are very different. The most common side effect is a skin rash. We also see hypothyroidism, that is the TSH starting to go up with symptoms. Besides that, side effects like hepatitis, colitis, and so on and so forth, pneumonitis, and so on and so forth are rare. They occur in somewhere around 1 to 5% of the patients. And one has to look out for these side effects. And a lot of times when we stop the immunotherapy, things get better. These side effects don't all occur at the same time. The first thing that happens is rash and pruritus, which occurs pretty early by the 3rd week or so. Liver toxicity happens somewhere around the 7th week. Diarrhea can happen before that, and so on and so forth. So recognizing these side effects is important, especially if you're co-managing these patients with a medical oncologist. Now, why is it that we are so excited about this as opposed to any other modality of treatment? And that has to do with something called as the tail of chemotherapy. Now, when we treat people with chemotherapy alone, what happens is that over a period of time, the number of people who live progressively goes down. And, we reach a plateau as to how many people are long-term survivors. With targeted therapy, it is better. And when we combine it with immune checkpoint inhibitors, this is what you can see. What you can see is that a significant number of people are long-term survivors, as opposed to people dying off fairly quickly. This is what you generally see in a group of patients, not all of them, a group of patients who have this. Now, let's say the promise is this: if we can get further effective treatments, we may be able to even get it up to this level. This is what we're really hoping to do. That is combining immunotherapy with things that are coming down the pike to be able to do that. So where does ASCO stand on this? What they say is that you should check for PD-L1 in all patients with recurrent or metastatic head and neck cancer. We've also now started moving towards giving it in a neoadjuvant setting. That means giving PD-L1 therapy in a neoadjuvant setting prior to going on with the surgery. And in that group of patients also, we are able to get better response rates and also better progression-free survival. Now, if you have a CPS score more than 1%, we consider it as positive. And that usually means that the patient may benefit from PD-1 or PD-L1 inhibitors. We talked about tumor mutation burden, which is sometimes used if you cannot get a positive CPS score. If you get more than 10% or even higher, it likely means that you will probably get a good response with the usage of these immunotherapy drugs. One other thing to also remember is that it doesn't work in every patient. But, in those people who it works, usually you may be able to get a sustained benefit. Other things that have happened is that, we've in oropharyngeal cancers, we've tried to de-intensify the amount of radiation that we give, especially for HPV positive patients. There's this study that shows that you can potentially reduce the morbidity of radiation in that group of patients. Similarly, in nasopharyngeal cancer, the usage of immunotherapy, that is nivolumab with another drug called ipilimumab, which works against the CTLA-4 region, it doesn't seem to really help a whole lot. And in this study called Jupiter, we found that this is another monoclonal antibody plus chemotherapy. It seems to work better. Now, how do we put it all together? And that's what I wanted to talk about here. Now, let's say if it's a new patient, that means someone who has not received treatment before, you do check for the PD-L1 status. Now, if it's a CPS more than 1, that means the tumor is staining for the presence of this particular protein, PD-L1 protein. And if the patient is eligible for chemotherapy plus immunotherapy, then you give chemotherapy and immunotherapy. That means pembrolizumab, nivolumab, and so on and so forth. If the patient is not healthy enough to get chemotherapy and has a CPS more than 1, you can consider giving them single agent immunotherapy, that also has a pretty good likelihood of a response. If the patient has a very high CPS score, here it says 20, there are other studies that show a higher number, you could consider giving them single agent pembrolizumab, or you could give them pembrolizumab with chemotherapy. So this is in the group of patients that are likely to benefit with immunotherapy. Now, let's say if the CPS is less than 1, there you have a wide choice. It's up to you to decide how you want to treat. You can treat them with chemotherapy alone. You could give them chemotherapy as well as a targeted agent, that is cetuximab that we talked about. And the chemotherapy is either cisplatin with paclitaxel or docetaxel or cisplatin with 5-FU. You could consider giving them immunotherapy, but the likelihood of a response is going to be less. Now, what if the patient has received treatment in the past? Then I think, you could try a different chemotherapy regimen. Or if the patient has not received immunotherapy before, you could consider immunotherapy then. So where do we stand at the end of this talk? One, as I said, oral cancer is a serious public health concern, and we should do more to try and catch these patients early so that more patients can be cured. Head and neck cancer, including oral cancers. Oral cancers considered as a part of this group of cancers for trial purposes. But we need to do more to try and do studies, basically more on oral cancers, so that we have more data pertaining to our group of patients. We talked about oral organ preservation, especially in larynx cancer, some patients with hypopharynx cancer, and rarely with patients with oral cancer. We talked about adjuvant chemotherapy after surgery with radiation for certain groups of high-risk patients, that is patients who have positive margin, extranodal extension, and certain other select groups of patients. In advanced disease, we have several drugs and combination of chemotherapies that work well, and the side effects need to be managed carefully. We talked about targeted therapy, which is cetuximab, as well as other agents that work in combination with radiation and in certain groups of patients, as well as in combination with chemotherapy in advanced disease, which is Morgan's paper. We talked about immunotherapy, how it works and where it works in this group of patients. So that's basically the gist of what I wanted to say. I wanted to thank the organizers of Ioccon, Dr. Anwar and his colleagues, for the opportunity of this talk. I'm open to questions if there are any. Thank you.
Anybody can unmute your microphone and ask questions to Dr. Mohan Menon. Anybody who is related to oral medicine and radiology, who are teaching their patients in their dental OPD, want to know about the chemotherapy. So we have the expert with us. You can ask your query. So Dr. Mohan, I think there is no query with
Sure.
us. You
That's
stay
fine.
with us for a time. Maybe if the
Sure.
query is raised, the next speaker, maybe
No
we'll
problem.
get back to you. And
Thank you again. Bye.
Otherwise, you have shared your email ID, I think, the first slide, and your
Yes.
email ID. So they can keep in touch with you if they have any query and question.
Absolutely. Sure.
Over to you, Dr. Milan.
Thank you, sir. Advancing to the fifth session of today's program, we are honored to introduce Dr. Abhishek Singh, serving as an attending consultant in head and neck surgical oncology at Rajiv Gandhi Cancer Institute and Research Center in Rohini, Delhi. Dr. Singh boasts a notable professional background. With numerous publications to his credit, Dr. Singh has contributed to a book chapter on robotic neck dissection and played a pivotal role in the first ever robotic neck dissection in India, utilizing the indigenous SSI Mintra robotic system. His extensive surgical experience encompasses various local regional flaps, ablative surgeries for locally advanced oral cancer, salvage surgeries, and specialized procedures such as CAD/CAM planning for free fibula flap with primary implants and PSI implants. Dr. Abhishek Singh is also actively involved as organizing committee member for Ioccon 2024, showcasing his commitment to advancing this field. I kindly invite Sir to share his expertise on loco-regional reconstruction options in oral cancer ablative defects. Over to you, Sir.
Dr. Abhishek, could you unmute? Yeah, your screen is muted.
Yeah, so can you hear me?
Yeah, you are audible.
Okay. Yeah. Is the screen visible?
Screen is visible, but it's not in presentation mode or slide share mode.
Now can you see?
Not yet. Could you press F5 or in the bottom, there is an icon. There are three icons. You can select that slide show mode. Yes,
My side it is on slideshare mode.
it's not visible here in slide. So can you press F5 possible on your keyboard?
Yeah, I've already pressed it.
Not going the slideshow mode actually.
Because on my laptop it's on
Yes,
slideshow mode.
So Abhishek, can you once disconnect and then reconnect again?
Okay, I'll do that.
There's some problem.
Okay.
Yeah, please. Yes, now it's visible.
A very good afternoon to everyone and the organizing committee. Thank you for this opportunity of the Ioccon. So my talk today will encompass about the local regional flap reconstruction options in oral cancer ablative defects. So just a brief. So oral cavity cancer is the sixth most common cancer worldwide, and in India now it is the #1 cancer, third most common. But in the male scenario, it has reached the first position. And most tumors of the oral cavity are squamous variant, and surgery is the mainstay for the management of oral cavity cancer. Like already been discussed by the other speakers, that adjuvant radiation therapy plus minus chemotherapy is based upon the stage of the disease and the margin positivity or like E&E node. Now, just a brief about what defects are we talking about, what defects would need a reconstruction. So suppose the buccal mucosa defect is there, the mandible and the maxilla. So these defects, when the portion of the bone is removed or the complete portion is removed, will dictate the term of the reconstruction that is to be done. So this is just a brief that what is a marginal mandibulectomy. It is something in which just a portion of the mandibular bone is removed. Segmental is one in which the entire segment is removed. So this is just a photograph depiction of a marginal mandibulectomy which has been done in a patient with a buccal mucosa disease and the concomitant neck dissection which has already been done. And these two are the side examples are, if you can see, these are the segmental mandibulectomies. The entire mandible is gone, the portion of the tongue is gone, and the neck dissection has been done. Again, the down image is again of a marginal mandibulectomy defect. Now, this is where the mandible has been removed in oral cavity, advanced stage disease, T4A disease. Inferior partial maxillectomy has been done, ITF clearance has been done, and the second image is where high ITF clearance has been done. So the bigger the defect, the bigger the reconstruction, and the more bulk of reconstruction do you need. Again, you will come in a lot of scenarios where you will have nodal positivity in these patients, in which you would have to do a modified radical neck dissection, in which the muscle would have been sacrificed. In this, you can see that only the IGV and the spinal extension nerve has been preserved. Rest everything in the neck is clear. So what are the factors that govern the reconstruction? Now, the first will be the defect. So defect, what is the location of the defect? What is the function? And what is the size of the defect? Then you would come to the deciding factor once you have the defect which has been created. What flap options do you have? What are the things you're looking in a flap? It's reliable, it's functionally and cosmetically acceptable, and it should be of an adequate size. So cosmetic comes last in a cancer patient. So first is your functionality and the reliability of the flap so that the patient can undergo the adjuvant treatment if needed. Now, also what would you look from a flap is it should match the recipient side, the color, the texture, and the thickness should be of adequate size. And there should be minimal donor site morbidity as well. Now, defects, subsites of the oral cavity can have encompass a buccal mucosa defect, you can have a tongue defect, you can have a floor of mouth defect, you have an alveolar defect, a palatal defect, and a lip defect. So you have cancer patients in which it would not be just a pure buccal mucosa, it will be buccal mucosa going to floor of mouth with the alveolus. You could have a primum upfront tongue lesion or a palatal lesion, but it could also has a gross involvement of the adjacent structures. Now, the various loco-regional flap reconstruction options for oral cancer ablative defects. So this is just an enlisting of the options that are available. So you have the submental flap, you have the infrahead flap, you have the FAM flap, then the supraclavicular flap. Then there's a modification of the submental flap that is known as the modified submental platysmal adipomyofascial flap, which I'll be talking about later. The pectoralis major flap, which has been the workhorse. So this is one of the loco-regional flaps, which has been the workhorse for long. Then you have temporalis flap, the temporoparietal nasolabial, the modified lateral trapezius flap, the forehead flap, the latissimus dorsi flap, pedicle flap, the deltoid. Buccal part of fat and the primary closure of tongue is now it is only done in very few cases. Now, besides loco-regional flaps, you have free flaps, which are microvascular anastomosis has been done. So patients who are viable, who have the financial backup. So the gold standard would be a free flap reconstruction. But in the Indian subcontinent scenario, what do you do if the patients are not affording? They cannot afford the price of the higher price of a free flap surgery. You cannot leave these patients. So they need to undergo treatment. So for that is when your local regional flaps come into the picture. And also patients who are medically compromised who cannot undergo a long duration surgery for a advanced free flap plastic surgery reconstruction incorporating a free flap, a free fibula, ALT, radial forearm flaps. Now, just a brief, in this presentation, what I'll try to do is I'll try to cover as much as possible about the local regional options that are there. I might skip the basic harvesting techniques and might show some video demonstrations of the flap being harvested. And I've tried to categorize it in the subsite wise so that you get an idea of what combinations can you use also. So the deltoid pectoral flap was the first flap which was discovered in 1965 by Bakamjian. It's a pedicled axial fasciocutaneous flap. So the flap journey, the journey of reconstruction has actually started from this flap. So this is now very rarely used, but it is still a salvage option that needs to be considered. It's not a first option, but yes, as a salvage, it is considered. So what are the supply? So you have the internal mammary artery perforators coming from the first, second, and the third space, intercostal space. So you usually have the flap, which is, as you can see in the image, extension is still, this is the DP groove. So the perforators will be lying here. So you incise this, the maximum length that you can do is you can, so this part, the red part becomes a little random based, but yet if you have all the perforators, you can probably get away with the distal tip necrosis. So the advantages, it provides a large area of skin cover, better color texture. It's less bulky than pec major flap. It is technically very easy to harvest. Disadvantage is the arc of rotation. So the arc of rotation is a limitation. So in higher defects, it will not reach to the palate. It will not reach to the upper alveolus defects. So that is something which needs to be considered. Now, obviously, you will have an unsightly donor defect, especially in the chest. You will have to graft this area sometimes if the size of the defect is too big. And another thing is that sometimes it is used in combination with the PMC flap as an outer cover. So again, in that case, you might have to use a skin graft for the donor site closure. This is just a brief example of the incision marking. So this is not a per se an oral cavity case, but it's more of a parotid defect case in which this was used for the cover. So the perforators are here. You go up to the muscle, the deltoid. You can go to the tip. You check for the reach. So this is the point of rotation. So this can cover up till this here, but going up into the maxilla again, it becomes a problem. Again, sometimes you'll have patients who are post RT in which you have done a salvage neck dissection. So you would want something to have as a carotid cover. So PMC, yes, PMF is a very good option, but short duration, DP works equally well. You can just DF the entire segment and just tunnel it into the neck over the carotid, and it gives a very good cover for the carotid vessels as well. Now, coming to PMC, this has been the gold standard. It was discovered by Aryan in 1979. So the blood supply is the main supply. It has three supplies. The main supply is the pectoral branch of the thoracoabdominal artery. Now, the pectoral branch of the lateral thoracic artery and the internal mammary perforators branch from first to sixth intercostal space. They are the ones that supply the inferior part and the lateral part of the flap. And the nerve again is the medial pectoral nerve. Now, a point to be taken in this that when you harvest this flap, you need to divide the medial pectoral nerve because PMC flap is a bulky flap. If the nerve is not cut with the gravity pull and the muscle traction, you will have a superior suture line dehiscence or gaping. This is just a pictorial demonstration of the flap which has been tunneled into the neck and used for a buccal mucosa defect with the segmental mandibulectomy. So coming to the incision markings, so this is the xiphoid process. This is the acromion. So from the mid third of the clavicle, you drop a perpendicular line down. This is where the pedicle is going to lie. A lot of incisions there are varied incisions. Some people will give a direct incision over the pedicle. What we do in our center is that we give an incision to the axilla. So this advantage of this is that if in future you need the DP, and we do not go to the parasternal dissection. So you leave around about 4-5 centimeters of the parasternal tissue, so that any DP perforator will be lifted off as a flap. So this which can be used later in case there's any issue or you need to salvage the PMC undergoing dehiscence. So again, these are just few images of the defects that are. So this is a bipedal defect. So you'll have an external skin which has been involved along with the internal component. This is the resection of the patients. This is just a pictorial demonstration of what all you can do with a PMC. So you can have a bipedal reconstruction. I'm sorry, the images might not match. The right might be left for the other patients, but it's just a collaboration. We don't have the complete set of images. So what you can see is we've done a PMC for this patient. You will have a fullness in this area, but yes, you can reconstruct the outer pedal as well as the inner pedal. So again, in the lower corner, what you can see is a floor of mouth lesion with the buccal mucosa lesion with segmental mandibulectomy. This is 3 years post surgery. Again, this is a bipedal PMC. You can see the inner lining and the outer pedal being made in the PMC itself. Again, the defect. So in this, what you will notice is a incision which has been here. So sometimes we always use a combination. So in patients in which the PMC is too bulky, this flap is known as a cervical rotation flap, which we'll be talking about later. This can be used for an outer covering. So this goes in here and the PMC lines the inner side of the oral cavity. Now coming to the nasolabial flap, it was first mentioned by Sushruta in the Indian literature, but it was originally described by Dupuytren, but it was Dieffenbach who popularized this flap back in 1833. So this is only usable for small to medium-sized defects because the thickness that you can probably take is around about 2.5 to 3 centimeters. So this is based on the facial artery. Now, it's a very simple and easy flap to harvest, which has a good blood supply. The buccal mucosa, floor of mouth, tongue, lips, and commission are the subsites that you can reconstruct using this flap. Now, again, this can be a superiorly based flap or an inferiorly based flap based upon the reconstruction that you're planning. Like I said, the blood supply is the facial artery. The inferior label is for the inferiorly based flap. The angular artery is for the superior based flap. And now, coming to just, again, this is not an oral cavity subsite, but just to give you an idea to what is a superiorly and what is an inferior based nasolabial flap. So this is a squamous cell carcinoma of the nose in which the alar cartilage and the nasal cartilage was removed. You can see the defect. So this flap is based, as you can see in this image, it's a superiorly based nasolabial flap. So you'll have the supply coming from the angular branch of the facial artery. So this is then rotated and closed. So this is the final image of the patient that has been done. Again, this is another patient in which we have done the nasolabial flap for the tongue reconstruction. So you can see that it has been tunneled. So the nasolabial flap you can take, it has very good movement. The scar is, yes, it's placed in the nasolabial groove. So cosmetically to some patients might be a little hampering, but after the radiation, you can see you can see the images. So this is post RT, the patient had undergone. Now coming to submental flap, this was described by Martin et al. In 1993. So it's an axial pattern based flap, which is based on the submental branch of the facial artery. Now, the venous drainage is again the submental vein, which again drains back into the facial vein. It can have 1 to 4 cutaneous perforators. So what you need to incorporate is you need to incorporate the platysma, you need to incorporate the level 1A soft tissue in this. Again, now the variation has come in which there was a lot of concern about the oncological safety. So you can always harvest just a muscle-only submental flap. That means you take out the level 1A, just keep the mylohyoid, the anterior belly of digastric, and the submental branches intact. That also can be used. Now, so this is just a diagrammatic presentation that just shows the venous supply, that's the facial vessels and the submental branch going anteriorly. Now, the upper limit of the flap, so what you need to consider is that at least 1 centimeter below the mandibular arch, you should have the upper limit of the flap. So because it's in this area, it hides the scar very well. And this also, if you leave 1 centimeter, it will prevent the eversion of the lip when you try to close this primarily. Now, how do you assess how much thickness can you take? So there's something called a pinch test. So what you do is you pinch the skin in the submental area to see the primary closure. That gives you the limit of the closure. Advantages is it has a wide arc of rotation, so it can reach even the palate if you take it to the floor of the mouth. So it gives very good contour, texture, donor side mobility is very less. Sorry. Now, and because it's in the anterior chin area, which is not very visible, so it is cosmetically acceptable. Now, the limitations is the thickness of the flap, that you will not get very bulk in this flap. Again, it's a hair-bearing area. So in male patients, it's a big problem because patients in T1, T2 lesions who would not need adjuvant radiation therapy. Now, the hair density in the chin area is the maximum. So these patients will be perpetually complaining about hair growth in the mouth, and it's very troublesome for the patients. So, but yes, so people have tried deepithelializing, taking the skin, then deepithelializing the skin, and then laser depilation has also been done for these patients. So, like I said, it can be used for the tongue, floor mouth defects. Intraoral, it has a very short distance, so it covers most of the sides. It can reach the upper maxillary defects as well. It is used in transoral robotic surgery now for covering the ICA carotid these days. So we have come up with a modification of the flap ourselves, which is called as the modified SPAF. So we are routinely using it, especially in radical tonsillectomies robotically, in which the parapharyngeal fat has been exposed and the IC is lying right there. You need a cover for that. So through the floor of the mouth, this gives a very good cover and a very good reach. And CA oropharynx usually does not spread to level 1A. So it is relatively oncologically safe as well. So the only contraindication of using a submental flap is in an N positive neck. So in N positive neck, you have to be very careful not to use this flap. So you should have, or even when you're doing a clinically N0 neck, if you feel pre-op radiologically or during intra-op, there is any node which is positive, so you would need to send that for a frozen section. If it is positive, then you should have a plan B in the backup that you would want to switch to some other flap such as PMC or lateral trapezius. Now, buccal mucosa. So in this article by Amin et al., the buccal mucosa was the most common site which was reconstructed using the submental flap. Sorry, followed by the floor of mouth. Now, Moni et al. In its systemic review, they did a comparison of the submental artery islanded flap and the free tissue flap, in which the hospital time was significantly and the operative time was significantly reduced. It had a less financial burden. So where money is a constraint, these flaps come in very handy. Okay, and obviously there's a lot of concern about the safety of the submental flap. So we have the largest series, which is by Dr. Verghese of 240 odd patients, in which it has been established that it is a relatively safe flap to use, but you should be using it in a N0 neck. Now, again, just a few image description of the flap which has been harvested. So you can see it's a complete segmental mandibulectomy defect. Now, the problem with this is that the bulk is little less, but yes, in patients who are medically compromised and who want a short duration of surgery, these come in handy. These are very handy flaps too, and robust flap to do. So we are routinely doing these flaps for these patients. So sometimes so this is just a video demonstration of the flap which is being done. So what you can see is it's a T4A lesion, varicose lesion involving the commissure and the buccal side. This is the defect this is created. This is the incision for the submental flap. So after the pinch test has been done, so this is the dissection which is done. The platysma is incorporated into the is being incorporated into the harvesting. So you have to be very careful that you have to preserve the marginal mandibular in this patient. The facial vessels have to be dissected and have to be preserved. So any node which you see, you send it for frozen section. I will just skip with the video because it will take a lot of time. So this is just so the facial vessels which are being dissected out. This is the facial artery, the facial vein, which is being done. Again, the flap is being raised from inferior to superior. Now, coming to the tongue as a subsite. So why is there a need of reconstruction? So Ansarine et al. Has come up with a very good classification for clostrectomy defects. So usually the type 1, the type 2 partial clostrectomy defects do not need reconstruction. They can be closed primarily and they can heal. It is only the type 3, type 4, and type 5 that mandate a reconstruction. So now type 3 again is a hemiglossectomy defect. You can do infrahead flap, you can do FAM flap, you can do modified SPAF, you can do infrahead, you can have supraclavicular, the modified lateral trapezius flap, and obviously the free flaps as well. But for T4A, T4B, and type 5, you would prefer using a free flap because the bulk of the defect is more in such patients. So that is the subtotal and the knee total clostrectomy defects. But if in case the patient is not affordable, PMC is a substitute, but we would prefer a free flap in these patients. Now, any small defect which is reaching to the tip, so the tip needs to be reconstructed. So in that, these flaps come in handy. Now, like I said, so any tongue defect which has a volume loss of less than 30%, you can manage with primary closure. Some patients, so you can do with SSG skin graft. Mid third lateral border tongue, in which you're going to the floor of the mouth, there's a communication of the neck to the floor of the mouth section. In those patients, again, you would need a flap. So infrahead, FAM, modified SPAF, these are your options. So in tongue, but as a institutional protocol, we do not advocate using the submental flap because the chances of a nodal positivity if a level 1B node is positive is very high. So in these patients, we would prefer the infrahead flap or the modified lateral trapezius flap. So just a few examples of, So this is our T1 lesion in which you can get away with the primary closure. Again, T1 lesion. So these do not need any deconstruction. You can just do a primary closure in these patients. So infrahead flap, coming to the infrahead flap, it was given by Clermont Conley in 1977. And the first report was given by them. The Wang et al. Is more renowned, called as the father of this flap because in 1986, he actually reported the technique of how to harvest this flap. So it is basically a myocutaneous pedicled flap based on the superior thyroid vessels with which the perforators are going through the infrahead muscles. Now, the infrahead muscles which are incorporated are the sternohyoid muscle, the superior valley of omohyoid, and the sternothyroid. So you do not take the thyroid muscle. So that has to be kept back because that you have to safeguard the external branch of the superior laryngeal nerve, which is very important when you harvest this flap. Now, it is a thin and pliable flap. The maximum skin island dimensions can be around about 7 into 4. So anything that goes beyond 5 centimeters in width, you might need an additional flap, such as a DP flap to cover the donor side defect. Now, small to medium sized neck defects can be covered. So if you can see in the marking, so the medial edge lies at the midline. The upper edge is at the level of the hyoid. The lateral edge is 3 to 5 centimeters from the midline, and the lower edge is at the suprasternal notch. Again, the various sites you can reconstruct is the tongue, the floor, the lower alveolar ridge, base of tongue. Now, for base of tongue, there's an article in which, along with because it has its supply, the infrared muscles have the supply from the ansa cervicalis. So that gives a very good movement to the flap in these patients. Now, the maximum length is 10 centimeters, depending upon the length of the patient's neck. So long neck patients usually will give you more length of the flap. The width, again, if you're crossing over 5 centimeters, then you would probably need a DP to cover the donor side because the neck skin becomes very tight to close. Again, a problem with these flaps is that if patients will need tracheostomy, there will be communication on the tracheostomy side. So you need to seal that up very well with the sternal head of the SCM. Now, for tongue cavity, oral cavity, oropharynx, the question is that when these can be, why can you not manage them with the skin graft? Why do you need a pedicle flap or a flea flap? So what happens is when you have a communication of the oral cavity or the oropharynx with the neck, and you're just using a primary closure, or you put it in the skin graft. So skin graft will cause a lot of contraction, a lot of fibrosis. Whereas also if you do a primary closure, if there's a communication with the cervical neck, so that will lead to a fistula. And if your saliva, if there is a salivary fistula which communicates from the oral cavity to the neck, then your vessels are right exposed there. So these patients will be at a higher risk of a carotid blowout because it's right bang right next to the oropharynx area. Now, again, a few modification. Sorry. So we have been trying to do away with the need for the tracheostomy for these patients, because if you take the skin, so yes, in the literature they have described the muscle-only variant of the infrahead flap. So in tongue patients in which the bulk is a little less, it's a mid-sized defect, which is when you need a skin and you need a cover of the marginal mandibular defect. We have been using the muscle-only variant. Again, the horizontal transverse variant has been described, but it's described less in the literature. So this is one of the patients that we have done in which the tracheostomy is relatively safer in these patients to do because you have good soft tissue here. So you just harvest the flap. But the disadvantage is that the part of the flap which is beyond the midline, that is all random based. So you can have a tip necrosis of this, but the muscle in this part of the flap is robust, so that stays. Again, we do a pinch test to see whether we can get a primary closure. So this negates the vertical scar of the infraheight is something which a lot of patients worry about. So, but this horizontal design negates it, but you have to be careful when using this flap. These are a few of the images of the patients who have undergone. So what you can see, the vertical scar below, and this is a flap of the patient. Again, another patient in which the infrared flap has been done with the marginal mandibulectomy. So this scar is what comes in, but the horizontal one negates that. But like I said, you have to be very careful of the patient choices that you take. So again, brief about the so yeah. So this is the tongue defect. This is 6 to 4 centimeters. The flap which has been taken, the neck dissection has been done. So you have to be very careful when you're doing the dissection anterior to the IJV, because the superior thyroid vein and the superior thyroid artery, they need to be preserved. And you cut how do you harvest the flap is first you start inferiorly, you divide the strap muscles here, you lift up the strap muscles over the thyroid capsula in an avascular plane. Then from there you go up identifying the vessels and preserving, and then you raise it up. So this is just a video demonstration of a patient who has undergone, I'm sure it's not playing, so just to show the movement, but I think it is not playing. So yeah. So the movement, these flaps will only support the tongue. The movement has to come from the remnant bulk of the tongue. So that is something which is there. Now coming to the modified submental platysmal adipomyofascial flap. So this is a flap that we have faced the problems of patients coming in with hair growth in the submental flap. So there's an article which has been published by us on this, a series of around about 25 odd patients. This flap, it obviates the need of any other surgery. So what basically you do is you leave the neck skin, you do not take the neck skin at all. So you just take the subcutaneous tissue, the level 1A and the muscles along with it. And also we have been using this flap in combination with a lot of supraclavicular and lateral trapezius flap, because sometimes the PMC is too bulky over marginal mandibular defect. So what do you do in these patients? So in these patients, this is a good flap to have over the cover for the bone. So we have done it for tongue defect, but like I said, now as an institutional protocol, we do not do it routinely for tongue. We have limited ourselves for buccal mucosa defects and for marginal mandibular defects and for oropharynx. Again, this is an example for the tongue. So what you can see is that you do not need to take the neck skin. So the neck skin is so vascular that it does not undergo any necrosis. So we have not had any donocyte necrosis or skin loss in any of the patients. Again, this is a tongue defect which has been reconstructed using a supraclavicular flap. The supraclavicular flap is based on the supraclavicular artery, which I'll be talking about a little later. So I've just briefly, what are the options for the tongue? That is what I'm trying to put across. Again, this is the post-operative images of the modified SPAF, which has been used in floor of mouth, marginal mandibular defect, tongue, buccal mucosa, palate, and again, you can see the palette image. And see, this is the scars. This is the only scar that will come. So horizontal scar, the neck skin is absolutely here. So there's no need for a primary donocyte closure. Now coming to the modified lateral trapezius flap of the tongue defect, again, we have been very fortunate enough that we were in communication with Dr. Damakeso, who is the first person to describe this flap in 1979. So from the original technique, even they have modified their technique to how we are doing it exactly right now. So this flap is more robust than the supraclavicular flap because the success rate of the distal necrosis is too much. So it's around about 40% in most of the patients in what we have seen also, and with the literature what supports. But the lateral trapezius flap in our series that we have published is around about 35 series. We've had only 2 flap failures because of and those 2 was because of the complete islanded mobilization of the flap. So this is the marking of the flap. So what you do is you take the chromium process in the center and you base. So this is an intermediate design. So there are 3 designs. You have the anterior design, the posterior design. So this is an intermediate design in which over the acromion is pedicled and it's based on the transverse cervical. Again, there are 3 supplies I will be talking about a little later, but this is just an image to show that tongue can be reconstructed very well with this flap as well. This is 3 supplies, the dorsal scapula, the transverse cervical, and suprascapular artery is what supplies this flap. So this is just a video demonstration of a patient who had undergone tongue resection along with marginal mandibulectomy and the neck dissection. So you do the flap marking. So there is an option, either you can connect it to the neck skin. So you check for the reach of the flap. And again, this is the acromion process. This is the clavicle. This is the posterior border trapezius. So you have to incorporate the trapezius. You have to palpate the posterior border of the trapezius and then incorporate it into the flap. So this is the incision that is being given. So you start with harvesting in the subcutaneous plane because you want to leave that neck skin there. Then you go deep up to the deltoid muscle here. So the DP groove lies here, the trapezius fibers are here. So you go deep down to the fat and the muscle. So you go over the fascia of the deltoid muscle and start raising the flap from distal to proximal. So we mostly use ICG at a center to check for the vascularity of the flap has been raised. So this is the elevation of the flap over the deltoid muscle. So the important point is that if you have a level 4 node which is positive, which is adherent to the transverse cervical artery, that becomes a relative contraindication for this flap because if it is stuck, you will probably be injuring those vessels there, which is the main supply of this vessel. So over the acromion, you have to be careful that you leave a little bit of fat, otherwise you'll enter into the joint space. So this is the only key point in raising this flap and this area. So this is the trapezius fibers being cut. So you have to identify the transverse cervical artery here. And this is the spinal accessory nerve. So you have to dissect and preserve. So initially, it was not being preserved, but with time, we realized that it is a nerve which has been sacrificed just because of the flap. So we modified it and we've been preserving this nerve ever since our modification. So this is the flap which has been harvested. We routinely use a Doppler to reconfirm the supply at the end of the harvest to see how the transverse cervical, because if you've done level 4 dissection, you have to be careful that the ascending branch is not ligated. So level 4, level 5 nodes is something which you have to be careful about when using this flap, when you've dissected in that area. So this is the portion of the flap which is being deepithelialized because this will go into the floor of the mouth. So you can see the reconstruction being done. So this is being stitched to the tongue. The DA portion will come over the bone. That will give a good cover to the bone. So this is the setting which has been done finally. The donor site can be closed primarily, but sometimes if it is too tight, the advantage of doing the deepithelialization is that will give you some of the donor site skin graft that can be further used in the same patient. That deepithelialization, the same graft, you don't need an additional donor site. So this is the tongue movement of the patient that you can see, which is again done by the remnant part of the tongue. This is the shoulder adduction. So we have our institutional experience. Like I said, we have published a series of around 35 patients in which the graft failure was only in 2 patients, that is 5.7%. And this is just a brief of the various subsites that we have used. The flap, so tongue, floor of mouth, buccal mucosa, RMT. Okay. Now, coming to the FAM flap, that is the facial artery myocutaneous flap. It was first given by Pirazab in 1992. It's an axial flap based on the facial artery. So with this flap, yes, around about 5 to 3 centimeters can be harvested, and it is a very good flap because it lines, you get the donor mucosa, but you have to be careful in patients who have a pre-existing OSMF. Then this flap becomes problem because you would not get much mucosa in those patients. So the vessel supply is the facial artery along with the facial vein, but the subdermal plexus is so solid in the mucosa that even if the vein is not preserved, you still have the flap viability. So this is in the article by Dr. Sean Joseph. They have used this flap as an islanded facial artery myocutaneous flap for tongue defect, and the donor site defect can be closed primarily or with the buccal part of fat graft, but you would need rigorous mouth opening sizes for these patients. Now, just a brief overview of the partial vasectomy defects with floor of mouth defects. So posterior location, if there's neck communication, you would want to put in a flap. These are the options, which are very options. If there's no orocervical communication, you don't need a flap, but you can use a buttress it with the sternal head or with the omohead as well. Mid-anterior location, you need to reconstruct. These are the options. Again, a brief about the various. So this is an infrahead flap done for a tongue patient. Below is the supraclavicular flap, which is being done for a tongue patient again. Now, floor of mouth buttressing is something which we do when we feel that the mucosa after the dissection, especially in the posterior aspect, when you go to the deep margin, the sublingual glands, it's a very thin tissue which is there between the neck and the floor. So in those patients, we hitch the digastric to the mylohyoid, and also we do a omohyoid buttress. So what you can see here is the omohyoid muscle. In some patients, you have a bulky omohyoid. This can be used additionally to be sutured here to buttress the floors. As you can see in this image, it has been secured here. And this is the vessel that is supplying it. And again, the sternal head of the SCM can also be used. Now, tongue, floor of mouth, marginal mandibular defect, where the bone is exposed, again, you need to put in a flap. Again, the options are infrahyoid, supraclavicular, modified lateral trapezius, bilateral nasolabial, PMC flap. So again, this is just a few of the options, the modified SPAF that we have done. So it's an anterior marginal mandibulectomy, what you can see here, and we have done the modified SPAF. And you can see the patients, there's no donor site skin that has been taken. And this is the post-op image after 6-7 months. Coming to the buccal mucosa defects, when do you reconstruct? You reconstruct when it's a posterior base defect, when you've knocked out the bone, then you need to put in a flap again. Masseter flap is not routinely used nowadays because of the fact that it causes a lot of fibrosis. But yes, it was an option. It is still to be enlisted. Now, suppose you have done you breached the sinus floor. Again, you would want to put in a PMC flap for those patients, or bulky flap, especially with a marginal mandibulectomy or a segmental mandibulectomy with an upper alveolectomy, bite composite sections, high ATF clearances. In that, you will need more bulk. So these flaps will not suffice. For that, you would want a PMC, a bipedal in which you have incorporated the skin resection. You could do a bipedal PMC, or you could do a combination flap of a cervical rotation and a PMC flap as well. So this is a buccal mucosa defect in which again the modified SPAF has been used. Again, few of the images of those patients. This is a submental flap in which we have done a bipedal submental flap for buccal mucosa commissure defect. So you can see this is the normal conventional submental flap that has been used. This is a lateral trapezius flap modified again for a buccal mucosa flap. Again, one of the patients in which tongue has been done. So,
Dr. Abhishek, could you please conclude we are running time.
Yeah. So, so all these options are there. So just coming to the last one. So PMC is something which has been done routinely. These are the land markings of the PMC flap. So this is a flap that has been done. Again, like I said, we can use it in combination. So this is the cervical rotation flap. The PMC flap is inside. This is a post-op image of a patient. PMC inside, cervical rotation flap outside. Again, you have forehead flap. You have the LD flap. So I'll be just be listing those. This is an image of an LD flap for the patient. So this is just a brief about the lip reconstruction. Again, the submental flap. The supraclavicular flap is the last one. That is this thing. So I will skip on the video of the supraclavicular flap, but the advantage is it is simple to use, but the only problem with this is the distal part necrosis. So we negate that by using ICG at a center. And so all T1, T2, T4 lesions, they need reconstruction based upon the site, subsite, the volume of the defect that has been done. So thank you so much. And thank you.
Thanks, Dr. Abhishek, for enlightening us and very, enlightening your knowledgeable this presentation. Anybody from audience who want to ask any question? Dr. Abhishek has shared all surgical, various flaps and approaches. If you have any confusion, if you have any doubt, you can share, you can unmute yourself and you can ask question directly, or you can put in a chat box. And those who are watching our program on our website, ioccon.org, they can enter into the Zoom room. There is a link in the bottom of the videos available. So if you click the link, you can easily enter into the meeting room in the Zoom. So those who are watching over there, they can also join here and ask questions. So Dr. Abhishek, there is no any question so far. You stay with us. Maybe if any question arises after the talk of Dr. Absun, then we'll come back to you for that answer of that question.
Right.
So I'm requesting you to stay with us for a while, and then you can keep your microphone off and camera off and mute, and maybe if any questions come, we'll get it back to you after this presentation of Dr. Absun.
Right.
Thanks for coming and sharing your
Thank you so much for the opportunity.
Thank
you so much.
Okay. So with your permission, Dr. Abhishek, we are moving to our next speaker.
Yes, thank you so much.
Thank you. So before I go to our next speaker, let me introduce our young moderator, Dr. Ankita Prasad. Dr. Ankita, recently did her graduation BDS from prestigious Maulana Azad Dental College, New Delhi, and she is serving as an intern over there. So over to you, Ankita, for chairing and moderating the session now onwards. Over to you.
Thank you, sir. I'm moving let's proceed to the sixth session of the day. So I'm going to introduce Dr. Efsun Somi. She has graduated from Gazi University, Faculty of Dentistry in 2001, Ankara, Turkey. In 2002, she completed her PhD program in Baskant University, Faculty of Dentistry in Department of Oral and Maxillofacial Surgery, and received the title of Doctor of Science. She worked as a specialist physician in Department of Oral and Maxillofacial Surgery at Turgut Noyan Research and Practice Hospital. In 2020, Dr. Efsun also received the title of lecturer at Baskant University, Faculty of Dentistry in Department of Oral and Maxillofacial Surgery. She is currently working as an associate professor at Baskant University, Faculty of Dentistry, Department of Oral and Maxillofacial Surgery, and simultaneously as an honorable lecturer professor in Kyrenia University, Faculty of Dentistry, Department of Oral and Maxillofacial Surgery, Kyrenia, North Cyprus. I request you, ma'am, to deliver a talk on the topic radiotherapy and dental implant applications in patients with head and neck cancer. Over to you, ma'am.
Thank you for your kind preservation. Is it okay?
Yes,
My
your slides are
slides-
visible. Yeah, Dr. Efsun, your slides are visible.
Is there any problem?
No, not at all.
I'll continue.
Yeah.
First of all, I want to thanks for Dr. Avar for to have an opportunity to taking in these valuable congress about oral cancer. Thank you. and for nice presentation of the other colleagues. Good afternoon, my colleagues. I want to talk about the radiotherapy and dental implant applications in patients with head and neck cancer. As you know, head and neck cancer is the sixth most common cancer type, has a 5-year survival rate of just above 50% with modern anti-cancer therapies. There are three cornerstones of palliative and curative treatment for head and neck cancer, with account of 3% of all malignant tumors are surgery, radiation therapy, and chemotherapy. The salivary glands, the composition of saliva, and the lining of mouth may undergo significant change to the radiotherapy. Mucosal ulcerations, mucosal fissures, salt sores, dental infections, tooth decay and tooth loss, and osteoradionecrosis, and finally jawbone deformities and related cosmetic issues occurs due to cancer treatment. Due to combination of persistent salivary decline, excessive sugar consumption, and high levels of carcinogenic bacterial flora and bad oral hygiene, patients undergoing head and neck radiotherapy are more likely to develop tooth caries. Multiple tooth loss occurs in the group of patients following radiotherapy due to deep rampant caries caused by a disease in salivary volume, deterioration of salivary components, and radiation comorbidities such as mucositis, which dramatically and adversely influence oral hygiene. Patients require dental rehabilitation to enhance the ability to chew, swallow, and bite, to meet their nutritional needs, and to improve their aesthetic, social, psychological, and economic quality of life. Traditional removal dentures may not fit comfortably after treatments like radiotherapy and surgery because of anatomical changes in the orofacial region and jaws. Like dry mouth, for this reason, dental implants are frequently chosen for these group of patients. As you know, a dental implant is an artificial tooth root that is surgically implanted into the jaw to support a bridge or prosthetic tooth, and it serves as an anchor for restoration. Considering the increasing prevalence of dental implants, a significant increase in the number of head and neck cancer patients requiring dental implant treatment or care is required. The bone damage caused by dental implants procedure is repaired in the same way that ordinary extraction socket heal. And the damaged bone first resorbs, then realigns itself around the implant, and finally osseointegration causes the dental implant to become permanently affixed to the bone. Progressive tissue, what are the causes of the dental implant failures in head and neck cancer patients? There are progressive tissue and vessel fibrosis, reduced healing capacity of the injured site, and resultant tissue dehiscence, and the osteoradionecrosis. They are all causes of the dental implant failure in head and neck patients. High radiation doses, accelerated or hyperfractionation, additional chemotherapy, and surgical interventions in radiation feed causes delay in bone healing, and also causes possible osteoradionecrosis complications like possible osteoradionecrosis. The main reasons for osteoradionecrosis are radiation trauma and infection. High doses of radiation-active cytokines promote hypoxia, initiate fibrosis, and cause osteopenia and osteoporosis, increasing the risk of bone fracture. In osteoradionecrosis formation, thrombosis and obliteration of small vessels decrease in the amount of osteoblasts and osteoclasts. And then fibrosis formation and adipose tissue degeneration, deterioration in repair and generated capacity, and as a result, bone necrosis come to mind. Although trauma is the triggering factor, the inflammatory process begins when microorganisms encompass it. It can also be difficult to use implants in some patients because the area of bone needed for the procedure is frequently in radiation damaged zone, which could lead to more important failures due to progressive tissue and vessels fibrosis and the resultant reduced healing capacity of injured site, tissue dehiscence, and osteoradionecrosis. What's osseointegration? Osseointegration, as you know, defined as a direct structural and functional connection between ordered living bone and surface of load-bearing implant, is critical for implant stability and is regarded as a prerequisite for implant loading and long-term clinical success of dental implants. Implant survival and successful osseointegration are influenced by the surgeon's experience, bone quality, topography of the bone, implant length and diameter, and technical factors like primary stability, total radiation dose applying to jaw, and timing of implant placement. Radiotherapy causes single-strand and double-strand DNA breaks in the irradiated healthy and tumor cells. Applying lower than 50 gray radiation causes neoplastic cells, osteoblasts, and bone marrow cells that divide quickly are susceptible to cellular death, relatively low doses of radiation. But applying higher than 70 gray radiation to the jaw, osteocytes become devitalized at high dose, leading to connective tissue fibrosis, osteoradionecrosis, deterioration of osteoradionecrosis. In a study published by Tanaka and his colleagues, it was stated that the early implant may loss occur in radiotherapy and irradiated bone, and including osteoradionecrosis. Conversely, one review reported that there was no difference between irradiated and received no radiation patients due to the radiation of the jaw. What is the overlooked that the dose planned for false tumor is often not equal to those to which the implant bed is exposed. For this reason, the main evaluation should be made according to the actual dose received by implant bed. In Albertson and colleagues in Albertson paper, he made a total of 31 implants for patients 1 to 5 years after radiotherapy and was applied to jawbone, and he achieved 100 full success. And this has led to the suggestion that radiation is not a contraindication to implant placement. In another study, Lee et al. Evaluated 58 patients with head and neck surgery, head and neck cancer who will receive radiotherapy. He evaluates also 151 implants, and the implants were inserted 3 to 4 weeks before radiotherapy. The median dose to tumor is 62.4 gray, and the cutoff dose they determined is 40 gray to the implant bed, and they concluded that the bone resorption begins higher than the radiation dose of 40 grays to the jawbone. And also 1 year after radiotherapy, the success rate of implant is 94% survival. 3 days after radiotherapy is 88.2%. Among head and neck cancers, oral cancers are the most frequently exposed to radiotherapy to implant site and jawbone. If the applied dose is above 40 grays, implant loss is possible, with the most implanted loss occurring in the same mandible and posterior implants. In the study conducted by Anderson et al., they stated that the radiotherapy dose higher than 50 grays caused soft tissue necrosis, and lower than 50 grays cause bone necrosis, and they stated that surgical complications occur when 1 to 6 months, and the deterioration in muscular structure, deterioration in fibrotic activity, and deterioration in wound repair occur before 24 months. They also stated the surgical complications occur between 1 to 6 months with while deterioration in muscular structure, deterioration fibrotic activity, and wound repair. And they declared that fibrotic activation started before 8 months, and the authors concluded that the safest time interval for the dental implants insertion in this group of patients is 6 to 8 months. In another study, it was declared that the risk was low in patients who received radiation below 40 gray, while the risk was high in patients who received radiation dose above 60 gray. They stated that above 60 grays, implant mobility increases and fails. In another study conducted by Klein et al., it was stated that the 5 years implant survival was 90.9% in patients who were placed 6 months after radiotherapy and received radiotherapy over 50 grays, while it was 77.5% in patients who received radiotherapy below 50 grays. In a study conducted by Neck et al., it was stated that the retention of the removable prosthesis will deteriorate, and it would be difficult to use because dry mouth, xerostomia, occurs in the patients after radiotherapy. The authors reported the dose received by the implant bed is important. In their study, they applied 72 grays radiotherapy 6 months after implant placement and reported implant success of 92% after 1 year, 80% after 3 years, and 75.2% after 5 years. In a systematic review, while the critical dose limit was determined as 55 grays, the success rate was reported as 77.9 when the implant was placed before radiotherapy, while the success rate was 92.2%. The author declared that the factors affecting osseointegration is radiation dose and area, time between radiation therapy and implants placement, and healing time of implants left unloaded, and localization where the implants was inserted in maxilla, whether in mandible. Again, in the same study, 775 implants were inserted in the patients, and they reported at the end of the study that dental implants in the mandible are more successful than in maxilla. And when 55 gray was selected as the critical dose for implant insertion, it was stated that there was a significant difference before and after radiotherapy. In this study, Pitero et al., the implant success rate before radiotherapy was reported as 89.5% to 97%, and the success rate of radiotherapy was reported after radiotherapy was reported 80% to 100%, while it was reported as 92.2% and 100% in patients who didn't receive any radiotherapy. Additionally, this study determined 50 grays as the critical dose for implant success. In a retrospective study, the patients were examined and the total implant success was reported 96.65%, while this rate was 93.02% in head and neck cancer patients. And in healthy patients, this survival rate total implant success is reported as 97.16. As a result of the study, the authors stated that dental implants can be applied to head and neck cancer patients as long as the risk factors are taken into consideration. In another study, Khan et al., where they examine the success of implants placed in lower jaw patients who had radiotherapy. They evaluated 73 patients who had radiotherapy, 316 implants with an average of 50 grays applied. They stated that success rate was 72% in irritated bone and 95% in non-radiated bone. They also attributed implant losses to radiation-induced fibrosis and hypoxia. In another study by Sammartino, they stated that implants in mandible were more successful than those in maxilla. Those that received radiation below 50 grays compared to those with higher radiation. And those that were performed up to 1 year after radiotherapy were more successful than those that were performed 1 year later. In one meta-analysis, 1,003 articles were scanned and 10 of them were selected. The authors evaluated the success difference between immediate and delayed placement of implants and the effect of radiotherapy on immediately placed implants. This article shows the importance of dental screening and elimination of fossio infection before radiotherapy to reduce the risk of osteoradionecrosis in patients with periodontal disease. It has been emphasized that the survival rate of dental implants placed during ablative surgery in head and neck cancer patients is low. Factors associated with implant failure include peri-implantitis, inadequate soft and hard tissue, muscle dysfunction, and xerostomia. Implant success in grafted tissues was reported that 60.32%. The cause of peri-implantitis is vascular obliteration due to radiotherapy, hypoxia, and decreased blood supply to gingival tissues. In a review I prepared with my colleagues, of which I was the lead author, we concluded that the safe time for implants placement is after radiotherapy between 6 to 8 months and before radiotherapy less than 14 days, because except this timetable, risk factors such as delayed wound healing, osteoradionecrosis, radiation risk, and unsuccessful osseointegration may occur. Protection from osteoradionecrosis during implant placement procedure. What are these? Pentaclavinanet and tocopherol recommended was used, maybe used. Containing nidosolone as a vasodilator, causing hypoxia. Prophylaxis antibiotics, local anesthesia, preferably without vasoconstrictor, minimal dental trauma, appropriate flap design, suitable RPM while we inserting implants and preparing implant bed, sufficient cooling, primary closure, proper periodontal health, and additional systemic diseases should be under control, and pay attention to the loading time. Conclusion. As a result, dental implant applications should not be avoided in order to improve the quality of life of head and neck cancer patients who have been and will be treated with radiation therapy. But the risk factors should be evaluated as much as possible, and patient-specific treatment methods should be used. Thanks for your patience. Thank you.
Dr. Ankita, could you unmute your microphone?
Yes, sir. Thank you, ma'am, for the wonderful session. Now, we would like to proceed with the 7th session of the day.
Dr. Ankita, anybody want to ask any question? They can ask question to Dr. Epson. Just we are giving for some time for question answer. Then we'll
Yes.
move on to the next.
Hi. Hello. Yeah, I had it. So, in patients who have undergone a fibula free flap reconstruction, do you do a primary immediate loading of the fibula, or do you wait for a year and then do it? Especially those patients in which mandible has been removed, they would be T4A disease patients.
Sorry, I couldn't hear.
So, in patients who have undergone a free fibula reconstruction and you would want a dental rehab at the same time, so would you do it with the fibula graft or would you do it later after the radiation has completed?
Simultaneous with surgery, we prefer. Because multiple surgery is needed when we wait, and then we preparing flap, we insert implants at the same time.
Okay.
Thank you.
Any more questions from the attendees?
Yeah, also another one question. When do you load these patients who have undergone radiation? Suppose you place the implants before the radiation and after the radiation therapy has been completed. When do you load these implants?
You mean when we insert implants
No, insertion has
after
been done.
radiotherapy?
So suppose you have inserted the implants before the radiation therapy, the patient receives radiation therapy after that.
Generally before radiation therapy, and we
The prosthetic loading, when does that, how much time duration do you give? The prosthetic loading.
prosthetic loading is recommended in the after 6 months time, because the loading is the factor, excessive loading is the another factor of osteoarterial necrosis, you see, and we generally complete the whole prothesis and implant supported prothesis before the radiation therapy. First, we the patients consult before radiotherapy to our colleagues, and we prepare the treatment schedule, and we also prefer all dental procedures before radiotherapy.
Okay, thank you.
Thank you.
Thanks, Dr. Epson, for joining us from Ankara, Turkey. And we are fortunate that we are, getting you in our third edition of International Oral Cancer Congress. So I thank from behalf of our whole organizing committee, and we keep on inviting you in other programs as well. So it's
Yes.
we are very thankful for joining us, and we are hoping that you would be joining in our another program called Pink Dental Congress. We got, I think, confirmation from your side.
Thank you.
Mm.
I appreciate. I honor.
Yeah.
Thank
So
you.
over to you, Dr. Ankita, to take it forward from here.
Yes, sir. So we proceed with the seventh session of the day. I would like to introduce Dr. Bhushan Zade, sir. He completed his MBBS from Government Medical College, Nagpur, and after successfully completing rotational internship, he pursued higher studies in radiation and oncology from the prestigious Tata Memorial Hospital, Mumbai. During his residency, he received extensive training in high precision radiotherapy like IMRT, IGRT, stereotactic radiotherapy for brain tumor, and stereotactic ablasive body radiotherapy for lung and liver tumors. He learned neuro-oncology under the guidance of Dr. Rakesh Jalal, who is his mentor. He was also awarded University Topper in MD examination in year 2009 from Maharashtra University of Health Sciences, Nashik. He also completed DNB in Radiation and Oncology from Nat Board, Delhi. Then he joined Ruby Hall Clinic since 2010 as a consultant radiation oncologist, and he pioneered 4D CT based stereotactic ablative radiotherapy for lung and liver tumors in Ruby Hall Clinic. He also started perineal interstitial brachytherapy treatment for difficult female genital tract cancers And both these technically challenging modalities have yielded very impressive results so far. He has a keen interest in treatment of breast cancer, especially in extreme hypofractionation and cardiac sparing radiotherapy using deep inspiratory breath hold technique. Besides, he is principal investigator and co-investigator of various study protocols, and he has delivered and chaired scientific sessions in various national and international conferences. I request Sir to deliver a talk on the topic Recent Advances in Radiotherapy in Oral Cavity Cancers. Over to you, sir.
Hi, Dr. Ankita. Thank you so much for those kind words. Let me share my screen first. Okay.
Yes, it's visible.
Am I visible now?
Yeah, yes, visible.
Okay. Audible?
Yeah, you are audible.
Great. Great. Let me start with my presentation today. I would like to talk about SBRT and head and neck cancers. So, we talk about conventional radiation, which has got huge role in management of head and neck cancers in a definitive settings where surgery is not possible because of some reason. In an adjuvant setting where surgery is done and we see the histopath report, which shows some adverse features, and for that we need radiation therapy as an adjuvant treatment. And then we have a recurrent head and neck cancers where resurgery may not be possible. There also we do re-radiation with the help of high precision radiation, or sometimes resurgery is possible and then radiation comes as a re-radiation in an adjuvant setting. So there are multiple, and of course a palliation is the way forward when it comes to recurrent cancer patients where advanced chemotherapies are not possible because of a poor general condition of the patient. So radiation therapy in head and neck cancer has got multiple indications. And today, in particular, we're talking about a very advanced form of radiation, what we call SBRT. The long form is stereotactic body radiotherapy. Other terminology for the same is SABR, stereotactic ablative body radiotherapy. And we are going to see the use of this modern modality of radiation therapy in the management of head and neck cancer. So first, we must understand what is SBRT. So this is a radiotherapy in which a very high dose of radiation precisely deliver to any target in the body. So in a conventional radiotherapy, we give radiation for 5 to 6 weeks, sometimes 7 weeks. In SBRT, we don't use radiation for so many days or so many sessions. We use radiation high doses in few sessions, typically up to 5 sessions. Now, only 5 sessions of radiation we are giving. So imagine the dose per session what we are planning to give. Now, why SBRT in head and neck cancers? So first, high doses of radiation are given. So high doses of radiation, we assume that the dose effect relationship, so high doses of radiation will yield better results. High conformality. So when we do high doses of radiation, the doses has to be very focused to the target area. So when we use high conformal radiation, the side effects are less. But the problem is the volumes should be small to moderate. We cannot treat the entire head and neck area like we treat for CA tongue or CA oropharynx or CA buccal mucosa, CA alveolus. In a primary setting, we cannot include that much bigger volume in the SBRT field because the doses are higher. So when we do SBRT, it has to be done under strict image guidance. It has got a different radiobiology. It overcomes radio resistance. So sometimes a regular or conventional radiation therapy doesn't work because of some radio resistant tumor biology. So with this high doses, we overcome the radio resistance. It has got less toxicity and less overall treatment time. And it has got a proven efficacy in other sites cancers. So head and neck, now we are trying using SBRT, but SBRT for brain, spine, lung, liver is highly proven efficacious treatment modality. So ultimately, what is our aim? Improving overall patient's quality of life, which really matters in any oncological management principles. So coming to radiotherapy in head and neck cancers. So as we all know, whoever deals with head and neck malignancy knows importance of radiotherapy in particular. So it has got a proven efficacy with huge data, tons and tons of data are available when it comes to management of head and neck cancer with radiotherapy. There are enough guidelines available in different settings like definitive, adjuvant, palliative. Improving side effect profile with modern technology has been cornerstone of last 20-30 years of research. Increasing indications in organ preservation settings in which we try and avoid surgery when surgery gets morbid, like oral tongue going into the base tongue or reaching the base tongue, the surgery becomes morbid. There we try to do chemoradiation, or sometimes buccal mucosa or cancer going into intratemporal fossa where surgery, craniofacial surgery becomes too extensive and too morbid. There we try and give radiation therapy with chemotherapy and avoid avoid surgery, preserving the organ function. But if there is a residual, definitely surgery is needed. But this conventional modality and fractionated radiotherapy has some limitations. What are the limitations? 6 to 7 weeks of radiotherapy can sometimes be prohibitive. A poor general condition patient may not be able to reach hospital for 7 consecutive weeks. Higher volumes, higher toxicity. So there are advantages and some disadvantages of this conventionally fractionated 6 to 7 weeks of radiotherapy. Now, when we use SBRT in head and neck cancer routinely, sometimes we have a gross disease, very conformal, nodal or primary. So we do the entire head and neck region radiation for 50 grays around, and then 20 gray boost we can consider with the help of SBRT. Sometimes gross disease is very close to critical normal structures, like in the CA nasopharynx has got proximity to spinal cord, or sometimes CA oropharynx going into posterior pharyngeal wall is very close to spinal cord. So these are the areas where high doses of radiation may cause adverse effect to the spinal cord or to the critical structures which are close to the tumor. Recurrent and second primary in a previously radiated volume. This is very, very important, this third line. So we have used, just imagine, we have used say 3-4 years back when the patient was presented primarily with oral cavity cancer. Patient underwent surgery, patient underwent radiation, and now he is cured for 3-4 years. Now there is a recurrence. Now recurrence, yes, if it is operable, patient undergoes surgery, but the recurrence unfortunately is not operable. So what is the treatment there? We do re-radiation, but in the re-radiation, the entire volume has already been radiated in past. So the acceptance of radiation or tolerance of radiation is less. In that case, we can use SBRT and treat these lesions with a curative intent. Now, what is the rationale in the re-radiation setting? So as our previous speakers also highlighted, 50% of these tumors are recurrences are loco-regional, and 15% present with a second primary tumor. Unfortunately, only minority of head and neck cancer patients with loco-regional recurrences or a second primary tumor are resectable. So majority are unresectable. Therefore, these patients either end up receiving some systemic therapy with palliative intent, or they are just sent to best supportive care without any definitive treatment. So to improve local control in this patient, re-radiation is kind of an important modality of treatment. And then In re-radiation, if we typically give that long course radiation of 6 to 7 weeks, again, patient may not turn up because they are already recurrent patients, may not be fit for long course radiation. So there, SBRT comes in a big way. So what is the data in a previously irradiated head and neck cancers? So there are multiple trials and retrospective analysis. Of course, there is no randomized trial because it's not possible in this particular scenario. So this is a retrospective analysis of prospectively maintained database. So very well kind of a maintained data set. 25 patients with median age of around 64 years, 70 gray of previous radiation. Most common site of recurrence is tumor bed and median volume was around 30 cc. Now the goal of SBRT was with a curative intent in most of the patients and a palliative intent for around 20% of patients. And concurrent cetuximab was used. So what we could see from this data, we can see overall survival at 1 year is almost 40%, at 2 years 20%. So for with a curative intent patient. So SBRT can be a safe and viable treatment option in head and neck re-radiation with low rates of severe toxicities, because toxicities are very important when we talk about re-radiation. Now, various case series, retrospective analysis. So to sum it up, the systematic review and a practical consideration of stereotactic body radiotherapy in treatment of head and neck cancers has been published a few years back. And of course, you can ignore the busy slide, but what you can take home is like number of SBRT patients, like 54, 50, 60. So not a very small number, not a very big number, a decent number patients has been enrolled. And if you see the study quality, good quality studies, fair. So may not be a randomized evidence, but a good quality evidence to support the fact of SBRT in a recurrent setting. And then few of those studies, like what table I showed, if I take some good studies like phase 1 studies, those escalation studies, so of 25 patients treated with 5 dose trials, like up to small doses to higher doses of radiation. The highest was 44 getting 5 fractions in 2 weeks. And there was no grade 3 dose limiting toxicity. So what this phase 1 study tells us that we can give up to 40 to 44 gray of radiation in 5 fractions without much of a dose limiting toxicities. So this is a very encouraging data from this phase 1 study. Then we go to phase 2 studies. These are the phase 2 studies of SBRT in recurrent head and neck cancers. Almost 110 patients with recurrent head and neck cancers. Cetuximab was given concurrently. Again, doses are very similar, 40 to 44 gray, 5 to 6 fractions, and overall survival was 10 to 11 months, and 1 year survival was almost 40 to 47%, and very low rates of grade 3 acute and late toxicity. So again, the encouraging data shows the SBRT is feasible, highest for conformed modality of radiotherapy in a recurrent re-radiation settings. Now, retrospective studies, median dose 30 gray in 5 fractions, again very similar doses. 1 year survival of almost 50%, 2 year survival almost 25%. So again, even these retrospective studies are telling us that we have enough evidence as a for SBRT in head and neck cancer when these are indicated. So to summarize, we have to accept that this is a rare situation or unique situation. We cannot have a phase 3 randomized data to prove SBRT versus surgery or versus any other modality. But there are enough phase 2 and large collaborative observational studies that indicate role of SBRT in light of few other treatment options like surgery or chemotherapy or immunotherapy. Properly designed phase 3 trial is warranted to explore role of SBRT in head and neck cancer. Probably in future we will get data in a very robust manner. Now, when we do re-radiation, so we must understand the patient has already received significant dose of radiation, and we are again giving radiation, which is a significant dose in the same area. So the organ at risk should be taken care of. And what is one of the most important organ at risk is carotid, because carotid is very close to tumor per primary or sometimes the node which is very close to the carotid. So when we treat these areas, we should be very careful that the dose max of carotid arteries should be less than 34 gray, and carotid invasion more than 180 gray should, by the tumor found to be a significant association for the carotid blowout syndrome. And in a head and neck oncology practice, we all know how fatal the carotid blowout syndrome could be. So we should be very careful in planning radiotherapy in a re-radiation setting using SBRT technology, and taking care of this fatal complications not to happen because of our poor planning. So these are the practical consideration of implementation SBRT. More than 2 years between time between first treatment and the re-radiation, but certainly more than 6 months. Volume should be less than 50 cc, ideal volume around 30 cc. Doses 30 to 40 gray in 5 fraction. Image guidance is must, and 2 to 3 millimeter margins are acceptable. So what are future directions in SBRT in head and neck re-radiation? So introduction of immunotherapy targeting immune system. So what is happening? The immunotherapy is boosting our own immunity to fight against the cancer cells. And addition of SBRT improves the antigenicity of cancer cells so that the immunotherapy works in a better way. So it's a synergistic mechanism coming in a big way in head and neck or in other cancers also. Then there are ongoing studies, SBRT with pembrolizumab in locoregional recurrent head and neck cancers, and again proton-based SBRT with nivolumab. So these are ongoing studies which are exploring role of immunotherapy along with SBRT in head and neck re-radiation setting. So we conclude, SBRT is a feasible treatment option in recurrent head and neck cancers. It's difficult to recommend a standard dose fractionation, but 35 to 40 gray in 5 fraction looks very standard. Careful about carotid blowout syndrome and other organ at risk, and phase 3 trial is what is needed in the future. Now, sometimes we wonder that something which is very effective in a re-radiation setting can be effective in a primary setting also. But as we know, the primary setting, fractionated radiation for 5 to 6 or 7 weeks is the standard of care. But there can be a very special situation that there is a primary disease which has to be addressed in a 6 to 7 weeks of radiation, but patient is just not willing to come for that time frame, or patient is very frail, elderly, multiple comorbidities. Patient is staying very far from the radiation facility and just not possible for that patient to come for this time frame. So in this special situation, we can think of SBRT for de novo cancers also. And what data suggests? Early glottic cancers. Of course, this is not a standard oral cavity cancer, which probably you guys are more interested in, being a dental fraternity. But it's a head and neck cancers, and extrapolation of one side to other is possible. So the data is available for early glottic cancer, which shows that in early glottic cancer, hypofractionation like 8.5 gray per fraction in 5 fraction can be equally effective and curative with very acceptable and less toxicity. So there is a systemic review and meta-analysis, 9 studies, 2 prospective, 7 retrospective in head and neck cancers with almost 150 patients. And they found that the doses in a stereotactic manner are effective. However, if you see the different subsites, like larynx is most common subsite, and the different doses and SBRT protocols, the biological equivalent doses, and cure rates. 1 year survival cure rate is almost 90% with 2 year 80 and 3 year 73%. And overall survival almost 75 to 50% once 1 to 3 years. So in a select group of patients where the standard radiotherapy may not be possible, you can always think of SBRT even in a primary setting. However, I must convey that I am not proposing SBRT as a standard of care in primary head and neck cancer. I'm just trying to impress that this is a modality where you can exploit the lesser duration of treatment in a situation where the protracted regimen of 6 to 7 weeks is not possible genuinely. So overall low toxicity profile. So in a de novo and recurrent settings, what are the potential for future development? So SBRT acts via different biological mechanism, so contributing to enhanced biological result. And the large body of evidence suggests that the distinct mechanism involve vascular collapse because we are using high doses of radiation, upregulation of immunomodulatory surface molecules, and other effects of tumor microenvironment. There are no active randomized trials on this platform. However, in future, there may be. And in a de novo situation also, it has shown to be safe and effective, providing local regional control and acceptable toxicity. However, there is a gap in the evidence and practical application which needs to be addressed in multiple aspects, including protocols, margin, those fractionation constraints. So one has to be very judiciously using this technology so that patient benefits maximum with least side effect. So yes, SBRT is improving in all the subsites of malignancy, and head and neck cancer is no exception to it. And more data is needed to establish its role in the head and neck cancer, re-radiation and primary setting. Thank you so much for patient listening.
Thanks, Dr. Bhushan. Even if you are you came today, landed today itself, you are from outside India. Where you been there?
I was in Muscat.
Actually,
3 days.
Today itself you have landed, and it's when
Yeah,
you
today morning, and it was like complete night. I was traveling from Muscat to Mumbai, Mumbai to Pune, and when you had called, I was just unpacking my bags.
Great. So nice, you still spared some time, and you're when
No
you
problem, no
yeah.
problem.
So and from audience, any question you want to ask from Dr. Bhushan? Anything related to radiotherapy in oral cancer?
Anything may not be a topic. Anything
Yeah,
in
yeah.
general about radiation therapy.
Anything, any query you have when you are referring your patient for radiotherapy. So if you have any query, you can ask very right away. Dr. Bhushan is an experienced radiotherapist with us. So it's better if you utilize the opportunity to ask questions. So no questions so far, Dr. Bhushan. We are very
No
grateful
issues.
that you still spare your time and join us.
No. My pleasure.
Maybe if you
No
have,
issues.
I won't say that you stay with us because you just came back,
Yeah,
so you just retired. What I'm saying that anybody if they have any question, they can email to us and we'll forward it to Dr. Bhushan for further.
That's
queries.
great. That's great. Yeah.
So with your permission, Dr. Bhushan, we are moving to our next speaker.
Yes.
Yeah.
Please.
So, thanks. Dr. Ankita, over to you.
Yes, sir. So we are moving with the eighth session by Dr. Kende Kazim. So I'm going to introduce Dr. Kende Kazim Konmodi, sir. He completed his Bachelor's of Dental Surgery in August 2016 from University of Ibadan, Nigeria, and completed his postgraduate diploma in education in December 2018 at Usmanu Danfodia University, Nigeria. In 2020, Dr. Kehinde also completed postgraduate diploma in peace studies and conflict resolution from National Open University of Nigeria. And he has also pursued Masters of Public Health with distinction from City University, UK. He is also practicing as an adjunct associate professor and has also been given the title of Director of International Engagement at Faculty of Dentistry, University of Puthi-Sastra, Phnom Penh, Cambodia. I request Sir to deliver a talk on the topic Synthesized Evidence on Oral Cancer, Plentiful or Scarce. Over to you, sir.
Thank you very much, Dr. Ankita, for the introduction. And good evening, everybody. I'll be presenting on synthesized evidence on oral cancer, plentiful or scarce. So I'm sharing my screen. Can we see my screen?
That's coming. It's coming.
Okay.
Yes, it's visible. And
Yeah.
you are audible, sir. So you can
Okay.
move forward. Yeah.
So,
Start your presentation.
so synthesized evidence on oral cancer, plentiful or scarce. So I'll first start with the table of content. Synthesize the discussion of today. We talk about synthesized evidence, the definition and importance, talks about oral cancer, the definition of oral cancer and global burden, and also global oral cancer eradication, where we are, and the current volume of synthesized evidence on oral cancer globally, and also the need to develop capacity on oral cancer evidence synthesis. Then I conclude and answered questions. Synthesize evidence. First of all, I will first start with the definition of evidence synthesis, because evidence synthesis and synthesized evidence they are closely related. One is a process and the other one is will I say an output. So evidence synthesis, according to the Royal Society, refers to the process of bringing together information from a range of sources and disciplines to inform debates and decisions on specific issues. So based on the above definition of evidence synthesis, it implies that a synthesized evidence is an information obtained through evidence synthesis. So, and synthesized evidence of different types. They include systematic reviews, narrative reviews, scoping reviews, rapid reviews, umbrella reviews, meta-analysis. A systematic review is a form of review. There is a form of structured literature review, which involves addressing a focused research question, which is usually narrow sometimes, and also it looks at gathering evidence to arrive at a conclusion. So, and it involves quality appraisals of literature and the likes. So that's what systematic review is about. Narrative review, it also looks at a very broad question, but it's not a structured literature review. Sometimes it may involve cherry picking of literatures and the like. So narrative review is a form of unstructured literature review and is not as reliable as structured literature reviews. Scoping review is a form of structured literature review, which involves mapping of evidence to look at the existing evidence and the existing gaps in the body of literature concerning a topic area. And scoping review usually address a broad question. So, and it's also systematic. And in scoping review, it is not necessary to do quality appraisals. What the focus of scoping review is to just provide information on what is out there and what is lacking out there. A rapid review a rapid review can be a form of systematic review, but it's done rapidly, like with fewer databases, and it's done due to the urgency. It's just, for instance, I'll give an example, like during the COVID-19 era, if maybe there is need to conclude about, let's say let's say from period of maybe, let's say, okay, we can say, let's say oral and maxillofacial manifestations of COVID-19. In such situation, because such finding is very urgent, so a rapid review is being conducted. It doesn't need to be done extensively like systematic review. So that's how rapid review is. And also umbrella review. Umbrella review is also known as systematic review of systematic reviews. An umbrella review is very, very important because there are possibilities that a systematic review on the same topic can be published the same year, and both of them may have different findings. For instance, systematic review here may look at PubMed, Scopus, Web of Science. Meanwhile, systematic review B may look at African Journals Online, look at maybe Web of Science, look at APA Psych Info, CINAHL, and the like. So because there may be the literatures in systematic review A may not be covered in systematic review B, and the ones in systematic review B may not be covered in systematic review A. So there may be difference in some findings, maybe like I don't want to use the word divergence. So as a result of that, umbrella review is usually recommended so that it will review all existing systematic reviews on that topic and come at a conclusion which is more robust and more reliable. And also meta-analysis. Meta-analysis is the form of quantitative systematic review which involves pooling of data to arrive at a mean value. So it's a form of quantitative data synthesis for in systematic reviews, and quite a number of studies have been done that is purely meta-analysis. So it has some overlapping borderlines though, but that's how in short term meta-analysis, that's how it is. So I will talk about the importance too, unlike other forms of evidence, which includes cross-sectional studies, before and after studies, case control studies, cohort studies, and randomized control trials. A synthesized evidence is the most comprehensive one. And also in a study by Murad et al. In 2016, in terms of hierarchy, that is reliability and, will I say, authoritativeness, synthesized evidence ranks atop other forms of evidence, while letter to editor commentaries are in the base, editorials, then cross-sectional studies, then after that case control studies, then after that cohort studies, and then randomized control trials, then atop is systematic reviews and meta-analysis and the likes. So it's more reliable because compared to letter to editors does not have a methodology, for instance, so it does not follow through a rigorous process. For instance, cross-sectional study is also a cross-section, so it does not look at, like, let's say, the effect of maybe an intervention from a longitudinal perspective. So those are the obvious limitations of those studies, and it's just on probably a delimited population. Like, let's say it's focused on a particular population and that's it. It doesn't look at other places. Like, for instance, a study conducted, let's say, in England is only focused on England. One cannot use it to generalize for other parts of the world. For instance, the prevalence of, let's say, tobacco use in England, one cannot use that prevalence to use it for generalization in maybe, let's say, South Africa or in Kenya or in India or Sri Lanka, because they are different population groups. So those are the limitations of such kind of studies. So however, systematic review can get data, collect data, synthesize data from different parts of the world, like big data, maybe if it's a global systematic review. So it's more reliable, it's more authoritative, and it's more acceptable all over the world. So synthesized evidence is the most preferred evidence for evidence-based research, practice, and policy making. In policy making, in policy research, in policy analysis, in anything related to policy, systematic review is more preferred because it's more robust, it's more comprehensive, it looks at the depth and breadth of the problem and gives a more robust solutions compared to cross-sectional studies, randomized control trials, case controls, this and the likes. So that's the importance of synthesized evidence. Now let's talk about oral cancer, the definition and global burden. Oral cancer is a malignant neoplasia of the mouth, lip, and oropharynx. However, the definition of oral cancer has been disputed over the years. Some will say oral cancer is the cancer of the oral cavity. Some will say it's the cancer of the oral. When I mean oral cavity, I'm referring to the mouth. Some will say it involves both the oral cavity and the lip. Some will say it does not include oropharynx. Some will say it includes oropharynx. So it has been disputed. So in such situation, to come to a consensus in such situation, well, a DEFI study can be conducted, and also a systematic review can also be done to look at the generalized, the most common definitions for oral cancer all over the world and use it to arrive at a consensus. So that's one of the benefits of systematic review, evidence synthesis. So that's the definition of oral cancer. And now also, in addition to that, quite a lot of countries prefer this definition. For instance, in Scotland, in the Scotland Cancer isn't cancer statistics or cancer registry now. This is their definition of for classification for oral cancer, cancer involving the mouth, lip, and or oropharynx. And also, in continuation to what we've been talking about, the burden of oral cancer is enormous. And in the year 2020 alone, about 476,125 people were newly diagnosed of the disease. This is very enormous. Almost half of a million of people were diagnosed of oral cancer in just 1 year. And to be realistically speaking, this population is even underreported because a lot of people are having oral cancer that they don't go to hospital, that due to medical pluralism. They go to seek alternative medical care practitioners for treatment. So that is possibility that this burden is highly underreported. And also in the same year, 2020, 225,900 people died of oral cancer. I can say that this is also underreported because I'm a member of the Global Burden of Disease Study Group in University of Washington. And in some of our studies, we found out that quite a lot of countries across the world have, the data is not so reliable because of underreportage. So it's very obvious that the number of people that die of oral cancer every year can be double of that. It shouldn't be surprising that can be double of that due to underreportage of diseases across the world, especially in the low and middle income countries. So, and over the years, several public health efforts. Now I want to talk about where we are concerning oral cancer eradication. Over the years, several public health efforts have been put in place to tackle the global oral cancer burden. For instance, we have the ENHANCE project, which is being done, for instance, in Europe, for instance. That one, I think ENHANCE, yeah. University of Glasgow is part of the collaborating institutions. We have WHO, all right, collaborating centers across the world. We have Alliance for Organizations Fighting Tobacco. We have tobacco regulatory policies. We have HPV vaccination programs and the likes everywhere in the world. We have so many institutions trying their best in terms of to eradicate global oral cancer. So over the years, there has been a lot of public health efforts that have been put in place to tackle the global oral cancer burden. Unfortunately, these efforts have not effectively eradicated global oral cancer disease burden, and that's sad. Instead of being completely eradicated, there has been a steady increase in the burden. Despite all the efforts that have been put in place all over the world to tackle the global burden of oral cancer, it is so unfortunate that the burden of oral cancer keeps increasing every year. It keeps increasing every year. And an analytical comparison of the historical trends in the rate of oral cancer comparing 1990 to 2017, it indicates that the global age standardized incidence rate and global age standardized mortality rate of oral cancer increased by one-fold between 1990 and 2017. It has doubled. The prevalence in 1990 and in 2017, it has really changed. It has doubled. So we now have an increased burden of oral cancer. The above findings in the analytic comparison shows that the global oral cancer situation keeps getting worse every day. And this is a call to us as oral cancer researcher, policy makers, and practitioners to prioritize on more public health efforts to ensure that this burden is brought down to the barest minimum. And what is the current volume of synthesized evidence on oral cancer? Several studies have been conducted on oral cancer, but they are not so much compared to other health-related topic areas like malaria, HIV, hepatitis, and even other forms of cancers as well, like for instance, breast cancer or cervical cancer. The records on PubMed database can give a reflection of the volume of these studies. So as to buttress this point, I did a PubMed, a scoping search, not so extensive, just to give a reflection of the situation we are in as regards current volume of synthesized evidence on oral cancer. And as of 3rd of February 2024, a PubMed-based search of literature containing the term oral cancer. I just used the word oral cancer. I did not include oral squamous cell carcinoma because it may not be necessary though, because this search is just to give a, will I say, for a prima facie evaluation of the current situation. So it was a search for title, to search for literatures having oral cancer in their title. And from the PubMed search, using the term oral cancer, title-based search now, it yielded only 8,151 hits. And we are talking of a population, global population of over 700, over 7 billion people and over 200 countries and territories. So oral cancer, and for the whole world, we are on PubMed, which is one of the most recognized database for health science literature. That's PubMed. It yielded only 8,151 hits. So after that, this is quite low compared to malaria, HIV, hepatitis search. However, the addition of the search term review, because review is usually the most common term used for synthesized evidence in their title, like a systematic review, a scoping review, umbrella review. So I put it, and also based on the reporting guidelines for several literatures of several studies, it's recommended that the study design is stated in the title, and review is a common word in synthesized evidence research design. So I put the word review to search using the combination of oral cancer and review. And the combination yielded only 312 hits. This is very, very low. So far in the whole world on PubMed, if we search, dig out literatures that have oral cancer and review in their titles, there are only 312 as at yesterday. So it shows that the evidence is very, very scanty. It is not plentiful at all. So let's continue. Based on the outputs of this PubMed search, it can be asserted that the current volume of synthesized evidence on oral cancer is very low. Unfortunately, other forms of evidence alone is not sufficient to drive the global efforts towards oral cancer eradication, and this is due to the intricate characteristics of these other evidences, which include their limited scope and limited robustness. For instance, a study looking at, let's say, knowledge, attitude, and practices concerning, let's say, oral cancer risk factors in Kerala, India. The study, you cannot use the findings to generalize for maybe Goa, for instance, or to generalize for Mumbai or for New Delhi, or to generalize for Colombo or for Peradeniya in Sri Lanka. So those are the limitations of empirical research, because they have limited scope. And also in terms of robustness, for instance, maybe there's a cross-sectional study may survey maybe 300 people, and 300 people alone compared to the world population or compared to the population of that country. Sometimes it will be difficult to generalize based on that findings. So it's not so robust, unlike systematic review that we put evidence from different samples and arrive at a more logical conclusion. I mean a more robust conclusion. So that's the limitations of other forms of research evidence. So based on these observations, it can also be asserted that many countries of the world do not have up to 10 oral cancer researchers who have proficiency in oral cancer evidence synthesis. Based on the total number of hits that we mentioned, 312 hits, if we divide 312 hits by the total number of countries we have in the world, we see that most countries do not have up to 10 oral cancer researchers who have proficiency in oral cancer evidence synthesis research, particularly systematic reviews and scoping reviews. So there is a need for capacity development on oral cancer evidence synthesis to provide robust and more reliable evidences needed for oral cancer eradication at the national, regional, and global levels. For instance, if we notice from what our previous presenters have discussed, we notice that many of the evidence they are referring to was systematic reviews. The systematic review is more reliable than randomized controlled trials and different other stuff because systematic review is more robust. However, those reviews are scanty. So we need more experts, oral cancer researchers across the world to produce more synthesized evidence that will inform clinical practice, public health practice, and in fact, clinical and public health research and also policy concerning oral cancer. And how can the capacity of oral cancer researchers be developed on this research type? This can be achieved through trainings and mentorships. Because evidence synthesis research, it's a very rigorous research. It's not something that's so easy. It's very, very demanding. It requires perseverance. It requires high skill. So as a result, it's cannot be achieved through one-off trainings or maybe one-day mentorship. It requires persistent, intentional, and perpetual trainings and mentorship. So it's very, very important. So because workshop alone, seminar alone, we cannot use it to acquire adequate skills on evidence synthesis research. It requires more frequent trainings. I mean, one seminar alone, one workshop alone one cannot learn systematic review, for instance, in just one workshop. It requires repetitive training, repeated training, persistent training, and also mentorship. So building proficiencies on evidence synthesis research in the evidence synthesis research is not a one-day event. It requires persistent efforts. Therefore, persistent and intentional mentorships and regular trainings are very crucial. So it's very, very important. If an expert in oral cancer evidence synthesis mentors or trains more oral cancer researchers, they'll be able to be independent to produce more produce more evidence, synthesized evidence, to train and mentor others. With that, in form of, let's say, geometric progression, in no time we have enough adequate number of experts all over the world to be able to generate synthesized evidence needed for oral cancer, public health research, clinical practice, and also policy. So conclusion, synthesized evidence provides strategic and evidence-based solutions needed for the global eradication of the current notorious oral cancer burden that is ravaging our world. As scientists, policymakers, and practitioners, we need to seriously consider capacity development in evidence synthesis research, as this will ultimately improve our capacity in tackling the global oral cancer problem we have in our present day. And these are my references. Thank you very much for listening.
Thanks, Dr. Kehinde, for your nice presentation. I'm just inviting the questions from the audience. Any questions from the audience? All attendees, they can ask questions. So, Dr. Kehinde, you are joining from which city in UP? Right now?
Middlesbrough.
Come again?
Middlesbrough. Middlesbrough.
I thought Middlesbrough. Oh, good. And you are from Teesside University, I think.
Yes, yes.
Any question from the attendees? There is no any question. Our next speaker is Dr. Vishal Rao. I have announced in the morning itself that he is a scheduled meeting with Health Minister. So he couldn't, means the meeting is rescheduled in the second half, though it was planned in the morning. So due to this, he is not available with us with his presentation. So our next speaker is Dr. Abhishek Kandwal. He is talking on behalf of Dr. Sunil Saini. He is joining in a short while. So we are waiting for him. As soon as he joins, we'll start our next session. By the time, if you have any question, you can ask Dr. Kehinde or anybody who have any doubt or anybody who want to share anything regarding the as an organizing committee. I can address their any query if you want related to anything. After that, we have our next moderator, Dr. Shantala Arun Kumar. Dr. Shantala is joining and she will be taking it forward now onwards. So Dr. Shantala,
Yes, sir.
in place of Dr. Sunil Saini, Dr. Abhishek Kandwal will be, giving the presentation. And
Yes.
Dr. Vishal Roy is not available, so his talk is scheduled at 3:10. But I have requested him to join by 3 o'clock, by 3:35. So we have just 10, 12 minutes. If we can utilize it to any, if anybody want to share anything, any research which is done in oral cancer or any discussion they want to. Otherwise, we'll pause it for 10 minutes. If people can take a small break of 10 minutes, they can take snacks or whatever, they can refresh and they can join again at around 3 p.m. Thank you.
Yes. It gives me an immense pleasure to introduce. It gives me an immense pleasure to introduce Dr. Abhishek Kandwal. 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 It's an immense pleasure to introduce Dr. Abhishek Kandwal.
Dr. Shantala, are you there? Could you please unmute?
Yes, sir. I'm there, sir.
Yeah, so Dr. Shantala, I think Dr. Abhishek has just joined in,
Yes,
and
sir.
I have made, he just joined in, and then might he like to be disconnected. I think he would be joining in a short while. So as soon as he joins, no, I will just
Yes.
make him a co-host, and then when he's visible on his video, we can introduce him and take it forward.
Yes, sir.
Dr. Shantala, are you working in your office?
Yes, sir. I mean,
Evening,
yeah,
yeah.
sir. Yes, sir. It's a PG room.
Acha, acha,
Actually,
okay.
there was
Hmm.
a lot of disturbance at my, I mean, at
Mm-hmm.
home, sir.
Okay.
Around the construction is going on.
Mm-hmm.
So I've come to the department.
And department has agreed your presence, and they open their premises for
Yes.
you.
PG room is always open, sir, till
Okay.
11 o'clock.
Okay. So, Dr. Shantala, there is the one announcement. Dr. Abhishek is joining in a short while, within 2 to 5 minutes. There is some network issue happened. Actually, he logged in 5-10 minutes back. At 3 o'clock, he logged in, but somehow he's not able to connect. So he's switching some another network.
Yes.
So he would be joining in another 2-3 minutes, not more than that, and then we will introduce him and we will take it further. Thank you. I'm seeing Dr. Inder Kumar Pandit. I think he is a principal of a medical college in Yamunanagar Dental College, and he was saying that he is having some, some departments who is starting as a oral cancer department in his college. Dr. Inder, am I audible to you? I think Dr. Abhishek has joined from some another device. Wait to Dr. Abhi, which I am looking at the.
Hello.
Yes.
Am I audible? Yeah.
Yeah, you are
Finally.
audible. Yeah, yeah.
So I would really apologize for the delay. There were a lot of internet issues. I'll just start parallelly with my presentation.
Meanwhile, Dr. Shantala, you just introduced Dr. Abhishek.
Yes, yes, sir. It gives me an immense pleasure to introduce today's speaker, Dr. Abhishek Kandwal. Sir is a professor and head, Department of Dental Surgery, Cancer Research Institute, Himalayan Institute of Medical Sciences, Swami Rama Himalayan University, Uttarakhand, India. He has done PhD in oncological sciences and is a gold medalist in MDS, periodontology and oral implantology. He has done fellowship from National Cancer Institute, Tokyo, Japan, with a specific focus on head and neck cancer patients, supportive oral care, and rehabilitation. He is a co-investigator in ICMR-led project for strengthening palliative care services in cancer in North India. He has done certification in Essentials of Palliative Care by Indian Association of Palliative Care. He is a core panel member in development of revised international guidelines on oral care and mucositis management in cancer patients by Multinational Association of Supportive Care in Cancer. He is specialized in supportive oral care and oral dental rehabilitation in cancer patients with specific interest in head and neck cancer patients for past 11 years. He is actively involved in research in oral toxicities of cancer therapies and is a part of various research groups for mucositis under international collaboration of Multinational Association of Supportive Care in Cancer. He has national and international publications specific to supportive oral cancer care and oral toxicities management in indexed journals. Welcome you, sir, and now it is over to you, sir.
Thank you so much for the kind introduction, and I would apologize for the delay. We will start with today's topic on the count of World Cancer Day. I hope I'm audible.
Yes, sir,
Yes,
you are
sir.
audible.
Yes. Okay. So on the account of World Cancer Day, today I would be discussing and sharing my views on supportive care in head and neck oncology. Where do we stand and what is the needed here in India, and how we could contribute to give a good quality of life to our patients. So when we talk about head and neck cancer patient, nowadays the treatment modality have shifted from just the patient specific treatment to a holistic approach. So now the treatment has to be focused on patient centric care. The first point, which is the primary cancer treatment, that is your surgery, radiation, and chemotherapy, that is what treats the cancer. But we do have to take into account various other aspects, which include supportive and oral rehabilitative and palliative care, and mind, psychology, and spiritual aspects also. So, what was the need and what is the problem which led to the development of the supportive care needs for these patients? As you all of know, that Ioccon 2022 has established that oral cancer is the second most common in India and nearly accounts 5 times more incidence that compared to the world population. And this has increased their burden and causes a lot of complications, causing poor quality of life. So when we are talking about head and neck supportive care, we need to understand why we want to address it. First of all, the head and neck cancer patients, including the oral cancer patients, they have most challenging scenarios because a lot of the time we have to resect a lot of hard tissue structures, including maxilla, mandible. There is a lot of change in the drinking, swallowing, speaking ability of the patient, breathing ability of the patient, and this overall puts the patients into very poor phase of their life, causing lot of toxicities and leading to poor quality of life. At this kind of scenarios, we would focus these patients to get more supportive care so that quality of life is improved. In India, per se, when we are focusing, we would say that there is no population-specific guidelines still available for systematic approaches as to how do we give supportive care for these head and neck cancer patients. Very low awareness of the supportive care concept is there in India. People are working in isolation. Surgeons are doing oncosurgery, beautiful surgeries. Radiation oncology are giving the best treatment plans. Medical oncology giving the best cutting-edge technology, drugs they have. But all of this is scattered, and perhaps the supportive care is most of the time is neglected. So we see a lot of centers, they don't have a dental oncology expert as a part of their team. There is a lack of speech therapists, lack of psychologists, lack of nutrition expert, lack of physiotherapists, and we don't have any national schemes like Ioccon also still do not cover the supportive care aspects of cancer treatment. They do cover chemotherapy, radiotherapy, and surgery, but the supportive care is often not even on the papers for us to see, and hence all this would increase the load of the financial toxicity of the patients. When we talk about supportive care, we focus that supportive care not only relieves of the symptoms, it relieves the symptoms of cancer specific in nature. It get a better compliance to the patient because the patient develops a good rapport. He is more comfortable. They come more often. They relieve from the treatment related symptoms, toxicities of radiation therapy, chemotherapy, including mucositis, trismus, constipation. All of these are better addressed when supportive cares are there. And all of this would also contribute to better delivery of treatment. So when supportive care is initiated, all of this will come into play and help each other getting good quality of life in these patients. Now, when we are focusing on supportive care, let us take everything step by step. What kind of supportive care issues are there when the patient is getting surgery for that cancer? And what are the quality metrics which we are going to observe? So the first important part of related to surgery is prevention of surgical site infection. We call SSIs. So this SSI has to be better. For it, we need to have evidence-based guidelines and strong antibiotic prophylaxis policies at our centers. So our centers should be having a very good antibiotic policies, proper charting, proper cultures and everything, so that the surgical sites are not infected. And once they're not infected, much better supportive care could be initiated on the very first day only. During the perioperative pain scoring has to be charted. Strong protocol has to be there. Pre, intra, and post analgesic protocol has to be established. Use of opioids and non-opioids, fentanyl patches, um, morphine has to be done in a very systematic manner. There have been a lot of data, there have been a lot of protocols which are already there. We just need to follow this and prevent perioperative pain. When we talk about nutrition rehabilitation, especially after upper digestive tract surgery, what would be the metrics in this? What is the rate of oral feed after the fifth post operative day? So if the patient is getting into the oral feed after fifth day, how many patients are getting it? If it is more, then you have a good supportive protocol. If it is less, then we need to. If it is going less, it is better. If it is more days, the patient is taking time to get on the oral feed, we need to look into supportive care in terms of surgical interventions. Now let us see what about radiation chemotherapy. So here we are going to make sure that we do nutritional assessment before and during the radiation and chemotherapy appointments. Must, which is malnutrition, universal screening test, NRS 202, MNA, MST. These are standard nutrition assessment tools. And this tools has to be given to the patient on the very first day of the diagnosis of the cancer, and this has to be followed up. And as per the recommendations, must is a 5-point scale. We can find out how these patients are improving and how we can correct the nutrition. Now we have to talk about whether nutrition is enteral, parenteral support. For this, we don't have to think much. We have SPEN guidelines. We have to follow them. Prevention of RT swallowing issues. So because of radiation, there would be a lot of problem in patients getting swallowing and having food. So we need to have a good swallowing program. So these swallowing programs are practically not existent in most of the centers because they are working in isolation. So radiation team has to work in a close isolation with solution expert, which is a speech therapist, and psychiatrist and speech therapist has to be a part of this team. So when we all of it are including dentists are the part of this team, we have better supportive care when the patient is under chemo radiation therapy. Radiation induced pain. So pain control protocol has to be established. Background pain and breakthrough pain. I'm not going to detail of it because of the constraints of the time, but background pain is there all the time, and breakthrough pain is one when it breaks the barrier of analgesia. So we don't have to wait for the breakthrough pain. If we are anticipating is, we have to have proper protocol to give proper pain control for these patients. Another important part is the mucositis prevention and treatment protocols. So we have international bodies like I was lucky enough to be part of MAS, which is Multinational Association of Supportive Cancer Care for more than now 14 years, and International Society of Oral Oncology. So these have formulated guidelines from 2014, then 17, and now 20 only. We got a lot of paper published. These papers are as free of access. You could get into the Cancer Supportive Journal. You can Google it out. They have proper point to point as to what to do in these patients and how to do it. So we have evidence-based guidelines on it. I would recommend everybody to have a look on it. Then we have to go for the major infection during chemo or radiation therapy. So for this issue, the rate of major infection, microorganism profile of what kind of organisms we're having, and antibiotic resistance pattern is one of the metrics we have to follow to take care of this issue. Psychological distress, obviously psychological service has to be there and to be well initiated. When we are talking about supportive care now in palliative care setting, so for the palliative care setting, early approach in recurrent and metastatic cancer has to be seen. For this, quality of life status and satisfaction has to be evaluated for every patient. Rate of unplanned emergency visit has to be seen. If it is very high, perhaps we are not giving them proper counseling and not giving them proper tools, rate of death in hospice and home care. So if we have a rate of death in hospice home care compared to the house, if we can make patient more comfortable at home and comfortable hospice, it would depends on how well we are giving the supportive care and palliative patients. Now coming to avoiding active treatment and end life care. So when the patient um, is in the last phases of his life, nearly maybe 1 month of his life is left. So we would try not to give any active treatment for cancer therapy. We would just give symptomatic relief of in terms of pain, breathing, bed sores. So here the rate of new treatment last 3 months. If you have a very high rate of it, perhaps we are doing something wrong. Rate of systematic treatment the last month of the life has to be assessed. So we need to make patient comfortable, and our intent has to be pure palliative rather than definitive. Now, here we don't have much time, but should have to discuss about tracheostomy care, how to care for stoma, how to do suctioning at home, educate the patient, nasogastric tube, how to care for it, how to feed, how to clean it, and colostomy care. These all care has to be properly addressed for supportive care in headache and patient, because most of the time they will have these kinds of interventions done. Now, coming to the oral supportive care, there were a lot of research gaps, there were lack of trials, there was no evidence practically existing anywhere. So for that, Multinational Association of Supportive Cancer Care and International Association of Oral Oncology, they joined hand across the world centers and developed a dedicated clinical guidelines in 2014 and 22. We were a part of these guidelines in 2022, and all these are available. They have particularly how to manage mucositis, how to take care of oral mucosa, how to see oral xerostomia, what aids we can use, how do we bring the toxicities of oral toxicity of cancer. Everything is there. We can just follow it, as these are all evidence-based generated guidelines. So this is a paper which we got published, and right now it has more than 351 citations, and it is considered one of the landmark papers in management of oral mucositis. Now coming to this, we at our own center have developed a protocol. We call it supportive oral care protocol, and this protocol was one of a kind in our country. This kind of protocol didn't existed in a systematic manner anywhere, and we did a study in which we included almost most of the cancer centers of the country, and we took dental oncology expert, we took medical oncologists, radiation oncologists, and surgical oncologists, and we formulated a certain protocol. So this protocol was basically focusing on eliminating the oral foci of infection and focusing on palliative care needs, their quality of life, and rehabilitation in these patients. So this was published and available, and we saw that across most of the centers we got an agreement of 99.4%, and which all of them agreed of the 41 points we have in SOCP. So these was agreed, and we are following this protocol from 2013, and now it is nearly 11 years in existence, and we have reduced a lot of toxicities for us. We also initiated a randomized control trial, which got registered in CTRI also. It was basically on the supportive care needs only of patients. How can we make this protocol? So this protocol is basically at 3 levels: level 1, level 2, level 3. Level 1 is before you start treatment, level 2 is during the treatment of cancer, and level 3 is after completion of the treatment. So these levels of intervention, which is the most important point, the first day of diagnosis of cancer, the patient gets enrolled into this protocol, and he is in the protocol till he's there, till his last follow-up. So these are the various, I will not go into detail of it. It is all available online. We can look into it. There is a various level, various steps, what to do before radiation, after radiation, during radiation, how to manage mucositis, how to take care of xerostomia. Everything is there in detail. How to take care of palliative pain for these head and neck or specifically oral cancer patients. So these protocol, when was initiated, we saw a drastic improvement of OHIP 14 index, which is oral health impact profile, at 1 year. So they were drastically significantly reducing the load of oral disfigurement and this burden. And when we're talking about DMFT index, we saw that they were able to control this rapid progression of caries. As you know, most of the patients with radiation and chemotherapy would be having a lot of dental caries, specifically radiation caries, and we were able to control it in a very good manner. The economical burden, how much money patients spend on getting this supportive oral care. So we found that for the 1 year cost of the supportive oral care was even less than 10% the primary cancer cost. Though this was not included in Ioccon schemes, there are no dental insurance treatment coverage. So because on based off of this, we have sent a recommendation to government that these all supportive care needs should be included as a package for any head and neck cancer patient, uh, so that they can have a good quality of life. So this is all about frequency. Mostly they spend around 10 to 20,000 in a year. So for monthly, it is maybe less than 2 to 3,000 only. So when we're talking about infections or supportive care of oral cavity, we focus on eliminating the oral foci of infections. And this is done by doing the extractions required, the restorations we have to do, and giving a good oral prophylaxis. So these are all X-rays of OPGs of pre-treatment assessment. Every patient, before even they start their surgery, radiation or chemo, we have to get a dental baseline done. And any infected teeth, abscess teeth has to be removed, restored. Oral deep prophylaxis has to be done to eliminate sepsi foci. These are all various. We could see these patients will have very poor oral hygiene, a lot of caries and infections there. So next we would be focusing on prosthetic rehabilitation planning. The very first day only, the whole plan has to be decided at what kind of prosthetic rehabilitation has to be done. This has to be discussed with the patient. This has to be discussed with the oncosurgeon, because oncosurgeon is going to change the anatomy of your oral cavity. So that has to be in close correlation with them. Then we have to see if there are any maxillary defects that are going to come up. So for most of the carcinoma of maxilla, nasopharynx, a part of maxilla or the whole maxilla has to be removed. So for this, we need to have prosthetic rehabilitation obturators, and this has to be done before the surgery in consultation with oncosurgeon, which will decide the borders and the extent of these prostheses. So once the maxilla is removed with OT, at the same point of time, a surgical stent is placed, so the patient is not left with any opening in his mouth, and he can have better healing and good outcome after that. So if these kind of prostheses, what is the advantage? All of us would be knowing that nasal regurgitation would reduce, speech would increase, aesthetics are better, nutrition, healing, and the need of NG tubes is also reduced drastically when we give these kinds of prostheses immediately after or just after excision. Coming to this maxillary obturators challenges, we would see that there are a lot of people, we have to get the right maxilla or left maxilla done here. The patient got removed his left maxilla. And there is a video here. I don't know if it's going to play or not, but I'll just try. Okay. I hope the voice of patient is audible. So once we put this obturator, there would be closure of that gap, and the patient voice would be, aesthetics are good. Okay, so hopefully you were able to listen to this. I don't know whether it was or not. Let us go to the next slide. So these kind of maxillary defects are there, and we need to rehabilitate them. So this is a standard prosthetic parting of all these patients. So coming to the mandibular acquired effect, what we can do if the patient goes a commando operation, hemimedulectomy, if then the patient has deviated occlusion. We have specific jaw support exercises. We have mouth guards during surgery to prevent any kind of trauma. We have this mandibular guiding flange prosthesis to guide the patient into occlusion. So these all patients have hemimedulectomy done. We all restored them with, we gave them exercises. We gave them devices to exercise. They are spring kind of devices which can the patient can press and it opens up. And as per his requirement, he can put the pressure in. All these patients were given when the opening was sufficient. We gave them this flange prosthesis also. Coming to the mucositis, we all of us know about the grades of mucositis. These are the various phases. What I would like you to emphasize is we have this landmark paper which got published in 2019, and it has pathogenesis of mucositis, updated perspectives, emerging trends. This is one of the most concise paper that could come up with mass, and it was a special article we could publish. I would request all of you to go into this detail of this diagram of how these chemotherapeutic agents, radiation therapy, and various NF kappa pathways and TLR pathways are going to affect this mucositis. And depending upon how these are affecting, we have targeted specific agents to address this mucositis issue. As all of us, these are some of the pictures of mucositis you could see. Some of them are chemotherapy induced also, some of them are radiation induced also. So when we are talking about mucositis, it can be complicated, it can be uncomplicated. Uncomplicated mucositis, generally we would do symptom management. For the complicated mucositis, there would be a lot of systematic issues, and most of the time we would have to take a break in this situation. So we need to address in prevention and limitation of mucositis from very start so that we don't get into this issue. Coming to the trismus management. This part is
Dr.
mostly...
Abhishek, I think your slides are not visible to us. I think, could you
Okay,
share
so
your slide? Yeah.
Right now it is it
No,
not
it's
visible
not
from...
visible. Right. It's not visible. Could you please?
Okay, okay. Let me just go from here. Okay, and I'll share it up. Share screen. So from which
Yes,
which
yes.
I think after the video I lost the slides.
Yeah, I think
Okay.
xerostomia as the slide number 52 is running.
Yeah, okay. So is it visible now?
That's visible.
My apologies. It might be after the video I
That's all
got
that,
it
yeah,
out of it.
the
So
technical.
I was just talking about trismus, one of the very important part. We all know the various causes out of it. It is very crucial to identify these patients. You will see these patients the very first day. You would know that these patients are with trismus, and we need to make a specific protocol as to how to manage the patients. There are various exercises: chewing, blowing, holding water, wooden stick, jaw opening devices. Then xerostomia patients, everybody would develop some kind of xerostomia. It can be on a lower level, it can be on the higher level. That has to be taken care of. Early care is very important. Radiation caries will happen in these patients. You will lose teeth at the neck of the teeth. All the teeth will go, only the roots would be there. The patient would end up into acute pulpitis, lot of abscesses, infection, and that is very difficult because most of the time it will lead into osteoid necrosis later on. And as most of the surgeons would agree, treating osteoid necrosis is much worse than treating actual cancer. So then salivary aids artificial saliva, pilocarpine, and we do have to have a good fluoride program, and it will be very specific how much ppm of fluoride, what is the frequency should be used. These all are there in the papers which have shared. So if anybody wants, they can go through that. So just showing you some of the cases, I wanted to show you some pictures that radiation caries would be looking like this. They will be the decay at the neck of the tooth, and most of the part of the tooth would be shed off. There will be a lot of problems coming and leading to pain. then trismus causing acute pulpitis. You would see the patient would be have very shiny appearance, skin would be swelled up, and a lot of pain would be there. So this all are preventable measures if we do have a good oral supportive care program. Altered occlusion, when we have hemiectomy, there is altered occlusion. Here we have to use your distal flanges, guiding planes, mandibular prosthesis. Trismus recurrence would be very common in these kind of patients because we are not able to access and see the posterior areas in these patients. Oral entrance opening. So if there are small holes while surgery, it will shrink, and maybe you would see after 7-8 months that small opening are happening in maxilla, maybe in the buccal GP sulcus area. So we need to be doing a very good oral examination, and sometime a mere prosthesis would close this gap and prevent better healing. So if this patient just 2 years post CTRT and most of the teeth are gone, this patient didn't had any supportive oral care protocol. This patient was on a similar basis. On the other hand, this patient coming to us for last 10 years, we were able to maintain his right side of occlusion. He have a hemiectomy on the other side. He's having his food. He is happy about it. And sometimes we have to see what the patient wants, what works best for it. This patient is in a very strict fluoride program and supportive oral care protocol the last 10 years. Osteonecrosis, as I told, is one of the worst complication you could get in head and neck cancer patient. Exposure of bone. You could see in the OPG there are a lot of big lesions would be there. So when we are talking about this, we have to talk about triad of care. We need to do oral care, disinfection, dietary modification, and pain management. Just brush through it. Soft tissue brushing, non-alcoholic rinses, chloride rinses, soda salt rinses, fluid application, zero stomatic management, oral lubrication, fungal infections to be controlled, lip care has to be done. And these are the commonly used benzodiazepine mouthwashes, Olocrins, soda salt rinses, one of the favorites of most of us to clear this debris from the oral cavity. It is very cheap and easily prepared at home. Oral hygiene aids, brush and tools. Lip care, very, very, very important. Candidiasis, you can take antifungal ointment for that. Analgesics, sometimes this lignocaine syrup, just swill it on the mouth and drink it. It will give you a lot of pain relief. Just before the food, it will help a lot. These gels, fluid application, it can be through varnishes or on the trays, and dietary modification. What kind of diet? Soft, bland, protein rich, probiotics, hydration, macro and macro nutrition has to be taken care of, and NG tube feed and care has to be properly explained to these patients. Pain management, we all know new adaptation of analgesic lecture, how to go up and come down in WHO pain, use of NSAID, use of weak opioid, strong opioid, fentanyl patches, morphine, nerve blocks, and pain control analgesia. These are the devices you'll find mostly in hospitals. They have morphine in it. There is a button patient can push and release certain amount. It will reactivate in a certain amount of time only. So these can be even bought and given to the patient at home, and the patient himself controls what kind of in how much anesthesia he needs. So if the dose is permitted, it will get released once the button is pressed. So with this, I close this lecture, and I would just give you these 3 points I would like everybody to understand and take as a take-home message, that we need head and neck supportive care team, which should include dental oncology experts, psychologists, palliative nurses, speech therapists, dietitian, physiotherapists as an integral part of head and neck cancer team. And this is along with the primary care providers. So there is already radiation oncologists, medical oncologists, surgical oncologists. We need to have a well-structured supportive head and neck program, and prevention and rehabilitation will only then can improve quality of life. Thank you so much with these words. If there are any questions, I would love to answer that. So I'm done, Dr. Nurul.
Yes,
If
yeah.
yes,
I'm just, requesting my attendees, they have any question, they can ask question. The house is open for question answer before we are going to our next speaker. Anybody having any question, they can either type in a chat box or they can unmute your microphone and they can ask a direct question. Dr. Abhishek, I think there is no question till now. You will stay with us. Maybe the question arises, then we'll get back to you. If you stay
sure,
another, say, 30 minutes. So there
yeah,
might
sure,
be after the completion of the speech of Dr. The next our speaker, Dr.
sure,
Srinivasan.
sure.
Yeah. So
Yeah,
over
I'll
to
do that.
you. Yeah, we
Yeah,
are very thankful to you, Dr. Abhishek, for joining us, and we keep on inviting you on our future programs as well. Our whole organizing team is, thanking you, and I'm also, thanking on behalf of the whole team. With your permission, should we move on to our next session
yeah,
next
sure,
week?
please. And thank you so much for this opportunity. Thank you
Okay.
so much.
Okay. Over to Dr. Shantala.
Yes, sir. I'm happy to introduce today's speaker, Dr. B. Srinivasan. He is a maxillofacial prosthodontist and dental oncologist. He has done his graduation from Government Dental College Hospital, Mumbai, and Tata Memorial Hospital, Mumbai, University Medical Center, Groningen, Netherlands. Sir is a founder of Enhance Head and Neck Rehabilitation. Sir is a consultant in Sir H.N. Reliance Hospital, Mumbai, Ruby Hall Cancer Center, Pune Hospital, Jahangir Hospital, KM Hospital, and also Sahyadri Hospital, Pune. He is a Vice President, International Society for Maxillofacial Rehabilitation. He is a founder, Association for Maxillofacial Prosthodontics and Rehabilitation in India. He is a ex-executive committee member, Indian Prosthodontic Society. He is a founder member, past president, Indian Prosthodontic Society, Pune branch. He is a past section editor, Journal of Indian Prosthodontic Society. His achievements are he's participated in WHO's Call for Action 2030 in Geneva, February 2017. He has international fellowships from Union for International Cancer Control to pursue advanced training in Netherlands and Sweden. Is the first case is the first person to treat a case for ear processes remotely tweeted by Australian High Commissioner to India, published by Times of India. Is an innovator of biotechnology ignition grant, BIRAC, Government of India Innovation Grant, reviewer, BIRAC, Government of India. Is an author for chapter on prosthetic rehabilitation in the textbook of head and neck surgery titled Restoration, Reconstruction and Rehabilitation in Head and Neck Cancer. He has published case report on customized ocular processes has been published and acknowledged in the book of maxillofacial rehabilitation. Surgical and prosthodontic management of cancer related acquired and congenital defects of head and neck by Dr. Jean Weimer et al. He is a managing trustee for Enhance Social Initiative Trust and he is a speaker for various national and international forums. He has collaboration with Andhra MedTech Zone, Tata Trust for support of cancer care for non-affordable patients, and also in collaboration with Venture Center, Pune. So over to you, sir.
Yeah. Thank you, Dr. Shantala, for a very kind introduction, and also heartfelt thanks to Dr. Nurul Anwar for having me over to share my views with all of you on this wonderful occasion of World Cancer Day. It is just befitting that the day really ends not just with talks on how cancer can be treated, but also on how survivors can be rehabilitated and reintegrated back into society. The previous speaker has really made my job so very easy by highlighting the importance of maxillofacial and head and neck rehabilitation. And that really paves the way for me to touch upon some highlights on how technology can so very well impact maxillofacial prosthetic rehabilitation. So just one moment, please, as yeah. So is my screen visible to all of you?
Yes, it's visible, sir.
Yeah, thank you so much. So here I am today to talk on the impact of technology in maxillofacial prosthetic reconstruction and rehabilitation. And I bring you greetings from all the organizations that I represent. And we hope that the next half an hour or 40 minutes is gives you some food for thought. So what I'm really going to touch upon today is the judicious use of technology. And if I were to tell you today that if you give me a digital scan from anywhere in the world, we can courier you a prosthesis. Will that sound very outrageous? To a lot of people that have interacted with, they say yes, but I would say no, because right here in India, we have developed. It's a made in India protocol, wherein we can use technology and fabricate prosthesis even if the patient is at a remote location, and even if we are not able to really see the patient face to face. But let's get started and set the ball rolling. What kind of patients are we really talking about? We are talking about what I call as a forgotten patient. So we have these unfortunate patients who have undergone different types of lesions, have been unfortunate to end up with defects, which leaves them debilitated for life. And what unfortunately happens is that sometimes the cure can be more dreadful than the disease itself. And we see a lot of these patients deteriorating right in front of our eyes. One of the things that these patients often ask is if anybody really cares for them. What is the only word surviving? A very pertinent question for some of these patients. Friends, on this occasion of World Cancer Day, let's renew our pledge to do something for them and add life to their life. So, as I've already mentioned, that the cure can be very much more significantly dreadful than the disease itself. And and there's a severe loss of self-esteem in a lot of these patients, which is very clearly evident by the fact that the lady in the photograph is not really even willing to look into the camera for the photograph. It's a severe loss of self-esteem. But yes, there are a lot of people who will vouch for, at the same time, will vouch for the benefits of rehabilitation. So you can, this is Nidisha, a very vocal proponent of head and neck cancer rehabilitation.
Rehabilitation of a cancer survivor is as important as the treatment itself, because it's not only the rehabilitation of a survivor, but also the rehabilitation of the entire family. It brings about the same balance that used to be there in the family before this entire cancer journey. For me personally, I would have preferred to die rather than undergoing all these surgeries if I didn't have the confidence that I wouldn't get my face back.
Cancer treatment is complete only after rehabilitation. So no rehabilitation, the treatment is not. So that's what we heard from the patient. And let's hear from the domain expert as well.
Emphasis is slowly shifting from survival to improving the patient's quality of life. Gone are the days when you could cure a patient and leave him or her crippled both functionally and cosmetically.
So we've heard from the patient, we've heard from the domain expert. So I think by now we are reasonably clear that head and neck cancer rehabilitation is definitely the need of the hour and is a huge unmet need. So the human face, which is the representative of a patient's identity, sometimes gets altered because of acid injuries, accidents, cancer surgery, and birth defects, and sometimes even trauma. Although the focus for today is very much related to cancer. And a lot of these patients with these kinds of defects are invisible in the population. They are around you, but you're not really able to recognize them, and you don't necessarily bump into them on a day-to-day basis. And these patients are in their millions globally. A lot of them, end up with severe disabilities, leading to like speech, swallowing, appearance, chewing, and there are a lot of host of issues that these patients go through. And the unfortunate part is that less than 50% have any access to any kind of rehabilitation, and the vast majority of these patients accept their disabilities with a fatalistic attitude. But thankfully, there is a solution in the form of reconstruction and prosthetics, and you can really create a lot of impact in these patients' lives. You can see even extensive defects can very easily be managed in today's time. But the biggest challenges that a lot of professionals face is that these kinds of treatment solutions call for a very high level of skill and experience. Have the biggest problems are low affordability, and because the number of professionals are grossly restricted to the urban centers, especially in India. These kinds of solutions are really beyond the reach of people who are at the bottom of the pyramid, the real non-affording people. So what we really need is a solution which will de-skill the entire process, so that a vast majority of people who are in the audience today and beyond should be able to treat such patients, so that we are able to de-skill. So de-skilling becomes a very important process. The entire process should be made affordable and accessible, and that's the only way that these kinds of treatment solutions can reach the masses. I mean, for any kind of innovation, you need to look around, what you're actually doing on a day-to-day basis. So Wi-Fi printing and video and dissemination of education through video conferencing today has become a norm. It's not rocket science anymore. So remote control is something that we are used to on a day-to-day basis. We are also used to doorstep delivery these days with Amazon, Dunzo, and FedEx. No matter what commodity you want to transport it from one location to another, you already have agencies. And for those who are not really good at cooking, you have ready-to-eat solutions as well. Now, if you're really wanting to combine these kinds of things that are happening around you, you can combine remote controlled doorstep delivery and a ready-to-eat solution. Solution. I think, can someone just put off their mic, please? Yeah. And what we can offer is a ready-to-treat solution. So you can simplify the entire treatment protocol to such an extent that even Dr. Nurul, can you please request someone to put off their mic? I think. Yeah. So what we can do is effect a ready-to-treat solution, and that is where with a strong investment in research and development, you can go through an entire process, the entire workflow of digital scanning to manufacturing, and the result in endpoints which are going to be helpful for patients at even remote locations. So you have data capture, which is possible through facial scanners, through CT scans, or through even mobile phones these days. And what we are trying to look constantly is look at is the use of frugal device solutions. And that's why we are very clearly, despite having a plethora of options in front of us, we are clearly looking at solutions that are frugal, low cost, and high impact. And while we are using the CT scans for getting our data, we are really looking at moving rapidly towards the use of the mobile phone as a scanning device and fabricating a prosthesis out of it. So this is how we are trying to address the entire solution. So let's just take a quick example of how these kinds of ideas can really be implemented, if it has been abstract for you all this while. So this was a lady who was working in the field when, and she lost a major chunk of her face, and you can see that the defect and the aftermath of those defects are very much really obvious. And it was very difficult for her to be able to come down to us and treat her, because she was living in Kashmir, and it was very difficult for me to go there and stay there for such a long time. So the real challenge was to understand how we are going to be able to treat her. Now, while this example is really of a bare more injury, it can very clearly be extrapolated to head and neck cancer as well. So we had this, her initial workup was done in Srinagar. Some of our colleagues are instrumental in doing the implants and her basic workup. And her reconstruction requirements were pretty obvious because of severely compromised aesthetics and compromised articulation, mastication, swallowing, and most importantly, a very, very severe loss of self-esteem. So what we did is we tried to gather all the data, capture the data using a CT scan, and using our existing principle of prosthetic dentistry, try to create end up with an interim prosthesis. And using CAD and a combination of CAD and 3D printing, even the denture base was 3D printed, we ended up creating a rough draft of a maxillary prosthesis. Now, this was to be tried in and tweaked. And because the prosthesis was already kept in place using digital protocols, even without seeing the patient, it did not warrant too much of an investment of time. Now go, and then after that, using the conventional impression protocols, the positions of the implants were captured. A bar was fabricated to splint both the zygomatic implants, and then the prosthesis, which was already kept ready, was then simply connected to the bar. So this was actually done in very quick time because the entire process was pre-planned and pre-planned digitally. Now, the most extensive part was going to be the facial prosthesis, and we took a scan of the patient with the prosthesis in situ, and then went through the entire process of using CAD and 3D printing to develop a facial prosthesis even without seeing the patient. So mind you, we have still not seen the patient at all. And so when the patient finally reached our office, because she at that point in time she did not have someone to be able to tweak the prosthesis for her. It was just a matter of a couple of hours before we could tweak the colors, tweak the fit, and the prosthesis was in place. So you can imagine that an extensive process like this, which could have taken a couple of days, probably even a couple of weeks, was suddenly brought down to just a couple of hours simply by the judicious use of technology. And this was a wonderful journey for the patient and made a huge impact in her life. Now, this would not have been possible without the use of technology. So let's just, through this video, just take a look at what we did through the entire process.
वाइफ के जो चेहरा था, चेहरे की भी रंगत आ गई है और वही पुरानी तरीके से देख रही है और 2-3-4 दिन हो गए लगभग वो खा पा भी रही है अच्छे तरीके से।
So what we really ended up doing is address the the solutions or that we wanted as part of our entire process in trying to de-skill, and we succeeded in de-skilling the entire process and making the entire process affordable and accessible. Now, we were constantly trying to push the boundaries, and in this process, we were able to treat not just in the first situation we had the patient coming to us at least for for a couple of hours, but now we decided to push the envelope, and that's where we decided to treat a patient at a completely remote location for a case of bilateral auricular prosthesis for a patient in Sydney, where it was again not possible for either for us to see each other. We decided to use the similar protocol, and then but this time we used FedEx to just courier the prosthesis to Sydney, and there we had a clinician who was going to be able to fit this entire prosthesis and under supervision from a remote location in Pune. So this was done in conjunction with the Australia India Council, and we also were fortunate to the cause got some visibility there when the Australian High Commissioner to India tweeted the entire the episode and was covered by the Times of India. Now, the benefits of these kinds of maneuvers are obvious, and patients are the best advocates or are the best feedback mechanism for these kinds of procedures, whether they work or they don't.
Sometimes when you're doing ears, you almost need two mirrors. When you're doing it yourself, you'll need two mirrors. So a mirror at the side so you can see the side of the hand in the bathroom.
Yeah, there we were from a remote location. And
whereas with the hearing aid, they have to take ear mold impressions of the canal and fitting and all that. So that takes a little back and forth. In this case, I'm not seeing that having to go back and forth as much.
I think if we could.
So what does this entire process, what has it achieved? It has achieved a situation where the location of the doctor and the patient becomes completely irrelevant or agnostic. It doesn't matter where the doctor is located. It doesn't matter where the patient is located. The patient or the doctor does not have to travel. It is the data that will travel through the internet. And the completed prosthesis can be fabricated in a remote location. And all that a clinician needs today, a fresher or somebody who wants to treat such patients needs to learn is how to fit it and how to make minor tweaks. So the entire learning curve has become significantly shortened. So which means that it's going to be possible for a lot of people in the audience and beyond to be who have never thought of treating such patients to actually be willing to offer their services to these kinds of patients. So that's what the technology has really done in trying to improvise accessibility to patients, and because they don't have to travel to across geographies to access care, it has also made care completely affordable. So what the Pune remote prosthetic technique, as we call it, is has done. It has combined a lot of digital technologies like scanning, CAD design, 3D printing, and we are rapidly moving towards the use of the new age buzzwords of artificial intelligence and augmented reality to ensure that our patients are benefited no matter where they are located in the world. The kind of impact that these kinds of treatment modalities can create is enormous. Patients who have become a social recluse suddenly, especially the teenagers these days, they just burst into Instagram suddenly. Or a patient who attempted suicide because of a deformity on the face, and after prosthesis done remotely where he did not have to travel too much, again, the kind of impact that it has created in his life is there to see. Now, even for complications related to radiation, where a portion of the cheek is missing and such patients are not a candidate for plastic reconstructive surgery anymore, you can help such patients no matter where they are located. Even for maxillary prosthesis, say for example, if dentists are willing to stick their neck out and willing to help such patients, digital technology can definitely come into play and de-skill and simplify the process to such an extent that all you need to do is reline these prostheses, while a vast majority of it can be really fabricated at remote locations. Trismus, which is a very big problem in oncology patients, renders the patients feeding through a Ryle's tube for sometimes the rest of their life, because conventional procedures will not yield a prosthetic reconstruction. In such situations as well, digital technology can eliminate the need for impression techniques and helps such patients. We are rapidly moving towards using newer technologies and devices. And what can be more often than the use of a mobile phone as a scanning device? And this is where we say that if you want to give us a scan from anywhere in the world, we can in fact courier a lifelike prosthesis to you. And we are rapidly moving from the use of a CT scan to a mobile phone. So these kinds of technologies are going to impact. It's going to impact patients because now they have to travel less, and they are going to be more. It's going to save them money in terms of indirect costs of treatment. It's also going to be an advantage for hospitals and clinicians, because you don't have to go through that entire learning curve and don't need the high level of expertise and specialization to be able to treat such patients. So what we are really pushing very rapidly towards is data from home and treatment in your neighborhood, where a mobile phone can be used to scan the entire face, visualization of the treatment done over the, using augmented reality, the process is being completed, and then using a delivery system wherein the prosthesis can reach a clinician in the vicinity of the patient, and then it can be fit. So it becomes a win-win situation for both the clinician as well as the patients. Now, even the use of new age technologies are entering head and neck prosthetic reconstruction, where very recently we've done our first case of using machine learning algorithms, where just by using certain back-end algorithms, we are able to predict the size and shape of the nose based on facial proportions. So which means that you don't even have to learn digital sculpting in the near future. So life is going to become easier and easier for a lot of us, to treat such patients. Now, moving away from facial prosthetics, where the impact is there to see, we move on to another more common situation where digital technology has really made a difference. Now, in the dental world, teeth in a day is a big thing, wherein you can give teeth replace all the teeth using implants, osseointegrated implants at one go. But can you believe that you can also give a jaw and the teeth also on the same day? And this is where you can integrate a lot of technologies to actually give these kinds of outcomes. Now, reconstructing the fibula, the mandible using the fibula can sometimes pose a lot of challenges, because it's not always easy to get the three-dimensional positioning of the fibula correctly. But using technology judiciously, you can achieve not just the fibula in the right position. It can be guided by the occlusion of that particular patient, and an occlusion guided mandibular reconstruction using technology can result with wonderful outcomes. So just again to give you to drive home the point, using a case. Here was a situation where there was gross malalignment of the mandibular segments. It was a situation of a failed fibular reconstruction, and we were attempting to reconstruct it. So we started it using the occlusion of that patient as a guideline, and then planning the position of the fibula and the cuts, or the osteotomies as they are called, in a reverse direction. So it was more of a reverse planning. And this process was to be done. So we planned not just the position of the teeth, the fibula, and also the implants within the fibula, all together with CAD, and the entire execution was to be translated using 3D printing. So here we are going through a process called the jaw and teeth in a day. So this is something in stage one. All we do is place the implants in the leg. And mind you, there are specific indications for this. This is not a one size fits all kind of a solution. There are specific indications which are which is possible for benign situations and also for secondary kind of a reconstruction where the patient has already undergone cancer treatment and then has come back maybe after a few years for reconstruction. So using your templates, you are placing the implants in the leg and capturing the actual positions of the implants. So and we are not removing the fibula from its original anatomic position at all. All we are doing is only placing the implants, and then we are capturing the implants using an impression. And then once this is done, a split thickness skin graft is taken and then and placed and sutured around the implants. The reason being, when this eventually epithelializes in the oral cavity, it will result in keratinized mucosa. And in stage 2, so that we are able to open the leg and the surrounding tissues have not got stuck to each other, you put a membrane. So 6 weeks later, and in the intervening 6 weeks, you wait for the implants to integrate. The series of laboratory steps will ensure that you are able to fabricate the teeth completely, and you tweak your entire process so that the prosthesis is already ready when you are when you go into the OT for the actual reconstruction. So there it is, the guide. You can see the implants on the far right corner. And then you use the saw. The plastic surgeon is using the saw to actually osteotomize the fragments, and you'll realize that the skin graft has already taken up well. You get adherent mucosa around the implants, and then you start inserting the prosthesis over the implants, then and there. And there you see that the prosthesis is already there over the integrated implant. So the entire fibula along with the blood vessels are already in place. You use the 3D models to pre-bend the reconstruction plate, which will guide the actual placement of the fibula in situ. As per plan again, you use the cutting guides to cut the mandible, both the ends of the mandible, in a precise manner as planned using your computer-aided designing. And once this is done, what we really do is we use an occlusal splint to be able to connect the natural dentition also with the prosthesis, so that it can be maintained in the same occlusal relationship as was planned originally. So you have the prosthesis in place, you apply the reconstruction plate, and there you have the entire process is now complete. Now, with this kind of precise planning, it is not very difficult to be able to get these kinds of results, wherein you have a good mucosa surrounding your implants, then you have a functional prosthesis, and you have wonderful outcomes, eventually achieving the kind of outcomes that you're actually desiring when you started the entire planning. So it's a very precise science, and calls for multiple people to come together to put their heads together, but the results can be very, very gratifying. So in a nutshell, my dear friends, we are what we are because of our patients. I consider myself extremely privileged to have got this kind of opportunity to serve this entire pool of patients and create an impact, hopefully create an impact in each of them. So the take-home message today is that digital technology is going to be the future, and innovation is possible even in low resource settings like ours in India, because some of these protocols that I've shown you, especially are related to the facial prosthetics, have been developed in India. So there is no real need anymore to look up, to the West always for innovation. It is very much possible in our own scenario, in our circumstances today. And digital technology is going to ensure remote healthcare delivery so that the reach of such kinds of treatment modalities are going to be global in times to come. Machine learning and artificial intelligence are going to make ensure that the patient can be located anywhere in the world, but still you can treat them. And needless to say, prosthodontists and digital technologists have a significant role in head and neck reconstruction in times to come. Now, to be able to enable all these things, what we are doing today is also embarking on a clinical program, so that, because this has to be a movement. This is not about making a presentation in a conference and forgetting about it the next day. There needs to be an ongoing service. And for those who are really interested, that is the reason why we have embarked on a clinical fellowship along with the International Society for Maxillofacial Rehabilitation. And depending upon interests at every level, be it short courses of 1 or 2 days, online certificate programs, hybrid clinical fellowship programs, and also the other end of the spectrum, those who want support for to translate all this learning into their practice. I think we have the entire spectrum and the spectrum covered. And you have international faculty who have almost 200 years of experience and representing 9 centers of excellence around, spread across all the 4 continents. So there are a gamut of options for different levels of engagement, and all this is going to be possible because of support from collaborators like the International Society, the Hislander Medical Center, the University of Wollongong, and National Cancer Institute in Amsterdam. So a project of this magnitude is possible only when there is support across the across the board. And one other another option for those who don't want to really go for any extensive training is to become a member of the Association for Maxillofacial Prosthodontics and Rehabilitation in India, because that will give you a bird's eye view into or a preview to different kinds of educational opportunities and outreach programs on a routine basis. So on this World Cancer Day, my dear friends, I think let's pledge to ensure that we are going to address a lot of these patients who need our services, and we have technology to support, and you don't need to be intimidated by the complexity of the cases, whether you're able to treat them at all or not. All you need to do is be willing to treat such patients, and we are there to support you either directly or indirectly by the use of technology. So friends, before we sign off, what we really need is change.
What this organization desperately needs is
Friends, after 40 minutes, this was definitely not the change that I was referring to. I'm hoping that the last 40 minutes have really ensured good food for thought for all of you on this on the occasion of World Cancer Day. And I thank Dr. Nurul Anwar and his entire team for giving me this wonderful opportunity to share my views with all of you. My friends, I'm not done yet. Thank you for a very, very patient hearing.
Thanks, Dr. Srinivasan, for sparing your time, though you are busy, and today is the World Cancer Day, and you are invited in many forums where you are putting your thoughts and all. And it's really important that the treatment and cure is not the end actually. It's a starting from there where we have to rehabilitate the patient well, so that we have improved the quality of life of the patients. So really it's not being done actually. It's a starting, and it's the ongoing process. So I'm pretty sure that through our network and this announcement, people are joining your organization as a member, as well as joining the fellowship programs and all. Meanwhile, any audience want to ask any question about rehabilitation of oral cancer patients, they can ask question, because Dr. Srinivasan is expert. One means there are very handful of maxillofacial prosthodontists who are in India, who is working in such a advanced technology and all. So if you want to know anything about rehabilitation, anything about the fellowship program, so you can ask question right away from here, or you can write to us, or you can we can forward it to Dr. Srinivasan. So if anybody have any question right now, they can unmute their microphone and ask question. So, Dr. Srinivasan, there is no any question as of now. You will stay with us for another. This is our last session, and then after that, we have going for the vote of thanks. But still, if somebody want to ask any question on rehabilitation, if you stay with us in 30 minutes coming, we'll come back to you for the answers.
Sure.
We are really thankful to you for sparing your time. Our whole organization committee and National Health Academy and Med School is thankful to you, and we'll definitely try to collaborate with you so that we can serve a patient better way, so that they can improve their quality of life.
Sure. Thank you so much.
Okay.
Thank you so much for having me over.
So over to you, Dr. Shantala. Dr. Srinivasan, should we move ahead to our next session?
Please
Yeah.
do. Please.
Okay.
Thank you so much.
Dr. Shantala, over to you.
Yes, sir. I'm very happy to introduce Dr. Vibhu Ranjan Sahni. He is a oral maxillofacial surgeon and is a consultant head and neck surgical oncology and oncopalliation. He is currently working at Rajiv Gandhi Center, Rajiv Gandhi Cancer Institute and Research Center, Niti Bagh, New Delhi. His achievements are he has surgical experience of more than 1,000 cases of head and neck cancer surgery. He is specialized in head and neck oncopalliation. He is trained in communication skills, including end of life discussion in terminally ill patients. He is expertise in speech and swallowing therapy for patients with head and neck cancer. He's recently completed certificate course in essentials of palliative care from AIMS, New Delhi. He has numerous scholarly publications in addition to book chapters. He has received certificate of appreciation for work in the field of head and neck oncopalliation from Healthy Ho. He is an organizing member of PACES 2023 and DUSA.
Can I share my screen, ma'am?
Yes, sir. Yes, sir.
Ma'am, it's visualized.
No, sir.
It's okay.
No, not visible, sir. You're audible, sir, but not visible. Slides are not visible.
Actually, I have
Just showing us.
now it's fine.
Yes, sir.
Okay. Good evening, all of you. I'm Dr. Vibhu Ranjan Sahni, consultant head neck surgical oncology and doing head neck oncopalliation in Rajiv Gandhi Cancer Hospital, Niti Bagh. So before starting, I would like to say something that every cancer patient has a different story, and each of the story of those cancer patient is actually incomplete without the incorporation of palliative care in the oncological services. So let me explain you how it's incomplete without the incorporation of a palliative care. So what is palliative care? Palliative care from the word means, it shows that it's a specialized medical care for especially for those people who are suffering from a life-limiting illnesses such as head neck cancers. And its focus is on providing the comfort and symptomatic relief not only to the patient but also to the caregivers. So palliative care basically based on four principles which was articulated by Thomas Buchan and James Childress in 2009. First is autonomy. You need to understand what patient actually want, and you need to give a patient-centric approach to the patient and to the family so that the compliance to your treatment is actually enhanced and towards the treatment. If you are providing the autonomy to the patient and his family for the treatment, for the treatment plan, then only they can have the good outcome and good quality of life later on also. Whenever you show the autonomy to the patient, then only you can provide the sufficient treatment goals and good quality of life, as well as the good end of life care also in some of the cases in which unfortunately has a disease progression in there. Second one is beneficence. Provide good only good things to the patient. You need to weigh between the side effects and the actual effects of the treatment, and then only you can proceed with their care. If you are doing so, and then you have to provide them non-maleficence. Basically, do not harm the patient unnecessarily. Do not give any over treatment to the patient. If you are following this autonomy, beneficence, and non-maleficence, then only you can justify the responsibility of a clinician to participate in designing and maintaining the healthcare system that is actually fair for the patient and their family also. Mostly patient came to us initially and we offer with a disease diagnosis. Many of time we need to address what they want, what they don't want, and what is the actual treatment plan. Then only you can give the benefit to the patient. So palliative care, now the question arises ki when the palliative care should be started. So
Slides are not visible.
Hello?
Excuse me, sir. Sir, slides are not visible, sir.
Okay.
Slides are not visible, sir.
We start again.
Yes, sir.
Yes.
Yes, sir. Yes, sir. Let's see. It's visible. Sir.
Sir, please unmute yourself.
Sure. Sorry. As you can see in this graph, as soon as the diagnosis is done, the role of palliative care specialist starts. Initially, the palliative care role, specialist role is only 5 to 10% to basically communicate with the patient about the treatment plan and address their psychological burden. Apart from the physical burden, the treating oncologist is covering, but you need to address their psychological, social, and spiritual burden at this point of time. But as the disease is progressing, unfortunately, all cancer patients will not get the desired outcomes. So as the disease is progressing, the role of the palliative care specialist going to be increased, like it's shown in this case, in this graph. When the disease progress, the symptoms arrive. And it's a duty of the palliative care specialist, along with the treating oncologist, to provide a adequate symptom control and provide a supportive care to the patient. Again, unfortunately, the disease again progressed, and at times the disease modifying therapies which was given earlier is not going to help the patient, and the patient is land up in this hospice phase. Hospice phase is basically last 3 to 6 months of the life, where the patient goal is, where the palliative care specialist goal is to provide only comfort to the patient. You must forego this life prolonging measures, and the whole intent is to provide comfort to the patient and to the provide prepare the patient for end of life thing. End of life care basically is provided in the last 24 to 72 hours. This hospice phase is very important, as you can prepare the patient for the end of life care. You should explain with the honest and rationalized approach, rationalized communication with the patient, how the anticipated events will occur. आगे 15 दिन में आगे क्या होगा, symptoms क्या क्या आ सकते हैं, तो to prepare them so that they can be prepared for every damn thing, and the emergencies that will happen in these case scenarios, and the family is actually prepared for these kind of emergencies, and these emergency will convert into the semi emergencies. And also the end of life phase is there, so they have multiple questions. You need to address all these questions. You can see these interrupted lines over here. This is the amount of communication is required by the palliative care specialist to the patient and the caregiver, so that a palliative care specialist provide a good, build a good rapport building with them and prepare them for this end of life care phase. In this end of life care phase or hospice phase, basically psychological, spiritual, and social burden can be addressed at adequate point of time. The palliative care specialist role is never end at this point of time. It is way beyond. The patient died, but suppose a patient died of carotid blowout. So the post-traumatic stress disorder, the patient family or caregiver having seen that surplus amount of blood and spurt of bleeding, and the patient gasping for death, then the patient will land up into a post-traumatic stress disorder sometimes. But if you prepare the patient and the family in this phase, then this, as you see, this bereavement care period which palliative care specialists provide to the caregivers is narrowing down, and all their psychological burden is completely addressed by the palliative care specialist. So as I already said, palliative care, it can be given with the life prolonging measures or curative therapy, but the hospice care is, which is the last 3 to 6 months of life, you must forego the majority of life prolonging treatment, and both of them basically manage on the basically work on the symptom management or providing comfort to the patient and establishing some goals of care with the patient, and make them aware about the anticipatory events which can be happen, and after that also help in the advanced care planning. Advanced care planning, basically Supreme Court of India into 2023 give this concept of advanced care planning, in which a patient and their family decide what to be done at that point of time when a patient will not be curative, not be in the curative mode, and he's suffering. So whether he want to get into the ICU, land up into the ventilatory supports, or whether he or she want a tracheostomy support or not, then with the help of a palliative care specialist, the patient and the caregiver can plan this advanced care planning for the benefit of them. So basically, what is the role of a palliative care specialist? As I already said, when the disease is progressing, then will be an increase in the physical burden. So to overcome the physical burden, the palliative care specialist will help to control the symptoms. I'm talking control of the symptoms, not talking about the cure of the symptom. As the disease is there, you can only control the symptoms, not cure the symptoms. The first and foremost symptom is pain. As I already said, the pain is basically somatic and nociceptive type and neuropathic type. Neuropathic can be somatic also and visceral also, and neuropathic can because of the nerve endings. As in the head neck patients, mostly the pain is somatic and the neuropathic pain. So in 1986, WHO gives a analgesic step ladder approach for treating the uncontrolled cancer pains. Initially, when the symptom is less, these are the step 1, step 2, and step 3 ladders, which was given by the WHO in 1986. There is a improvisation given by the step 4, which is an interventional treatment for providing this bidirectional approach. Then step 1, and this step 4 can be used with step 1, step 2, and step 3, so that the step 3 person can shift to step 2, or step 2 person can shift to step 1, likewise. So for the initial phase, when there is a pain, mild category of pain, then step 1 is there. You can give NSAIDs or PCM in this category. When there is a increase in the symptoms, then sometimes we have to give the weak opioids like in the form of tramadol. But when there is a severity increases and the disease progressed and beyond the curative intent, and patient is in the palliative phase, then the strong opioids in the form of morphine or fentanyl patch or methadone can be given. Most of the time, along with these, adjuvant medications is also given. Adjuvant medication may be for the neuropathic pain. There are multiple receptors which we have to address at the same time. Sometimes we have to give address the NMDA blockers is there. We have to give the ketamine drips also. We have to give gabapentin also to provide the adequate neuropathic pain, and central desensitization is there. If there is central sensitization, then we give this drips also. Sometimes in the initial phase, we have to also give the interventional treatments in the form of the blocks. But solely the pain is controlled with these strong opioids, especially in the end of life care phase or in the hospice phase. In 1960s and 1970s, Dame Cicely Saunders, a nurse practitioner, give this concept of palliative care, also give the concept of this total pain. As you all know, the pain is shown physically. The physical pain, actually we see the pain in the patient is actually the physical pain, but down inside there is social pain also, psychological pain also, and spiritual pain also. Physical pain can be because of the treatment per se, can be because of the cancer, compression of the nerves or something. But have you ever addressed this kind of social pain? The patient suddenly has a deformity, has a fungating mass, is not able to go outside, he lost his job, he has financial concerns, and he was worried about the future of the family, being a sole earner of the family, and suddenly he was dependent on anybody else. He was doing all his duties, day-to-day work, but suddenly he was dependent on his family, his children, his wife, or vice versa. If this social pain is aggravating, then there will be a psychological burden also, or psychological pain is also there. Patient will become anxious. There is a fear of suffering when the disease is progress. Always my patient asks me, sir, last में pain तो नहीं होगा, ऐसा ना हो कि मेरे को तड़प तड़प के मरूं. Because of the past experience of illness of their loved one, they see that severity of pain which their loved one face, and they actually scared of that kind of pain. They don't want to be on the ventilator at that last point of time. They want with their families. So ultimately, this depression part is inculcated in their things. They were severely depressed at times. You need to address all these things. And suddenly, out of nowhere, a spiritually humble guy suddenly had a anger with the fate, and he was asking, why me? Why this disease is happening with me? And he was suddenly had a loss of faith. He became a he suddenly feel that there is an existential crisis. He thought कि why I have born? मैं पैदा क्यों हुआ? Then there is a fear of unknown also. उसको समझ नहीं आ रहा कि मेरे को क्या डर लग रहा है. So in all these things need to be addressed with this physical pain. If you are giving only the medication for these physical pain, then these issues will be unaddressed and the patient will not be able to control their pain. You need to give more and more doses, but he will not be get relieved, adequate relieved. So we need to give the adequate control of their pain by addressing all these things. Another important aspect is palliation of the airway. Airway obstruction is very distressing symptoms in the progressive disease. Obstruction can occur anywhere along the airway, but the symptoms and treatment depend on the level of the obstruction. Sometimes there is a sonorous breathing without the stridor, then you can suspect a tumor in the base of tongue or something in the oral cavity. So just to palliate that, you need to just prop up the patient and give a nasal tube can be given, nasal airway can be given for controlling that thing. But in case of a obstruction, if there is a biphasic stridor, patient came with a biphasic stridor, then there is a laryngeal obstruction. Depending on the severity, if there is a complete obstruction in the larynx, you need to do a tracheostomy. And also there is a timely laryngoscopy for evaluation of the airway is must. But for patient with known incurable disease, especially in the end of life care phase, you need to discuss honestly with the patient and the caregivers whether they want tracheostomy initially or at that point of time. Because if the patient came to you at the end of life phase, then there is no point of giving him or her a tracheostomy. So better to palliate the airway, you need to communicate with them that you need to, the patient and the caregiver need to decide that they actually need tracheostomy as early as possible so that this airway emergency will not happen to them. Another symptoms is dysphagia and assessment of risk aspiration. It can be caused by the mechanical obstruction, functional obstruction, drug-induced side effects. There will be a pain because of the pain, fistula, he's not able to swallow. So evaluation is must. You can examine with physically or do a phys and fluoroscopy. One thing I want to say, you need to do a phys examination or fluoroscopy for any cancer patient when the patient is diagnosed with the disease, so that you can properly guide your SLP, can guide the swelling maneuver before the surgery, and he can adapt these changes later on easily, and we can remove the NGT and PEG tube. I would like to also set the NGT is when you are planning for a removal of NGT in normal patient, in curative patient, then do not give NGT stay for more than 21 days because if NGT or Riles tube will stay for more than 21 days, then there will be a disuse atrophy. Then there will be a chance of aspiration, which is continuously haunted you. And suddenly a patient came to you in the emergency with a severe pneumonitis. In some cases, In hypopharyngeal cases, you can also do a serial dilatation in patient in which there is a narrowing of the passage. There are other symptoms also which can be palliated. These are xerostomia induced by the radiation, drug induced xerostomia, iatrogenically induced xerostomia. If there is a bleeding and you need to address them with a ligation of the ECA, or you can incorporate the interventional radiologist for embolization of the bleeders. Wound care and pressure care is must. If you communicate to the patient about the wound care and these pressure care, then you can prevent the foul smelling things in the patient and also the infestation of maggots, especially in the fungating wounds. Nausea, vomiting, and constipation are some of the symptoms of the post chemotherapy. You also need to palliate that thing. In the end of life case, there will be a confusion and agitation. You need to address that with a combination of communication with the patient and the caregiver, and also with the, if you are communicating enough to the caregivers that these confusion and agitation will arise in the end of life phase, then they will actually understand that this kind of confusion and agitation must be addressed with the help of chemical restraining in the form of morphine or some kind of a palliative sedation. So second part of a palliative care specialist, role of a palliative care specialist is basically a decision making. Communication is actually a key. When you do a honest communication and your communication is rational with the patient-centric approach, and also you discuss the risk and benefit with the patient and the caregiver, then only you can explain each and everything to the patient. And then the patient compliance is also rises. They opt for the treatment you are giving to them for their benefit, and also the rapport building will generate. So they will effectively take a decision on, this is what is called as a shared decision making between the family members and between the doctor, is done adequately in the benefit of the patient. As I already said, you have to relieve the psychological burden. So palliative care specialist helps the cancer patient and his family to relieve their psychological burden. As I already said, patient is in distress thing. They will fear of this distress. They need control especially in the end of life. They have a fear of suffocation. They have a fear of bleeding. So you need to address all these things with the symptom control and also with the psychological counseling or communication with them. If you already explained them the anticipatory events, they will actually understand. The anticipatory events is not like you have to tell them each and every visits. This things can happen to you. Do not panic. And you can do this thing with, अगर ये होता है तो ये करिए, नहीं तो ये करिए, और अगर कुछ नहीं समझ आता then come to emergencies. And also you need to address the social desires of the patient and the family also. One of my patient want to go to the Ioccon temple. He was admitted to us. So we optimized that patient and told him directly go from this hospital to the Ioccon temple, then came back. And then we actually arranged that thing for him. If we communicate adequately, then only we can plan an end of life care adequately. So for that, as I said, the regular review and timely assessment is must. You need to confidently control the symptoms. If you control the symptoms, then only your rapport will build with the patient. And when there is a rapport building is done with symptom controls and with your sensitive and honest communication, then only you can actually help them to take a sensible and proactive decision making. And everybody, I must say, everyone should know how to break the bad news, especially in the end of life phase. It's a duty of not only the palliative care specialist, but also every doctor to explain the patient that this is going to happen with your patient with the sensitive and honest communication. And they need to learn this breaking bad news. So when you explain all the anticipatory events to the patients or the caregivers, then at time comes when the death is near to the patient or end of life is near to the patient, then they automatically recognize that thing, or we can plan the end of life care with the patient and the caregiver with the help of this communication. Then the patient will decide beforehand that he want end of life in the hospital or at home. It's a duty of a palliative care specialist, or I must say any doctor, to make sure that his family is by the side, not whether he or she should be at home or in the hospital. And all his religious, spiritual, and cultural preferences should be addressed beforehand. I think all of you don't want to be like this at the end of life of your phase, at the end of life care phase. You need anybody don't want them to be into the ICUs or wired with so many things, but everybody want like this, a good death like this, with the patient, family, friends all around them, their loved ones around them. So this is a case discussion. 44-year-old male is a known case of carcinoma buccal mucosa, diagnosed in 2021, underwent surgery followed by concurrent chemotherapy, but has a recurrence in 2027. He received multiple lines of chemotherapy, immunotherapy, but there is a progression of disease. He came to us in the hospice phase 1 month before his death. These are the physical symptoms. He has pain, dyspnea, disfigurement is there. He has so much pain that he's not able to sleep, not able to lie straight. So we titrate him with a fentanyl infusion, fentanyl patch, and somehow we can give him the relief. But when we communicate with him after giving the some kind of control in his pain, then we understand he's a very social person. Because of the facial deformities, he is not able to attend marriages and social gathering. He was a completely independent guy. So dependency is a issue for him. He's not able to go home, go outside home for socializing. He is a businessman. He's not able to attend his work properly, and there are psychological issues are there. There is a fear of death. He has a severe dyspnea, so he has fear of death also, fear of choking also, fear of suffocation also. He's concerned about his wife and children. And there is a question. He asked me, sir, मेरे साथ ही ऐसा क्यों हुआ? मैंने तो आज तक किसी को कुछ कहा नहीं. So we address all these things, and before dying, he actually transferred all his things. He taught his wife and his children how to tackle the business after him. This is a photograph. We celebrate his 20th anniversary in the. This is for his death, and he's a very to heart patient, to our heart, basically. So we all plan that we live always well, but we never planned how we can going to live. So if you planned your current day scenarios well-being, then you need to be planned your end of life also. It's for all. The life should be, जैसे आपने अच्छे से जी है वैसे ही आप अच्छे से जाएं. Live well or live well. So transitioning is very important. Timely transition into palliative care, especially speciality. If any of the cancer patient is there, you need to timely transfer them to the palliative care specialist or be in touch with them so that you can plan all these things and provide a good quality of life and good quality of end of life to the patient. So this is basically a time for change. Timely incorporation of palliative care is must. Please do not send the patient to the palliative care specialist in the end of life care phase. Better to send them in the hospice phase or earlier so that the palliative care specialist can explain all the things in advance. He needs multiple communication session with them, with the patient and the family, to actually prepare for a good end of life. Thank you.
Thanks, Dr. Vibhu, for your exhaustive your talk, and you have just shown light that not live well, but plan to live well, and you have highlighted the issues when people are at their end of their life and all. So this is the reality, and the cancer patients faces such things in their life. Anybody from audience, they can ask any question. Before they are asking any question, I'm just let them know that there are very few dental surgeons in India. I don't know, apart from Dr. Vibhu, who is having the background of dentistry. But most of the people who are working in palliative care are anesthetists actually. So they are having experience in anesthesia. But it's very motivating that one of dental surgeon who is pursuing his career and helping patients to live well, and he is from the dentist fraternity. So it's great to see you, and I amazed to see you when I took your connect with Dr. Sunny, because last time Dr. Sunny has presented the same topic. So this is the motivating for our all other dental surgeons who want to pursue their career in oral or dental oncology. Last day also Dr. Shakti Singh Deora, he is oncologist, oncosurgeon, and he is working, and he has given the way ahead for dental surgeons, that how they are important and why they should be in the team of the cancer care patients from starting diagnosing till the palliative care and all. So here the dentist is all means from stage 1 to end of the day, they are serving, and they are excelling in their what I would say services and all. So anybody who want to ask question from Dr. Vibhu Ranjan Sani?
Actually, I want to add something.
Yeah.
Palliative care can be done by anyone who's a degree with the BDS, MDS, MBBS, BMS, because for this palliative care you need to we all some point of time is trained in giving the morphine or opioids. So for palliative care specialist, you need to have formal training of opioid providing. Basically, you need to know, look for the norms also. You need to learn that also. So a formal training for 1 month is fair enough, and you can join. You can dispense the morphine and fentanyl, which is a mainstay for the, especially in the end of life care patient. And we are also planning to start a palliative care teaching program. We'll like to share with you.
Great, great. So anybody who has any question for palliative care or rehabilitation, Dr. Srinivasan is also available now. He is with us now, and Dr. Vibhu is there. So if you have any question, you can write to us, support@ioccon.org. We'll forward it to the respective specialist, and you will get your queries answered. With your permission, we are just close to our 4-day marathon, the conference. I think we have spent 1,000 minutes for the starting from Thursday. We started by 3 p.m. and now it's about 5 p.m. So it's a long, and we have some, say, 40 speakers who share their work, their thoughts, and with the permission of Dr. Vibhu, should we move to our organizing secretary, Dr. Ruwan, who would be going to give vote of thanks. And this would be the end of our IOCCON 2024 for the third edition. Should we go ahead, Dr. Vibhu? Yes.
Definitely, sir. Thank you
Yeah.
very much, sir.
Okay,
I
so
would like to congratulate for your this marathon webinar sessions.
Yes, sir. There are many, oral and maxillofacial pathologists, prosthodontists, oral surgeons, oncosurgeons, radiation oncologists, the chemotherapists. People are joining across world actually, and we are touched all social angle as well. We have the person who are working in social medicine related to oral cancer. We have talked about tobacco cessation and all. We have talked about the economic burden of the oral cancer. There are multiple specialists from different walk of life, different domains. They have shared their, thoughts, their knowledge, and it's a very, fruitful that we collaborated virtually, and it's a very, good program so far. And we expect that we would be going further better in 2025 when we join again.
Sure, sir.
Yes,
Thank
over
you
to
very
Dr.
much.
Ruwan. Over to Dr. Ruwan.
Dr. Nurul, thank you. Can you hear me?
Yeah, you are audible.
Yeah, thank you, Dr. Nurul, for giving me the opportunity and it is my honor and privilege to propose the vote of thanks at the end of this Marathon International Oral Cancer Congress. First of all, I would like to thank Dr. Nurul Anwar, the organizing chairman, who has done a wonderful job in organizing the event for the third consecutive time. Without his efforts and his organizing skill, I'm sure the entire session would not have been a success. And Dr. Nurul was supported by a team of members from the organizing committee, which included Dr. Mirnani, Dr. Manoj Singh, Dr. Prasangi Piris. They were the main people in the organizing committee. And then we had the privilege of having a group of advisors. This group of advisors guided us in organizing the event to a grand success. The advisors include Dr. Puneet Ahuja, Dr. Nadeem Jeddi from the Indian Association of Oral and Maxillofacial Pathologists, Dr. Manjula Artigala from the University of Peradeniya, and co-organizers representative Mr. Ishrafil Khan, Chief Technological Officer, Mediskill, is also help us in the technical aspects. Dr. T.P. Chaturvedi and Dr. Geeta Rajput from the Ioccon 2024 serves the advisory committee as well. Now we are thankful to all our speakers, and without the speakers, any conference will not be a grand event. Their valuable contributions are highly appreciated. And these speakers join us from all over the world, which includes Padma Shri Dr. J.K. Singh, Dr. G.N. Karisbappa, Dr. Rashesh Gupta, Dr. Vishal Dang, Professor Dilip De Silva, Professor Nadine Jayasurya, Dr. R. Ramya, Dr. Samdara Sirivardhana, Professor W.M. Tilakaratna, Dr. Shakil Singh Dora, Dr. Abhishek Singh, Dr. Preeti Jain, Dr. Padma Shri, Dr. Shadab Mohammed, Dr. Manesh Tiwari, Dr. Azim Mishra, Padma Shri, Dr. Ravi Khannan, Dr. Mohan Menon, Dr. Infusion Zomre, Dr. Abhishek Kandawal, Dr. B. Srinivasan, Dr. Sanket Katreddy, Dr. Vibhu Ranjan Sani, Dr. Kehendi Kadmodi, and these are some of the speakers who has helped us in making this event a success. We would like to thank our moderators, Dr. Ankata Prasad, Dr. Shantala Arun Kumar, Dr. Shahid Quadri, and especially we would like to thank our IT team. Conducting online conference is extremely a difficult task without having the good support from the IT team. Their valuable contribution from the day one is highly appreciated. Registration team is done a wonderful job in registering the people and providing the necessary service to the registration, the registrants. But last not least, I would like to thank all the delegates who attended the conference all over the world. And without you, your participation, this conference would not have been a success. I'm sure we will be able to organize another conference, a better conference, learning from the lessons from this conference in 2025. Thank you very much.
Thanks, Dr. Ruwan, for sharing your vote of thanks. I think you have already concluded. I'm just, a small announcement to all registrants that they would be getting their participation certificates on our website, ioccon.org, by tomorrow, 12 o'clock. So my team is uploading it, and they would be giving one opportunity to correct your name, because there are some registrants who have filled a wrong name, or there might be change in a spelling. So you would be getting only one opportunity to change your name, and after that you will get your certificates downloaded from the portal only. The portal is www.ioccon.org. With the permission of Dr. Ruwan, I am signing off for this IOCCON 2024. Have a nice day, and this is World Cancer Day. So I request all delegates who join that this is not the end, this is the beginning, and we should make our contribution to decrease the burden of oral cancer across the world and give better services to the patients afflicted with the cancer and oral cancer especially. Over to you, Dr. Ruwan, to say something, and then I'll just sign off.
Thank you, Dr. Nurul. And as you said, this is the beginning of new work and new friendship. And this time we met different people, and this was a joint organization. This gives us a strength, and I'm sure we can do something better for the poor people who are suffering from the oral cancer and oral potentially malignant disorders in the future. Thank you.
Okay. We are signing off for the day. Thank you. Thank you, everybody.